We will start with session of Dr. Sanjay Dudat, sir.
It's my great pleasure and honor to introduce Dr. Sanjay Dudat, sir. He is a senior surgical oncologist at Nanavati Max Super Specialty Hospital, Mumbai. The Vice President, IIM Maharashtra State in 21 to 22. Trustee of IIM Mumbai West. His working experience in surgical oncology since 30 years. He came from Tata Hospitals, performed all radical, major and supra-major surgical surgeries successfully. More than 5,000 surgeries he has performed till date. He has many publications in his name. Cancer and anti-tobacco awareness is his passion. He has received many prestigious awards. He has association with ISO Oncology Associations. He has special child master Atharva and also working for such special children. He had a nice workshop just one day before yesterday at Sirampur and Shirdi. I welcome him on the stage. Sir, please come on the dais.
Can I start? Good morning, everybody. First thing, I would like to congratulate Dr. Kuteswar and the whole MASTACON organizing committee for giving us such a fantastic hospitality right from the day one. And to organize such a big conference in a small place, doing a superb job. Heartiest congratulations to Dr. Kude and his whole team. I'm from this place only. I'm from Ahmednagar, so I'm no way away from this Shirdi, Shirampur or anything. I did my all education till 12th in Nagar. Then I went to BJ, then I went to Tata. So that is how the transition began. But you cannot forget your native place and all our own. Now we are going towards different topic. It's very leading topic in oncology. Is organ preservation of an organ and its function. Now, if you look at 50 to 60 years back in oncology, the concept was, a cancer concept was basically only a radical cancer. Like because cancer spread loco-regionally, so there was a radical surgery concept. Radical surgery, ultra radical surgery. You must have heard about ultra radical Halsted mastectomy also. So these surgeries they used to perform successfully, but morbidity and complications were very high, really high. So the years together it was going on like that. Then finally the researcher understood that cancer is no way locally or local-regional disease, it is a systemic disease also. And the concept started coming, is there a need for any such a radical surgery to get patient into a lot of morbidity and problems? And that is why the concept of this organ preservation came into action. Now, there are three determinants of cancer cure. If you look at the type of cancer, the stage of diagnosis, and adequacy of the treatment. Now, curing cancer is not accepted in casually recent times. What we want in the treatment, of course, cure is the first choice, no doubt about it. What we want along with the cure is quality of life. Now, if you don't have this quality of life, then the cancer, your treatment has got no value. And now this concept of organ preservation has become a forefront of the modern cancer care for the past 2 decades. And organ preservation, please keep a silence, please. Everybody silence, mobile on silent, please. Listen to 20 minutes. Organ preservation approaches must have likelihood eradicating tumors, have a low risk of recurrence, and not compromise. Oncologically compromised, we are not supposed to. Otherwise, people get disturbed. Please go ahead. Now, the concept of organ preservation is basically it's a paradigm shift towards the more conservative. More conservative surgery, more and more success rate, and more quality of life. Challenges for curing cancer that it remains with that, and that is why you need to select the problem. Organ preservation becomes an integral part, as I said, and if this happens because it becomes successful because of imaging, surgery, chemo, and radiation. All the advances happening in these four fronts. And always remember, it is a multidisciplinary management. Dr. Scott cannot handle one thing. It has to be multiple people who are involved in managing services. Now, this is how the success of organ preservation depends upon the balance between disease control and the function of the whole thing. So, you have to have local control, accurate assessment of the disease. On the other equilibrium, you should have functional outcome proper, and that is why leading to better and better quality of life. So, who is the important factor in this? The surgeon, the most important. Should have thorough knowledge of understanding of the anatomy, accurate assessment clinically and radiologically, and should have training to perform all the procedures properly and successfully. So, where it can be done? Now, it can be done in breast cancer, head and neck cancer, lung, kidney, bladder, ovary, rectum, anal cancer, soft tissues. We'll see few examples because we don't have much time today. In 20 minutes, I will take to cover important. As we know that, we know the mastectomy, everybody knows it, gold standard, but it got converted into breast conservation. Now, what is the rate of breast conservation? Our series is 65 to 70%. Majority patients we do breast conservation as far as possible. Now, this concept initially was proposed in 1930, but it got disregarded because the concept of cancer was radical. So then they did a trial, phase 3 and phase 2, phase 3 trials in US and Europe, and they consistently demonstrated if you do a radical surgery, mastectomy versus breast conservation with a selected good number of patients, the survival and the recurrence rates are almost equal. This is how the trial of NSAPP06, which is a famous trial, you can see the mastectomy as well as the locoregional rate is almost equal, but maintaining the balance between mastectomy and DCT, functional as well as locoregional outcome. This is how the breast conservation is normally being performed. Wide excision of this area and do a small axilla. Previously, we used to do all axillary clearance, but nowadays with the sentinel node biopsy, axillary node sampling, we just do specific axillary, this thing, do frozen. If negative, we just preserve the axilla. If positive, we do the complete axilla. So that is what are the eligibility criteria? Capability to deliver the radiation therapy. That is must. Second thing, acceptable cost message and margin should be available. Okay, histology. Exclusion criteria is multicentric disease, multicentricity. But multifocal you can do. Multifocal means lesions in one quadrant. You can excise that quadrant. You can still do breast conservation. Multicentric is contraindicated. Extensive microcalcification on the mammogram. Then positive margins. So like this, there are certain exclusion criteria. That is why you have to select that patient very properly. Now we are getting a lot of younger patients nowadays in breast cancer. So they are getting multicentricity. So we do mastectomy with the reconstruction at the same time. So this is a standard procedure, taking an incision and removing the lump as well as the axilla. Depends upon whatever is the axillary glands positivity or not. These are the few examples of breast conservations. Again, you can see the good star after 3 months. These are the patients after 6 months, upper inner quadrant, lower inner quadrant, with a good breast conservation, doing very well for 10 years. This is not a malignancy, but it's a very good case from Aurangabad I got. It's a large mass breast you can see on the left side. Very big. But on mammography, the whole thing was a mass. It turned out to be fibroadenomyolipoma. So we excised the whole thing, and there was a lot of discrepancies. So we put a LD flap and did a reconstruction. So this is what is called as how you preserve the breast whether it's a benign also. This is a phyloid tumor. Locally advanced breast cancer also, if it is really locally advanced, only lump, large size, and patient wants breast conservation, younger patient can give neoadjuvant chemotherapy, reduce the size of the mass like this here, and you can do breast conservation. So these are the few examples of this. This is post-volume replacement. Whenever there is a large this thing after neoadjuvant chemotherapy, this has been flap has been put. This is a pregnancy and breast conservation. This lady came to me in long back 15 years with a mass in the breast, 2 centimeter, lumpectomized outside. Came to me, she was 7th month pregnancy. So I took a decision of completion of surgery first. And then I said, I told gynecologist to deliver little early. So God's grace, she delivered little early with a good baby boy. Boy is in 10th standard, doing very well. So these are the important cases where you can do after delivery. I have given chemotherapy, radiation therapy, everything to this thing. Now coming to axillary clearance, again there is a preservation of axilla. Whenever you want to do axillary clearance, we used to do every axilla completely. But nowadays the concept changed. If you are clinically and radiologically nodes are not there, you can still try a good sentinel node biopsy. Now what is sentinel node? Which it drains. This is a sentinel node which it drains first. Here, it's a there's a pointer. In which the lymphatic channels drain first, that is a sentinel node. Now, this sentinel node you have to identify either by methylene blue or isosulfan blue as a nuclear medicine radiology. So we normally use methylene blue, or you can have a nuclear medicine dye also at the same time, and you can do the needful. And this is how the blue node, and along with that you can take 2-3 nodes out and send it for pathology.
Recording होता है पण मग ठीक आहे.
Connect to the data. They don't allow them to find connect to the data to determine the relative position of the nearby device.
But we use gamma probe and methylene blue all together, so increased accuracy is much better, and that is how we can do the axillary preservation. And these are some indications where you can use sentinel node biopsy. Some are contraindicated. So this is a table which can depict the things. Coming to head and neck cancer, that depends upon tumor size, tumor site, location, proximity to the mandible or maxilla. So if you look at the mandible, we used to remove hemimandible along with the commander. But nowadays, if there is a genius sulcus lesion which is sitting on the mandible, but the CT scan wise radiologically mandible is not involved, you can do good marginal mandibulectomy like this, and preserve the mandible. Who wants to have a bad face? Nobody wants. Everybody wants good mastication. So preservation of the mandible becomes an integral part, no doubt about it. Coming to the tongue, with a small lesion on the lateral border, we used to do hemiglossic in 90s. Changed to only wide excision, and depends upon neck. What is your USG and scan findings? And later on, if you want to, you can give that. And if there is a more tongue part goes, you can have radial forearm free flap also, which can be put there to get a tongue shape also. Of course, you will not get a other sensation, but shape of the tongue will be very good. Laryngeal preservation. I think the utmost thing in head and neck cancer is laryngeal preservation. Laryngectomy nobody likes. Anybody likes colostomy? No. Same way, nobody likes the permanent tracheostomy. So the combined chemo radiation concept came in picture. On last 3 decades it was going on. And first choice is always chemo radiation. And then laryngectomy comes as a salvage surgery. So I will not go into the details of the whole thing. Otherwise, you can give DCF as a standardized chemotherapy for 3 cycles and then give concurrent radiation chemo. Of course, these cycles are a little tough to tolerate for the patient, but yes, you can get a good laryngeal preservation with chemo radiation. And if it recurs afterwards, then you can have salvage total laryngectomy. Thyroid cancer. Thyroid cancer, you know, it is 94-95% is a well-differentiated thyroid cancers. 5% medullary carcinoma and 1% is anaplastic. Now, problem comes when to do hemithyroid and when to do total thyroid. Now, previously, even if 1 centimeter nodule in the thyroid, total thyroid. But that concept got eradicated after 90s. I think good work by Dr. Jatin Shah from Suman Veterinary Memorial, and he has given a good criteria as AGs, MEs, and other criteria too, where we can save the lobe of the thyroid. If it is a less than 3 centimeter, confined to the thyroid, no thyroid extension. So these are the criteria where, sorry, age is criteria. Age, lesser the age, less is the risk. Grade, low grade, extra thyroid extension, and size of the tumor. I think 3 centimeter or 4 centimeter considered as a cutoff for the total thyroidectomy. And what are the indications for total thyroidectomy? Diffuse bilobar tumor, massive bilateral nodal metastasis, major extrathyroidal extension, and distant metastasis. If there is a pulmonary effect, yes, we have to undergo total thyroidectomy and do a radiography extension. So that is how the concept become for hemithyroidectomy versus total thyroidectomy. And total thyroidectomy has got its own complications of trigger and other injuries. You can have parathyroid, permanent injuries also, despite of your meticulous dissection. You can preserve, but you can get blood supply gets hampered after your surgical dissection. So it's a very millimeter blood supply. So in lung cancer, the only procedure, of course, you know the lobectomy, you know the bilobectomy, and you know the lunarrectomy also. So what is important is sleeve resection, how you perform. So whenever you have a tumor here at the upper lobe or bronchus here, then ideally you can cut here and do a pneumonectomy. But what has been done? Of course, it has been done by very skilled thoracic surgeons. Very few people do it. Cut here, take out the upper lobe, and join this carina branch to here. And that is how the bronchial sleeve, which you can save the lower lobes and taking out the upper lobe. That is how it is a very highly skilled operation. And perform, you can, nowadays, young people are very well trained. They are doing robotically also, they are doing by bats also. But people are doing it with bronchial sleeve surgery also. Kidney, now you know that incidental detection of RCC, they increase from 7 to 30%. And that is in early 70s. Now it is 40 to 60% is the incidental detection. Now, are you going to remove all the kidneys of all patients of 3 centimeter? No, not at all. You have to preserve the kidneys because it is very important. Young patient 40, nephrectomy, unless there is no choice. But retrospective studies shows tumor less than 3 centimeter rarely metastasize and have slow growth rates. And 25% of incidental renal tumors are benign, risk of unnecessary nephrectomy. So you know that we don't do total biopsy or anything for kidney tumors. It is basically a CT scan and clinical diagnosis. And this is how the partial nephrectomy is performed when the tumors are situated at different upper pole, lower pole, mid pole outside. So you can have a nice partial nephrectomy done by, again, with a good experience neurosurgeon nowadays, neurosurgeon or uro-oncologist, and you can preserve the kidney as far as possible. Now I'll skip this. We'll straight away go to ovarian cancer. Now, most important is fertility preserving surgery. Now, we indicated in young women, low malignant potential tumors, well differentiated tumors, and germ cell tumors. Now, if you look at frozen section is important. Now, what is stage 1A ovary? I think that is most important. Stage 1A is confined to the ovary, no papillary excrescences on the surface, no ascites, no capsule invasion. That is how the definition of stage 1A. And you have to do the other staging at the same time on table because sometimes they get it upgrade to stage 3 directly by doing lavage and everything. If they have peritoneal nodules and everything. So it has to be properly staged 1A classically. Then you can do the preservation in such cases. Germ cell tumor, you know that you can take out one ovary on one side and you can preserve the other ovary for fertility point of view. Even in adenocarcinoma, very low grade, I have to found that adenocarcinoma very low grade, but you can get it and you can do that. Recurrence rates are 9%. Uterus and remaining ovary should be removed after completion of childbearing. Now, this fertility preserving surgery also coming up in a big way whenever possible because there are late marriages, late pregnancy, but the younger diseases are coming up in breast and ovarian. And lastly, the rectal cancer. Now, the rectal cancer, we have sphincter saving approaches, anti-resection, and very low tumors, bulky tumors, we have a chemoradiation approach. Now, this is the new technique in last 1 decade, which has become very popular, give neoadjuvant chemoradiation first, see that there is complete response or not, and then you take a call accordingly what you want to do. Now, as we know that you can have sphincter saving, that is an organs preserving again, anterior section, upper third, middle third, this type of approaches we do, and lower third, coloanal anastomosis. Unless you can't get anastomosis, clear margin, then you have to go for abdominal perineal resection. Now, this is how APR got converted into AR because of improved understanding of pathological patterns of recurrence in rectal cancer. Public awareness was there for alternatives for permanent colostomy. And trials comparing efficacy of sphincter saving surgery versus APR, same as breast cancer. So you have got a very good success rate. What is the margin required? 1 centimeter macroscopic free margin, distal margin is required. That's all, nothing else. And introduction of ESW, I think, ye to vardhan hai for this doing and low anterior sections, no doubt about it. And neoadjuvant and post-op chemo and radiation therapy at the same time. Now, here again, you have to keep a control, disease control as well as sphincter control. Because if you do anterior section on the 80-year-old male with sphincter is very bad, don't do anterior section, do an APR, because with a sphincter not properly preserved, you can get incontinence. So you have to be very careful in that. Now, I have got only few slides, don't worry. Total mesorectal excision we do so that the local recurrence rate becomes very less. This is a nerve preserving anterior section we normally perform. We started this when I was in Tata 1994. We used to have a lot of importance in other problems, but with the nerve preserving dissections, we could prevent bladder dysfunction, retrograde ejaculation, as well as the impotence. I had done a study for 60 patients with that study. So majority people, impotence and retrograde ejaculation was nicely prevented by doing nerve preserving ER. This is an end-to-end stapler where you get a sphincter saving surgeries, whether it's a colostomy before, a proximal or not, but I think it is a blessing for all the rectal cancer patients who are related. And whenever you have chemoradiation, you need to have a complete response for the patient to preserve that organ and observe. I think that is very important. If you have a complete response after 8 weeks, do a biopsy, see that all are negative, and then you can observe the patient very closely every 3 months and doing the small sigmoidoscopy. We have to be very careful for the follow-up. Renal cancer, again, neoadjuvant squamous carcinoma, chemoradiation gives an excellent response, same as adenocarcinoma. And soft tissue sarcoma, last slide of mine. Traditional approach of amputations are being avoided with advancement and refinement of surgical techniques, rehabilitation services, effective chemotherapy drugs, and limb preservation surgeries. I think they have changed the whole scenario which is in practice right now. So in various organs, we can do organ preservation and we can do best quality of the patient. Now the radical concept is almost going up. According to me, after 30 years, surgery also part will come down. Chemotherapy will vanish. Only targeted tablets will be there. Now these improvements will occur in the next 30 years and 3 decades of time. I'm telling you, the cancer treatment will change every year. No time we have to change with the world. We can't work with 1947 techniques at all. And that is why my concluding slide is, these are the becoming a standard of cure, good clinical and radiological assessment, extremely important. Surgeons should be thorough knowledge of anatomy as well as the disease, as well as the procedure, maintaining the proper balance between disease control and the function of the whole thing, and we will get a better quality of life. And I think that is most important. At the end, how are you going to see the patient happy? You have done a surgery, but patient is not happy, then your surgery is not reached the goal at all. So quality of life, and quality of life. Thank you very much. I have to go a little fast because the time is less. We started late. Thank you so much for giving me a little extra time. Thank you so much.
Thank you, sir. I think we'll take questions and answers once we finish all the three lectures.
Absolutely no problem.
Yes, sir.
Because we are already late.
So
start with the
we'll
next
have that, sir, please be seated on the.
Thank you so much. Thank you.
Thank you, sir. Now I will call on the stage Dr. Garud, sir.
Dr. Prakash Garud, sir, a well-known cancer surgeon, studied in Grand Medical College, Mumbai, and trained in Tata Memorial Hospital. He has presented internationally and also visited in many countries and operated over there. His additional education in specialized branch in UK. He started a cancer hospital and radiation center with full-fledged cancer therapy, including cancer surgery, radiotherapy, chemotherapy. It is a dedicated cancer center running in Ahmednagar, which is run by specialists from Tata Memorial Hospital and AIMS. Dr. Karur sir is also a member of ISO, International Society of Oncology. I welcome him and request him to start the lecture. Thank you.
Thank you. I thank the MASTACON organizers to invite me for this lecture. And I give greetings to all the attendants for this Maharashtra Association of IMA conference. Thank you. I'm Dr. Prakash Garud, and our topic today is oral cancer awareness and the new adjuvant therapy. Of course, we'll be touching the basic things also in the oral cancer management. The common cancers in men are head and neck cancers, that is oral, very common, lung, esophagus, prostate, and gastrointestinal. In women, obesity, the breast cancer has become the commonest one. In uterine cancers, endometrial cancer, then the head and neck oral cancer is also common, the third common in women, and then the ovarian cancer. The oral cancer, the incidence is 6 times higher in India as compared to the developed countries. Obviously, because of the voices, that is tobacco that is used in India. In 1 lakh population, 42 persons develop the oral cancers in India. The epidemiology is the oral in head and neck cancers, more than 90% are the oral cancers. And all the more than 90% of the oral cancer are squamous cell carcinoma. And the annual incidence is 5 lakhs cases worldwide annually. 3 lakhs deaths worldwide annually because of the oral cancers, and 2.5 lakh in India itself. And these patients suffer from the oral cancers. And this is the squamous cell carcinoma of the head and neck is the 6th leading cancer worldwide. 15% of all cancer patients of oral are in female, and male to female ratio is 3:1. Why it is important? As Dr. Dudhat has said, that organ preservation is important. There is a lack of awareness among the public. Increasing incidence is increasing because voices are increasing. Curable in the early stage, very important for any cancer. Early stage is curable. Second, face appearance directly affected. Organ preservation is very important. So face appearance preservation is very important. And it's preventable in 50% of cases. That's why the oral cancer is 50% we can prevent it. The entire head and neck has been shown where there is a larynx, thyroid, we just discussed it, there is nasal cavities, paranasal sinuses, but we are discussing only the oral cavity here. Frequently aggressive in biological pure oral cancers, very aggressive. On the sites affected are the lip, tongue, buccal mucosa, gums, floor of the mouth, palate, oropharynx, and unknown primary site also. The established risk factors are very well known. That is the tobacco and its products like chewing tobacco, smoking, mava, and gutka, the alcohol use, or bad oral hygiene, hot chili diet, spicy diet, oily diet, and use of pesticides in vegetables. Age more than 40 years is another risk factor, and human papillomavirus recently come as a positive factor. There is a field cancerization in oral cavity. The concept of field cancerization is that it is a biological process affecting large areas of cells by carcinogenic alterations due to the exposure to all these risk factors. So head and neck cancer risk factors, we have already seen tobacco, alcohol, and the HPV. In sites affected by the tobacco is not only the oral cavity, there are many organs are affected in the like lung, esophagus, stomach, colon, rectum, urinary system, bladder, and uterine cervix. All are affected by the tobacco. The signs and symptoms of the clinical presentation in oral cancer is most of the patients presents in the advanced disease with the regional nodes in 43% of cases, the distal nodes in 10% of cases. The presentation starts with the leukoplakia, erythroplakia, that is the red patch, leukoplakia is white patch, ulcerative lesion, swelling, dyspnea, dysphagia, dysphonia, hoarseness is there, bleeding from the lesion, epistaxis, bleeding from the nose, and trismus and submucous fibrosis is very common in the tobacco chewers. Sequence of the disease progression is in oral cancer is it starts the leukoplakia, white patches, then the erythroplakia, then dysplasia, and then carcinoma in situ, then the frank carcinoma, then the regional lymph nodes and the distal metastasis. So this is the case of the leukoplakia of the left buccal mucosa. Here the left buccal mucosa cancer is seen on the left buccal mucosa, oral cancer. This is the left lower alveolus cancer is seen here, completely lower alveolus is affected. Cancer of the right upper GPS is seen here, is affecting the right buccal mucosa also. Cancer of the tongue, left side of the tongue, cancer, ulcerative lesion is there on the tongue. Cancer of the right buccal mucosa affecting the lip also, you can see that. And the cancer of the hard palate, here where it is left side of the hard palate is affected. The lower gingivobuccal sulcus, there is a right gingivobuccal sulcus and there is the central part of the gingivobuccal sulcus where the inner part of the lower lip also is affected. Advanced cancer of the oral pharynx also we see when presented with in the late stage. So this is the late stage of the oral pharynx. In neck, many times presents with the neck nodes. And these neck nodes usually affected in the oral cancers are the group 1, that is the submandibular and submental, and the group 3, which is the internal jugular, mid-internal jugular lymph nodes involved. But in the late stages, most of the lymph nodes of the neck involved. Delayed diagnosis is because of the obvious things, the lack of attention by the patient themselves, lack of awareness, lack of attention, lack of pain. Cancer always is painless in the initial stages. In co-relation to the injury, they have a misconception that because of my teeth injury, this happened, that happened. That's why misconception is there. Fear of the disease. Many times patients fear that there is a cancer, but they don't want to show because there is a fear of the cancer itself. And extreme tolerance in India. Extreme tolerance. Missing the lesion, then the fear of the disease, correlation to the injury, and absence of the pain, extreme tolerance is there in India. That's why we come with the late cases. The screening is done when there are no symptoms, but the checking is done. That is the most important because incidence of the oral cancer is very high in India and cure rates for early stage are very high. That's why early detection is very important. Methods what we do is a clinical examination, digital video horoscopy, like we have a colposcopy, we have a digital video horoscopy, diagnostic imaging, CT scan, MRI, biopsy, FNC, all we routinely will do. This is digital video horoscopy where magnified view of the entire oral cavity we do staining and we do abnormal cells biopsies also. So early detection of the oral cancer is done. Pathology of oral cancer is most common and more than 90% is squamous cell carcinoma. Then comes the mucoepidermal carcinoma, then adenocarcinoma. Verrucous carcinoma is the very low grade squamous cell carcinoma, and then the basal cell carcinoma. Staging prognosis is very important. We do the TNM staging also and the clinical staging also. Stage 1 is T stands for the tumor size, N for the node, and M for the metastasis. So T1, N0, M0 is the stage 1. Cure rate is 80 to 90% in oral cancers. In the stage 2, T2, N0, M0, 70% cure rate is there. In stage 3, T3, N1, N2, and no metastasis, and 40% of the cure rate is there. And stage 4 is the advanced disease, where there is a large tumor, there is a matted nodes, and there is a presence of metastasis, then cure rate is only 10%. The effect of the tumor size of the survival is directly shown in diagram like this. Lesser is the tumor, more is the survival. Treatment approaches in oral cancers, like in any cancer, there are multi-modality approach. Like surgery, we have surgery where there is a resection is done, reconstruction is done. Complete resection is most important. The resection has to be R0, residual disease 0. Chemotherapy, we do neoadjuvant like before surgery, adjuvant after surgery, and sometimes along with radiotherapy, we concurrent chemotherapy, and in advanced stages, we do palliative chemotherapy. Always a combination of drugs, 2 or more drugs of the chemotherapy. In radiation, usually given post-operatively, and sometimes it's an advanced stage, which is inoperable cases, radical RT is given, and in advanced stages, palliative radiation is given. So multi-modality approach is very important. Management of the neck done with the most now commonly is a modified radical neck dissection where there is a organ preservation. Local advanced disease is managed with the concomitant chemo and radiation only because they are inoperable. So there has to be a holistic approach. Dr. Dudhat has told a team approach. It's a team in oncology that working, including the physician, family physician to the oncosurgeon, radiation oncologist, medical oncologist together will fight all this oral cancer. Some of the circuits. Here the composite resection is done. Mandible had to do because mandible was involved. Tubular digastric muscle is seen anteriorly, posteriorly intermediate tendon, and the buccal umbilical is excised. And then this is the post-operative CA lower lip cured patient. This is another cured patient of the oral cancer. Another cured patient oral cancer. So most of the patients we see, male and female are together, cured patient of the oral malignancy. Some innovations has come, like Dr. Dudhat told me. A lot of innovations are coming up last 10 years, much more. In surgery, reconstructive procedure system, because the face has to look good. That is because face is the most important appearance of the personality. Radiotherapy, there are so many advanced machines has come now with all these facilities, IMRT, IDRT, RapidR, SDRT. Newer drugs are targeted therapies and antibodies. As we heard that in future, in another 30 years, these antibodies will take the major role. Targeted therapy will take the major role. In reconstructive procedures, we see the pedicle flaps in the oral cancer, like deltopectoral flap we see here. Then the pectoralis major myocutaneous flap will take from the chest. Pectoralis major osteomyocutaneous also can be taken using the rib along with the flap. And then the pre-flaps are now the trend is a pre-flap where these are radial flip as is flap used most of the for the oral cavity in the tongue or the floor of the mouth. Tubular pre-flap also used for the replacement of the mandible and especially for the middle of the mandible. This is the preoperative case where there is a cancer of the oral cavity, lip is involved, and the buccal mucosa is involved, and this is the post-operative case where same patient where we see here the deltopectoral flap is used, also the pectoralis major myocutaneous flap is used. Chemotherapy is important as because we use a combination of the drug like cisplatin, 5-fluorouracil, ifosfamide or paclitaxel. Other combination is used paclitaxel and carboplatin. And now targeted therapy has come in chemo also. That is the epidermal growth factors are very important and they are expressing 40 to 80% of the head and neck cancers, oral cancers. So EGFR stimulates the growth of the cancer cells, and that's why there are antibodies, cetuximab, for example, cetuximab, and tyrosine kinase inhibitors like gefitinib, they are used in oral cancer for squamous cell carcinoma. This is the EGFR. You can see the EGFR, they acting and they stimulate this cancer cell growth, but they are inactivated by the tyrosine kinase inhibitors here and the EGFR antibodies. This is the main problem occurs after chemotherapy, hair loss. Very many, that's why people fear the chemotherapy. But nothing to worry, we always assure patient that this is a temporary phenomenon and the newer drugs lead to less hair loss. But after the treatment, complete hair growth is there, so no problem. So there's also complete hair growth after the treatment. The radiotherapy has now So many innovations has come. The latest machine shows there is a 2D, two-dimensional radiotherapy, 3D CRT, IMRT, IGRT, SPRT, SRS. All these treatments help us for the organ preservation, for the delivering the correct treatment and the maximum treatment to the tumor, preserving the normal tissues. Very important. This IMRT reduces the dose to the normal structures like parotid, spinal cord, orbit, optic nerve, etc. Allows a dose escalation, so we can increase the dose also, and improves the long-term function post radiotherapy. This is a picture of the radiotherapy where you see 2D and 3D CRT, where there is no organ preservation, but in IMRT there is an organ preservation, like spinal cord is preserved here, not given. This is rapid arc. Rapid arc is a video, please. Rapid arc is done used by this machine where in 360 degrees the rotation is there, radiation is given, and in preserving the normal tissues. Yes, sir. So this is the machine, vital beam latest is the advanced machine where the patient is taken on the table and then the orphid is fitted on the head and neck so that the patient doesn't move, and so there should not be any movement during the radiation. So the normal structures are preserved and maximum dose will give to the tumor site. So this is the fixation and position given to the patient, and then with the lasers, the sizing of the tumor is done, the positioning of the tumor is done. This machine is with the CT scan attached to it, inbuilt CT scan. So they take the images also. This is onboard imaging is done for every patient before starting the treatment, and these images are very useful for giving the treatment while later on treatment, because these images are matched with the previous CT scan. So this is the matching going on. Verification of the previous CT and the on-board CT scan, they are matched together so that, and then planning is done so that only maximum treatment goes to the tumor cells and the organs, normal organs surround are there preserved. Now the treatment delivery is going on here. This machine moves in the 360 degrees and giving the radiation to the tumor. At the same time, multiple collimator moment is there, which manages the images to and allowing the radiation only to the tumor cells and preserving the normal structures. Very important functions and these days in the advanced machines. Next steps. After the treatment, rehabilitation is very important because not only the organ preservation function also should be important. So important in perioperative care, physical and occupational therapy is done, speech and swallowing the rehabilitation also is done, and the nutritional support is done. The follow-up of the long-term survivals in head and neck cancer, 80% recurrence occurs in first 2 years. Follow-up is very, very important. Close follow-up and a treatment of early recurrence is curative, hence follow-up is important. And period coincides with the time required for the rehabilitation. At the same time, rehabilitation going on. So it is helpful for the patient for follow-up. Prevention, 50% oral cancers are preventable, and avoid tobacco and its products, avoid alcohol, good oral hygiene, proper diet and exercise. They're all preventive. There is a cancer prevention, there is a primary prevention, which I already told, and there is a secondary prevention where there is an early detection and treatment. So both are important. Chemo prevention has recently come, like because of the field cancerization oral cavity, the vitamin A analog are also used for prevention. This is our oral head and neck cancer group, which is cured patients, all female cured patients meet regularly and support the society also and make awareness. So in summary, 50% of the oral cancers are preventable. Screening and early detection is the key to success. Multimodality approach is must. Early detection and complete treatment is must for the cancer cure. regular follow-up is very important in the cancer patient, and once in a year checkup after the treatment is important. The schemes are there for the pre-treatment, and there are the head and neck fellowship is going on by the NHS. So thank you very much.
Thanks a lot, sir, for such a wonderful lecture. Now, I request Dr. Tavan sir to felicitate Dr. Karur sir. I request Dr. Amar Deshmukh sir to felicitate Dr. Dudhar sir. Thank you, sir.
Third, sir, on your colleagues.
Our next speaker will be an online lecture. Dr. Abhay Bhave sir, he is a metallurgist from Mumbai. He has done fellowship RCPA from Australia. He has also been a fellow at CMC Vellore. His area of special interest is coagulation and benign hematology. It will be online lecture.
Good morning, everyone.
Question and answer sessions.
Can you hear me? Am I audible?
Respected both speakers, I have a question for you, both of you. What is the role of tumor markers in a normal person?
In a normal person, in one sentence, there is no role for tumor markers. Very clear. Not to do tumor markers. If the labs are doing, they are wrong, because tumor markers indicate a prognostic value, not the screening or diagnostic value. It is to support your diagnosis. If a lady has a ovarian mass, if you suspect benign versus malignant, you can do CA125 to compare that. But a normal lady comes to you as a screening, no tumor markers to be done. I have taken out that thing from Nanavati Hospital lab since 2009.
If there is any family history,
Nothing. No. Tumor marker is not. Unless there is a suspicion of the disease, then only. Otherwise, it has got no value. People tried everything. All trials miserably failed. CA125 trial failed. CA15-3 miserably failed. I think we don't do even CA15-3 also in the breast, unless it is really good. CA125, yes, we do. Yes. Now, it's a good question, basically. Now, whenever you have young patients, basically less than 45, and who are triple negative, basically, then they have got a genetic predisposition. Not all triple negative will come positive, but there are certain percentage, and to 10 to 15%, they will have genetic mutations. Now, these genetic mutations we never used to do before 2010, because tests were very costly, around 1 lakh. That has come down to 13,500 in a good labs. So BRCA1, BRCA2 mutations and additional standard hereditary gene panel we do that, and we get an assay after 3 weeks. So whether it's a BRCA1 positive, BRCA2 positive, any of them positive will have high chance of that lady for the development of opposite breast cancer also. And at the same time, if she has got a sister and a daughter, it can be transmitted. Now then, for such a BRCA1 positive patient or BRCA2 positive patient, you have to screen the first degree relatives, daughter, sister, and other people. So see that there is no transmission or there is no presence of BRCA1 and BRCA2 mutation. Now, another thing, addition to your question, if the lady is BRCA1 positive, I diagnosed it, triple negative BRCA1 positive. So I will give the choice of bilateral mastectomy. Okay, and later on, ovrectomy after the treatment is over. Now, young patient of 35, if the childbearing age is over, bilateral mastectomy is the choice first to give it to the patient. Nowadays, yes, people are going to agree, but majority may not right now. So, mastectomy or whatever you do, but if the triple negative BRCA1 positive, ideally mastectomy with reconstruction. Otherwise, if you do breast conservation, then you have to follow up that breast with the MRI very regularly every year. So that close monitoring is required because you can get cancer in the same breast or opposite breast. So these things need to be counseled by the oncologist and the genetic counselor for the patient point of view. They should not do offhand, go or maybe BRCA1 group. Patients should not do that. Don't even encourage that to do the test on their own. Because I'll tell you one thing, I have a patient of triple negative, BRCA1 positive. I did a mastectomy and opposite breast monitoring. I told her she was not agreeing for bilateral mastectomy. And finally, I did her daughter's BRCA1, it came positive, 25. So I had to counsel her for half an hour. Then I sent to genetic counselor who are expert in this, and finally made the monitoring protocol for her. So it has to be handled in a very carefully. And you have to identify such high risk individuals nowadays because breast cancer, the increasing age of breast cancer in Asian countries has changed from 60s to 25 to 45. So we are getting steep rise in this particular period of years, and which is not a good sign. That is called as young breast cancer incidence which is rising.
Good sir.
Yes.
I have one question to you and one question to Garud sir. I request Garud sir to be on.
Yes, sir.
Chair, please. Garud sir, first to you. Have a seat. Can we do an breast implantation in silicone implant?
Yes.
Immediately after surgical removal of the malignant part? Because
You can do primary, you can do secondary.
Because later on there are the chances of fibrosis.
So primary is always better. But only thing we need to have a choice what is going to be the disease status. If the disease is badly locally advanced, if it is bad nodes, and you know that it may recur locally at the earliest, so you can avoid reconstruction, do later on after 1 or 2 years. And if you feel the lady is only multicentric disease and standard mastectomy to be done, you can definitely offer either a flat lat dorsal pram or implant with lat dorsal. But younger patients, if they are 27, you don't take a tram flap because they are going to undergo pregnancy later. So that needs to be considered. So I'll share one news, see how the things goes. One lady, one girl I treated in 2017. She is young breast cancer, post-marriage, 26 and a half. So I treated her with breast conservation. Triple negative, BRCA was negative. After 3 years of everything, she was very keen for pregnancy. She did her pregnancy. Yesterday, I got a call when I was state executive going on. She delivered a baby boy, and she's doing very well. Okay. I think these are all the things for an oncologist, which is encouraging. No question about it.
We are proud to JMO people from Nagar. They are conquering
Our
Mumbai and
yes.
Garud sir. Does genetics play a role in malignancy? You know, what is the ratio of male-female in genetics and what is the situation of mass regarding ratio of malignancy? The basic question is related to genetics.
As per the oral cancer concern, no genetic. But whatever he said, that we don't do the normal patients, person genetic studies. So genetic study has a role where in certain cases, in specific cases, as Dr. Tulad already told, only that.
Okay.
Sorry for the interruption. Now, already as we are running short of time, so
Genetic testing is going to be
question
a future of the whole thing, but only thing it has to be done judiciously, not as a routine testing manner. Thank you so much.
Thank you so much.
Thank you all.
Okay, let us wind up with the question answer session now. Thank you. Our next speaker is Dr. Abhay Bhave. He will be online. It is an online session on hematology. The topic is approach to bleeding disorders.
हॅलो हा मी ऑनलाईन माझं स्लाइड पण दाखवतोय मी
दाखवताय एक मिनिट
हो.
स्लाइड
इट इज सेइंग युअर स्क्रीन शेअरिंग
हा हा एक मिनिट सर होल्ड ऑन करेक्ट
हो
येस येस दिसतंय सर या प्लीज गो अहेड
मी सुरू करू Hello. Good morning. I hope I'm audible to the audience.
Yes, sir.
Okay. I would like to thank the organizers of MASTACON for inviting me for this online opportunity to discuss on approach to bleeding disorders in the community. So, bleeding disorders are common referral to a hematologist. And the ones which we see commonly are severe thrombocytopenia, hemophilia A or B, von Willebrand's disease. The problem is bleeding can add to morbidity and mortality, and therefore we can have a problem if we don't diagnose the bleeding event adequately. And for this, we need an evidence-based evaluation and treatment. Now, you cannot go away from the combination of a good history taking, good physical examination, and laboratory. This combination of history taking, examination, and laboratory will ensure that we get a proper diagnosis so that we can treat our patients adequately. The normal homeostasis is made up of the endothelium and blood vessels, coagulation factors, especially and including the fibrinolytic system and platelets. Anything which goes wrong in this system can cause either bleeding or clotting. So there are some events which tend to make you bleed. There are some events which will tend to make you clot. But it is basically an interplay of this triangle, which is called the Furkov's triangle. So who can bleed in the community? Those who are on medications, especially oral anticoagulants or antiplatelets, those who have got thrombocytopenia, those who are factor deficient, especially 8 and 9, either congenital or acquired as part of autoimmune disorders. Patients who got sepsis and admitted in a critical state who go into DIC. Those who have vascular malformations such as angiodysplasias, especially inside the gut. Those who are decompensated cirrhosis of liver where there is a thrombocytopenia, and liver is the seat of forming large number of coagulation factors. If liver is not functioning, these coagulation factors will be deficient. And rare, but still there, is congenital platelet disorders, which can give rise to bleeding. So what can be our simple approach to such patients? We need to know, is this a congenital event or an acquired event? Is it in the mucosa or it's in the deep sites like the joints or muscles? Is it secondary to drugs like antiplatelets or anticoagulation? And we must also keep in mind that sometimes we have something called as Munchausen syndrome, where there's fictitious bleeding or self-induced bleeding through injuries. So if it's from birth, it is likely congenital, and we should take a good family history, and we should be able to pick up other family members who have got a similar bleeding tendency. If it comes later on in life, it is more likely to be acquired, but there are certain mild deficiencies of factor 8, 9, and 1 Willebrand's, which can come later on in life, principally if they have never been challenged. If it's predominantly a mucosal bleeding, like the nose or gums, it's more likely to be thrombocytopenia. But if it's in the joints, muscle, or in the brain, it's more likely to be a factor deficiency. The drugs that I alluded to earlier are drugs like aspirin, clopidogrel, acetrom, warfarin, or the newer direct oral anticoagulants or novel anticoagulants. And we have to keep in mind, do a physical examination for Munchausen syndrome. I also ask for histories of surgery in the past or a dental extraction, because this is a challenge to the system of the coagulation. And therefore, you might come to know whether there was a bleeding episode in the past or not. And sometimes they forget about it, or sometimes they may want to hide it, but asking is very important. Simple things like post-vaccination bleeding, or need of blood transfusion with a small procedure, or need of factor infusion, not only in the patient, but in some other family members, all adds to your ability to decide whether there is an issue with coagulation or not. Remember, mild congenital disorders can present later in life. Every child who bleeds need not be congenital. Combinations are always possible. And therefore, a combination of history, general examination, and certain investigations is very helpful. Sometimes we have to do specialized investigations, and sometimes we may need to repeat an investigation at a later date just to see whether the reports were really true or not. If there is bleeding and we have found a reason, many times institutional based management is more necessary, so that adverse events can be taken care of in emergent times. Usually, in my experience, unprovoked bleeding is a severe form of bleeding tendency. And if there is an injury related bleeding, it's a little bit different to when it happens without the history of bleeding. I consider that much more significant and can contribute to morbidity and mortality. And last but not the least, liver-related diseases, renal-related diseases, telangiectasias or hereditary hemorrhagic telangiectasias and angiodysplasias all contribute to bleeding events. And therefore, it's not necessary, it always has to be a coagulation or a platelet defect. There might be other vascular reasons for bleeding. The first investigation that I ask for is CBC, especially to see the platelets. Then I see the other organs like liver function and renal function, because if they are abnormal, they can contribute to bleeding. And therefore, my site of origin of bleeding is more clear. But many times I have to do a coagulation test. PT, PTT is the front runner. If they are prolonged, now what do I mean by prolonged? If the PT is more than 3 seconds of control and APTT is more than 6 or 8 seconds from control, they're considered to be abnormal. I'll give you an example. Suppose for PT, the control is 9 seconds and the patient is 15 seconds, then it is beyond 3 seconds control. Therefore, it's abnormal. Likewise, if the APTT control is 24 seconds and the patient is 38 seconds, it's 12 seconds difference. So that's 6 to 8 seconds beyond control. That's considered to be abnormal. If they are abnormal, we do mixing study where we take the patient's plasma and add normal plasma to it and see whether it's getting corrected. If it's getting corrected, that means there was something deficient in the patient's plasma, which you made proficient by adding normal plasma. And then when you repeated the study, the PT-PDT had both come to normal. This usually indicates a factor assay deficiency, a factor deficiency. And the commonest factor deficiencies that we have got are factor 8, factor 9, and von Willebrand's, amongst the others. What if on mixing studies, there is no correction? That means despite giving 50% of the amount of factor, the patient's PT-PDT is still not getting control. That means there's something in the patient's plasma which is preventing the clotting. So that's inhibitor. Probably there is an inhibitor in the plasma, and we'll see how to assess this. I also look at plasma fibrinogen. If it's less than 100, there is a risk of bleeding. And if it's less than 50 milligram per deciliter, spontaneous bleeding is known to occur. I also do platelet mapping and thromboelastogram, two brilliant tests available for us to look at platelet function. Are they at cause for bleeding? And nowadays, we've also been able to pick up flow cytometry for platelet-related issues, especially the platelet glycoproteins present on the surface. But this is not in the routine realm as yet. It's still in clinical trials. This is the thromboelastogram, which shows a graph which shows an R time, which is a time for initiating of the fibrin clot. So it's like a clotting time. Then there is an K time, which is the time needed for activation of the clot so that the earliest thrombin platelet interaction can be seen. Then comes the alpha angle, which is this angle, which tells me about the fibrinogen, and the maximum amplitude, which tells me about the strength of the platelets. Bigger the graph, more is the strength. And then the clot tends to lyse. So lysis times tell me whether there's ongoing fibrinolysis or not. So there are measurements over here which are given. And based on this measurement, I can come to know which of the issues is causing the patient's bleeding. Whether it's a factor deficiency, fibrinogen deficiency, platelet deficiency, or excessive fibrinolysis. So beautifully it can be covered. Sometimes I have to do an angiography or endoscopy to find out if the bleeding is related to a blood vessel, especially in the GI tract. You'll ask me what happened to BT and CT. We actually don't do it now because there's too much variability in its reports, and therefore it is not our recommendation. But most of the times, BT CT is included as part of testing for any procedures which are needed to be done on a patient. Sometimes it is more to do with medical legality than actual need. But you must remember that when we are doing blood tests, there are a lot of variables, which are pre-analytical variables, which can cause abnormal reports. So we have to be very careful that the laboratory which is doing the test has technicians who know how to collect blood. They should be collected from a peripheral vein, preferably by a double collection technique or double syringe technique, where once the needle is inserted into the vein, we collect the first sample for other tests. The second syringe should be collected for coagulation profile so that the chance of errors is much lesser. And the vein should be accessed well. Please do not collect blood from central lines because it comes in contact with the catheter and it may have got activated by the time it goes to the laboratory. These coagulation factors may have got spent and we may not be able to get the true answer in these patients. I look at the peripheral smear and these are platelets. Those minute dots which you're seeing are platelets. And I look at the graph. Normally the platelets are between 2 and 20 femtoliters. Here you can see it's a beautiful graph which is seen up to 30 femtoliters. So I know that the platelets are adequate and they are not the cause of the low platelets, of the bleeding. So we come to the coagulation test because whatever said and done, how much of a good history and physical examination do you do, your answer is going to come only from the coagulation tests. And therefore, we have to know the coagulation test. We have 4 coagulation tests which are very important: the prothrombin time, the partial thromboplastin time, thrombin time, and the fibrinogen. Through the partial thromboplastin time, we are able to detect factor 12, 11, 9, and 8 deficiencies. Through the common pathway, we can pick up factor 5, 10, 2, and 1. And through the prothrombin, we can pick up factor 7 deficiencies. You'll notice that the reagents are different because you're looking at 4 factors here in the APTT, while only 1 factor in PT. Therefore, you have to have different reagents to be able to pick up. This is the APTT pathway, which looks at not only the intrinsic pathway, but also the common pathway. And this is the extrinsic pathway, which looks at factor 7 plus the common pathway. Therefore, common pathway being common to both, it's very important that we do PT and PTT simultaneously so that we can differentiate between both these 2 pathways. Remember, these 2 pathways are shown separately only for laboratory. Within our system, both the pathways work together. Factor 13 is necessary for stabilizing the clot, and fibrinogen is very important to be able to form the clot. So fibrinogen forms the clot, 13 stabilizes the clot. How do we interpret this? Factor 7 deficiency, if PT is prolonged, it is usually factor 7 deficiency. It could be because of vitamin K antagonist, liver disease, vitamin K deficiency, or inhibitors such as lupus anticoagulant and the newer oral anticoagulants, especially apixaban, rivaroxaban. What What if only the PTT is prolonged? It can be factor 8, 9, 11, or 12 deficiency, and also the presence of dabigatran, which is a new oral anticoagulant. If it gets corrected, it's a factor deficiency. If it's not corrected, then we are looking at presence of an inhibitor such as heparin, lupus anticoagulant, or dabigatran. So there is a method to making an interpretation on these cases. If the thrombin time is prolonged beyond 2 seconds from control, it can be because of presence of heparin, low fibrinogen, or abnormal types of fibrinogen. It can be because you use a drug like heparidin or leprinoids, which interfere with the ability to do thrombin time. And even dabigatran, if it's present, it's a very sensitive indicator that it is still in the system. The fibrinotic pathway is difficult to assess. Fibrinogen has to be converted to fibrin. Fibrin will then form the fibrin clot. So for fibrinogen conversion to fibrin, we need thrombin. When fibrin is formed, it forms the clot. On the other hand, if the clot goes excess, we need someone to cut it down. So plasminogen gets converted to plasmin, and that is done by TPA, which are plasminogen activators. And once they are activated, plasmin cuts this fibrin to size. But sometimes this fibrin can go over and cause fibrinolysis. And that's what happens either with thrombolysis that we use for, say, pulmonary embolism or for myocardial infarction, and also in snake bite. If both PD, PDT are prolonged, it's multi-factor deficiency. We can do a thrombin time. If it's normal, it could be factor 5 deficiency. If it's prolonged, it's usually fibrin or fibrinogen deficiency. We can do a factor 5 and 10 assay. They are the common ones. And we can do fibrinogen quantitation. So each test has an interpretative value, and you can come down really what's needed. What? Because we want proper replacement therapy to be given. And it has genetic implication. And you have to take a decision of hospitalization. The patient is continuing to bleed. It's a deep-sighted bleeding. There's an altered level of consciousness, especially on warfarin. If they're altered level, there's a bleed in the brain. So we have to admit such patients. And then we follow standard protocol. No intramuscular injection, no NSAIDs are given. We can sometimes manage these patients at home, but sometimes we have to admit them. And that decision is based on clinical profile. We can use plasma or factor therapy, transfusion as needed for platelets or for hemoglobin if there is severe bleeding. We can also use tranexamic acid, which is very good in order to reduce the incidence of bleeding. And also the diagnosis of factor 8, factor 9 or von Willebrand's based on the factor assessment can also give us an opportunity to use factor therapy at home. What if the PT, PTT and thrombin time, fibrinogen, factor 13 are all normal? We can still have other situations. It can be a mild factor 13 deficiency. It can be some types of von Willebrand's disease. It can be a mild factor 8 and 9 deficiency, which may not be picked up on your PT, PTT, and rare platelet disorders can be there. And sometimes these bleeds are because of
मी डिजिटल बोलतो. हा सुरू झालं.
I hope I can be heard. So in patients who got Glanzmann's thrombosthenia, you'll see that the ADP and epinephrine both do not respond In Bernard-Soulier, the ristocetin was poor. Here, the ristocetin is adequate. And there are platelet disorders, which are storage disorders, where there's a partial response. So again, platelet dysfunctions also can be picked up adequately. Usually in patients who have platelet dysfunctions, we give DDAVP or recombinant factor 7A, but these are expensive and sometimes not available. And therefore we end up using platelet transfusions, tranexamic acid or prothrombin complex concentrate. The key to successful management is awareness and a proper approach. I'm going to quickly show you some cases which may interest you. This is a 1.5-year-old boy. He underwent circumcision, and by evening, the surgeon gets a call saying that there is a constant ooze from the surgical site, and it's not stopping. The CBC was normal. They did a good history taking again. There was no past history or family history of bleeding tendency. So in this situation, what was the next test that we should do? Platelets are normal. So PT-APTT was done. It showed a prolonged APTT. Now, normally no one does it for a 1.5-year-old child. Mixing study was done and it got corrected. This indicated there was some factor deficiency. And when an analysis of factor 8 and 9 was done, it showed that factor 8 was deficient. This was hemophilia. And that's why this patient was bleeding because of undiagnosed hemophilia. Usually they bleed when the factor count is less than 1%. This is a 13-year-old girl who's got persistent menorrhagia. She developed anemia due to this bleeding, needing transfusion. Her menarche was at 12 years of age, and she's always had this bleeding tendency during her periods. Her mother also had this menorrhagia and she had bled during this child's delivery. Here, the platelets were normal. There was a mild anemia because of blood loss. What should be the next tests in this patient? Again, platelets were normal, so PT-PTT was done. There was a prolonged APTT. We did a mixing study. Factor 8 and factor 9 levels were done, and factor 8 came low. But remember, she's a female, so she's likely to be a carrier. It's usually not severe unless she's got XO or she's got Lyme's disease, which is part of a genetic mutation which occurs. And she turned out to be a 1 Willebrand's factor deficiency, which is much more common in females. Let's take some other scenarios where you might think coagulation or bleeding is the problem, and actually it is something else. This is a 52-year-old male who underwent bypass 12 hours ago, and suddenly he had 750 ml of blood loss in 15 minutes from one of the drains. There's no other site of bleeding. His preoperative test for coagulation was not done. He was taken up directly for surgery, but he had no past history of bleeding, including at appendicectomy. Look at his current platelets, PT and PTT. They're all within the normal range. So never does a coagulopathy cause so much bleeding in such a short period of time. So we opened him up again, and there was an arterial spurt at one of the sites that was ligated, and he was fine. This is a post-operative Whipple surgery. There was bleeding again from one drain about 24 hours after surgery, and there was a mild increase in the abdominal girth. No other site. There was an ET tube, there was an IJV tube, Foley's catheter, and there were 3 other drains. None of them were bleeding. Her preoperative coagulation test was normal, and there was no past history of bleeding. She had an exploration done just about 6 weeks ago. There was no excessive bleeding at that time. Look at her platelet count. It is 87,000. The PT is 21 against control of 11, which is higher than 3 seconds from control. And the APTT is 54 against the control of 26, which is higher than 6 to 8 seconds than control. So there is a coagulopathy over here. So here again, we did an angio and we picked up, because it was isolated one side, a coagulopathy should have bled from multiple sides. She was bleeding only one side. So we did an angio and we found a feeder vessel and we embolized that spurter and we were able to stop the bleeding. Now, many times what the intensivists and the surgeons might feel that there is this coagulopathy and let's control the coagulopathy with components. You're actually harming the patient, because this coagulopathy has developed because there's consumption of all these components, part of the bleeding. So you're going after the smoke, go after the fire. Put off the fire, you're sorted. We did that and the coagulopathy improved. In this case, we've got a 24-year-old male who who's got a severe calf pain with swelling of the leg, with inability to walk. He had played football the previous evening, and they thought that there was a bleeding event or an injury over there. But he's never had any past history of such episode. His CBC and PT, was all normal. His PT and PDT was abnormal. It was in fact unrecordable, and they rushed to the hospital thinking that he's got a bleed in the leg and his PT is abnormal. And the plan was to give FFP, which is why I was referred. Actually, he had a deep vein thrombosis in the calf vein. The pain was because of a clot, not a bleed. Came normal. Basically, the first sample which was collected, the child was very anxious. The boy was very anxious, and when the sample was collected, it was with a clot. So the sample had clotted by the time it reached the laboratory. So all the coagulation factors were used up. Therefore, PTPD came abnormal. So don't go by the reports, go by the clinical situation. Sometimes it's a combination. That's why it's called CPC, clinical path correlation. You have to correlate everything. Sometimes the patient and reports are two different people. You can't believe it. Always counter check it. So I'll conclude by saying the risk of bleeding assessment is a common reason for a referral to a hematologist. It is always challenging to evaluate it at times unless we have an approach. Certain bleeding symptoms like epistaxis are quite common in the general population, and there's not necessary to have a hematology problem unless there is a low platelet count or a factor deficiency. There is clinical variability in symptom expression amongst individuals with the same identical bleeding problems. So a factor 8 or 5% may not bleed as much as someone else who's got the same factor 5%. So the expression is variable, even if the factor level might be the same. Bleeding risk for many bleeding disorders are unknown, and therefore we are not able to quantitate all of them and how risky they are for a patient. So a good history and appropriate test that we have highlighted in the previous slide can help to identify clinical significant bleeders and how to approach them. A correct diagnosis will help in the right component being given to the patient for the right patient in the right quantity, so that we can control the bleeding and prevent morbidity and mortality of this bleeding episode. I must admit, thrombocytopenia, hemophilia A and B, and von Willebrand's are the commonest disorders of bleeding, but we should be like a wide door. We should keep our mind open. While we keep this in mind, we must keep other situations also open. Factor replacement has changed the way we manage these patients. Platelet transfusions have made it much more possible for us to take care of patients. And now with nucleic acid testing, all blood components have become so safe that it can be used but should not be abused. They should be used judiciously, and we can improve the quality of life, not only for that period, but for home factor therapy. We can take care of them for the future and prevent them from becoming worse. So there's much more there to coagulation that meets the eye. You need a good amount of coordination, good amount of communication between the patient and the laboratory, so that you can actually find out what is the real problem. This is called as iceberg. What may be simple to you at first may have a very important connotation, which is picked up only on blood tests and communication. I thank you for your kind attention, and I'm happy to take questions.
The drug which we use commonly in head and neck or breast was actually an antibiotic. It was extracted from Pacific yew tree. It was a bark of Pacific yew tree. It was actually scheduled to become an antibiotic. It ended up like an anti-neoplastic. Even the drug, now we are in reading sessions, a drug which is called as L-Tropopac, a direct thrombin agonist, was actually an antifungal and it was isolated from soil. So it was isolated from soil. It was going out to be scheduled like an antifungal. It ended up like an platelet enhancer. So repurposing happened in the past and repurposing is happening today even. I will go through, we will embark on a journey wherein we can repurpose anti-diabetic, anti-hypertensives, vitamins, and other drugs. Even our diet can also decide the outcome of malignancy. And how come it is? How evidence-based it is? We will see. So this is a session on repurposing drugs in oncology. So as I have mentioned, it is a strategy for identifying new uses for approved or investigational drugs. Reuse of an existing oncological drug for a new indication is termed as soft repurposing, and use of a non-cancer drugs like anti-diabetic or anti-hypertensive into malignancy is hard repurposing. So we'll go to hard repurposing in this case. So this I have mentioned in the past also, taxanes actually were scheduled to be approved for restenosis or as an antibiotic. It ended up like a chemotherapy. Doxorubicin was also an antibiotic. It ended up like a chemotherapy. It is a mainstay chemotherapy in breast malignancies. L-Trombopac was actually an antifungal and it became a thrombopoietin receptor agonist. It was isolated from soil. Vinca alkaloids, vincristine, mainstay in hematological malignancies, was an antibiotic, became a chemotherapy, isolated from Vinca rosea plant. So which of the class of drugs we can repurpose today? Anti-diabetic, metformin. Anti-hypertensive, amlodipine. Let me tell you an interesting story. I came across with an 82-year-old female patient with endometrial carcinoma, peritoneum completely studied, no chance of radiation, no chance of surgery. The only way getting away for was chemotherapy. Because of her age, we were not able to give her a very harsh kind of a chemotherapy. So we gave her minor chemotherapy. In oncology, it is called as metronomic chemotherapy. It's a very small dose chemotherapy that we had to give. She was hypertensive and was on amlodipine. To my surprise, after 12 weeks, all of her peritoneal lesions went away. She was having only 1.7 mm mass in the endometrium. What actually happened? It was not metronomic chemotherapy. A small dose chemotherapy cannot create that miracle. What happened was amlodipine. When we researched, I published my first paper, and that paper is amlodipine as an immune checkpoint inhibitor. Actually, amlodipine acts on calcium-calcineurin pathway. And this calcium-calcineurin pathway is an active pathway in endometrioid endometrial carcinoma. It was actually amlodipine along with our paclitaxel carboplatin metronomic that created this miracle. And that led to my paper publication as amlodipine as the checkpoint inhibitor. Antibiotic, you would be surprised, clarithromycin is now an approved drug in multiple myeloma. It can be given even in resistant refractory multiple myeloma that has progressed over lenalidomide and pomalidomide. And it is proven, evidence-based. Levofloxacin is anti-leukemic. It can also be used as an anti-neoplastic as well. Because levofloxacin, if anybody knows, it acts on DNA gyrase, which is DNA topoisomerase 2 inhibitor. Topoisomerase 2 are mainstay in neoplastic drugs. So levofloxacin can also be repurposed as an anti-neoplastic. Azithromycin, this was another paper that I published in an international journal. Azithromycin can be used in cyclosporine-induced gum overgrowth. And for general physicians here and medicine guys, it can also be used in amlodipine-induced gum overgrowth. So if your repurposed amlodipine has given for a long time and it caused gum hypertrophy, azithromycin, even azithromycin paste can be applied, and that can help you in getting away with gum overgrowth. Epileptic, anti-epileptic valproate. If a person with oncology is having some kind of epilepsy problem, valproate can be of dual use. It can be an anti-epileptic as well as it can be an anti-neoplastic. It is actually histone deacetylase inhibitor. It also suppresses epithelial to mesenchymal transition. Now, what is epithelial to mesenchymal transition? Just like the way Ravan changed his demonic 10-headed demeanor into a saint and abducted Sita, it's the same way these malignant drugs, malignant cells, they change their epithelial outcome, convert themselves into mesenchymal cells, reach into the bloodstream and metastasize. So to prevent that from happening, valproate can help you, and in that, by doing so, it can also give you a survival advantage. Antiparasitics, chloroquine, hydroxychloroquine, artemisinin compounds, bebendazole and ivermectin have also been used as an anti-neoplastic drug. Prolactin inhibitor, bromocriptine is a PGP inhibitor, which also prevents the multi-drug resistance. Anti-angiral nitroglycerins, and we have another study published myself. Vitamin B2, that is nicotinamide, is a poly-ADP ribose polymerase PARP inhibitor. Now, these PARP inhibitors are mainstay in ovarian carcinoma, which are BRCA positive. Early in the morning, someone asked about familial malignancies. Sir said that it can be BRCA positive. So, what do you do with BRCA positive ovarian carcinomas? After getting themselves treated, 3 cycles, neoadjuvant surgery, followed by 3 cycles of the adjuvant chemotherapy. Now, BRCA positive individuals need to give a maintenance PARP inhibitor, and this is a recommendation. It's a recommendation, and everyone does it. So these PARP inhibitors, which are commercially available in the market, are olaparib or niraparib, and these are very toxic. They cause anemia, thrombocytopenia, and all other. So in a maintenance, hardly few of our patients take those maintenance PARP inhibitors. But this nicotinamide, which is a B complex, can be repurposed as a maintenance in ovarian carcinoma, which are BRCA positive, and this nicotinamide causes the toxicity of that high nicotinamide. It has to be given in 1,500 grams per day for 14 days out of 21. The only side effect is 0.1% fatty liver. So as compared to olaparib, niraparib, the side effect is very less. So now coming up to how metformin acts. Metformin is an AMPA pathway. It acts on AMPA pathway. It needs intact LKP1, and this was actually derived from plant Gallega officinalis, which is a French lilac. And this is how metformin acts. If you see it out, pointer does not work. So metformin will act on SIRT1 AMPA pathway and will lead to lipogenic gene expression and glucogenic gene expressions, and by changing the gene expressions, it can be repurposed as an anti-malignancy. So this was the first paper published on metformin and reduced risk of cancer in diabetic patients. So metformin induced suppression of mammalian transmitter of receptor or AMPK activation is more toxic to cancer stem cells or cancer stem cell like cells. Metformin is potentially effective to enhance efficacy of radiotherapy as well. So if a diabetic is there who has been prescribed radiotherapy, you can continue on metformin. It enhances the sensitivity of multiple chemotherapeutic agents like cisplatin, paclitaxel, carboplatin, doxorubicin, and BRAF inhibitors. Metformin actually reverses the insulin-mediated insulin-like growth factors. In case of oncology, insulin can be a growth factor to malignancy as well. So when it comes to malignancy, metformin would be more life-saving than sulfonylureas or than insulin. So insulin pathway is one of the crucial pathways for development of various cancers, including breast cancer. Few studies of breast cancer suggest benefit of metformin as chemosensitive agent. Metformin pre-treatment reduce PRP-mediated DNA repair and enhance cisplatin DNA adapt. Cisplatin is again a part where we give in triple-negative breast cancer. Like few others, they did not find the benefit. Those studies which did not find benefit of metformin were actually done on non-diabetic. So in a non-diabetic, even metformin will not give any benefit, but if you have a diabetic patient with malignancy, metformin will be a lifesaving agent. So this was our paper on amlodipine. Here we published that amlodipine inhibits the nuclear factor activator transcriptor 2 nuclear translocation, and it can be an additive as an immune checkpoint inhibitor. Immune checkpoint inhibitor is a buzzword in oncology. They are going to change the whole way the oncology is practiced. Immuno-oncological agent will be a part of all types of malignancies. Currently, they are approved around 10 to 11. Sir might be knowing that it's indicated in almost every kind of malignancies. But all these, even the cheapest or the most economical immune checkpoint inhibitor in the market will cost 1.5 lakh every 43. So this amlodipine research is one of the most essential for those who are middle or lower middle or from the poor category, wherein amlodipine can be repurposed as an immune checkpoint inhibitor, especially in endometrial adenocarcinoma. So amlodipine, as we know, it's a calcium channel blocker. It's an immune checkpoint action is there based on the calcium-calcineurin pathway, especially in hormone-driven malignancies like endometrioid variant of endometrial carcinoma. In fact, we have treated one endometrioid variant of endometrial carcinoma, and if any patient, if she's suffering from hypertension, amlodipine should be the drug of choice. So these are all the trials that are published where amlodipine can be used in breast, colorectal, pancreatic, leukemia, sarcomas, and any other. So again, coming to the next topic, clarithromycin, antibiotic, Dury-Salmon staging. If anyone knows, multiple myeloma was done by Dury-Salmon staging. So Dury, he reported that greater than 50% response rate in multiple myeloma when 500 milligram of clarithromycin was administered twice per day, which is the regular dose. So clarithromycin has not only been used in myeloma, but it has also produced cytological remission in chronic myeloid leukemias. It is effective in lymphomas, Waldenstrom's granuloma. Clarithromycin with lenalidomide or pomalidomide reduces the dose of steroids. What we have a problem in India is that we don't have patients suffering only from myeloma, but we have patients suffering from diabetes along with myeloma. So giving steroids in diabetes will worsen his diabetes as well. So what we need is a strategy wherein steroid is to be on the lower side, myeloma can be treated, and diabetes can also be controlled. So we need clarithromycin, which will reduce the dose of steroids and as an objective response rate. See the figure of objective response rate, it is 90.3%. 9 out of 10 will respond if clarithromycin is added to the conventional. And a combined stringent and conventional complete remission was also more than 1/3. And conventional CR was in 2/3 of the patients. The total it was 90%. It can serve as a potential adjuvant to multiple myeloma treatment. Again, coming to another antibiotic, levofloxacin. It's an attractive drug. It acts on DNA dirase or DNA topoisomerase 2. Levofloxacin arrests the cell cycle at G2M level. It promotes apoptosis and its concentration dependently regulates gene and signaling pathway. So these are the this is the better side. Here you can get what does not only just levofloxacin, but all the fluoroquinolones. They have cell cycle arrest. The apoptosis is done, enhances microRNA biogenesis. It is used as an adjuvant to chemotherapy, enhances cancer stemness, and inhibits the EMT, that is epithelial to mesenchymal transition, which is the beginning of metastasis. So it prevents metastasis from occurring. So what I would suggest is, if at all a person is suffering from some kind of a community-acquired pneumonia or any other infectious cause, and if the antibiogram is sensitive to levofloxacin, I think it should be the preferred antibiotic of choice if the person is suffering from malignancy. Another drug, azithromycin, it's a macrolide. Gingival hyperplasia is a well-known complication of cyclosporine as far as the renal transplanters are concerned. For general physicians, amlodipine or calcium channel blockers can also cause gum hyperplasia. Azithromycin elevated the reduced matrix metalloproteinases 1 and 2 And that was the pathogenesis of how azithromycin reduced this gum overgrowth. Again, going to another drug, anti-epileptic valproate. It has been studied in relapsed primary resistant leukemias, along with all trans-retinoic acids, the hypomethylating agent like azacin. Also, it has shown cytotoxicity. It has enhanced the cytotoxicity of cytosine arabinocyte. It exerts inhibitory effect on cellular proliferation, migration, again on EMT, and it induces G0 or G1 arrest in malignant glioma cells also. So valproic acid in glioma can be used as an anti-epileptic as well as anti-leukemic. So this is how the valproic acid acts. It acts on EMT, MMP2, and it acts on caspases, which are actually apoptosis pathway and AKT-mTOR pathways. Chloroquine and hydroxychloroquine, they act on autophagy and they can be also repurposed as an anti-malignant drugs. Artemisinin compounds also arrest cells at G2 MLS. It can be combined with doxorubicin, erlotinib, and sorafenib and has found to have synergistic action. In case of prostate cancer, it can be used with bicalutamide and it reduces AR7 and AR spliceosome. Actually, AR spliceosome are the main reason why prostate cancer become resistant to hormones, whether it is bicalutamide or whether it is abiraterone acetate. So to prevent that spliceosome from occurring, artemisinin compounds can be used. Mebendazole, this was a study done in Tata by Dr. Patil, and he has suggested that this can be used in glioblastoma. He recommended mebendazole with temozolomide, and there is a study called reverse swing M trial going on. Ivermectin, along with COVID, it has also an indication in as an anti-malignancy. Bromocriptine it can reduce the cancer resistance. So this was another publication of ours, nicotinamide, which we studied, and we have published around 5 papers on this topic. That it is a poly-ADP ribose polymerase inhibitor, and it can be used as a maintenance in BRCA mutated advanced ovarian carcinomas. So these are the part 1 functions. It helps in DNA repair, transcription regulatory, inflammation, and in cell death. So if PARP is inhibited, we can get a good control on malignancies. The majority of currently available PARP1 inhibitors are very toxic. They can cause anemia and neutropenia, but nicotinamide helps in bone marrow recovery on the other side. So it can be repurposed as a maintenance in those patients who are not tolerating the conventional PARP inhibitors in BRCA positive ovarian carcinomas. Vitamin D less than 7 nanogram per ml will actually inhibit the action of rituximab. So what we suggest, there is a protocol called as Dr. Job, wherein vitamin D needs to be given along with rituximab, endoxan, vincristine, adriamycin, and prednisolone to treat lymphoma where vitamin D is less than 7. So vitamin D helps in rituximab mediated antibody-dependent cell-mediated cytotoxicity at regular dosages. At supraphysiological dose, it can reduce the proliferation of cancer cells, but that supraphysiological dose comes with their own calcemic side effects. But at the physiological dose, it can be used as supportive to rituximab. Aspirin. Aspirin is a drug that used to give in colorectal carcinomas. Elderly colorectal carcinomas, 90, above 90s who are suffering. Aspirin is the drug of choice along with vitamin D. You cannot give conventional drugs to that septuagenarians or octogenarians or for nanogenarians. So here, aspirin can be repurposed as anti-malignancy in colorectal carcinomas. How can we repurpose food? Yes. Gut microbiota has to do with remission rates in multiple myeloma. Gut microbiota is assessed with stool short chain fatty acid level. If stool short chain fatty acids level are high, there are high remission rates and prolonged remission rates in multiple myeloma. So prebiotics, probiotics, and healthy diet helps in maintaining bacterial flora and helps in sustained remission in multiple myeloma. So this is how gut microbiota actually, because of the antibiotics and other, there is a dysbiosis. Dysbiosis leads to immunity, inflammation, metabolic and genotoxicity, leads to patients with lymphoma. So short 10 fatty acids. From which food do we get? We can get it from food, toast, raw bananas, legumes, plant materials, and partly milk seeds. From the milk products, butter, cheese, parmesan, whole cow's milk, and from human we get it. What is this? This is bitter gourd. So bitter gourd or Karela, it is a P glycoprotein inhibitor, and it can reduce the multi-drug resistance in chemotherapy, especially in doxorubicin chemotherapy, and other chemotherapy where P glycoprotein mediated efflux resulted in drug resistance. Here we can even reduce the dose of doxorubicin and get the maximum effect of doxorubicin if we used bitter gourd extracts along with doxorubicin. So these are the another drugs which follow that thing. So doxorubicin, vinblastine, etoposide, metoxantrone, cytarabicin, and paclitaxel mediated resistance because of the drug efflux by PGP can be prevented by giving bitter melon extract. This is other spices that can reduce PGP are black pepper, turmeric, fruits like orange and grapefruits. The other part of the this topic is what are the drugs that can cause carcinogenicity. Then hydrochlorothiazide is a photosensitizing drug. It can cause renal, lip, and other skin malignancies. The other nifedipine, it can enhance photosensitivity and can do lip malignancies. Pantoprazole, neuroendocrine carcinomas, noradrenaline, esophageal, ovarian, and liver malignancies. Sulindac can cause gallbladder carcinoma, and psychotropic drugs can cause testicular and breast cancers. So the message is many common drugs can be repurposed as anti-neoplastic agents. All the studies in repurposing drugs are either clinical or phase 1. It's easy to register a trial, and these drugs may help with potentiating conventional chemotherapy. So whenever you come across patients of malignancy suffering from some comorbidities, you can already focus on these drugs, and that can potentiate the action of our chemotherapy, and we can get a better results in malignancies. Any questions?
Yes, sir. Hello. Is there any role alkaline food in prevention of malignancy? Alkaline food.
No, sir. Our physiologically, our blood itself is 7.4. So 7.4 is alkaline itself. So alkaline water or alkaline anything does not have any proven benefit as far as anti-malignancy is concerned. What I have shown you are proven papers published, and they have shown benefits actually. There is no proven benefit of alkaline water. Physiologically itself, we are at alkaline level itself. We are having a pH of 7.4. So physiologically also we are at 7.4. Despite that physiology, we are suffering from malignancy. So what we should focus on rather than on pH, we should focus on how to prevent that malignancy from occurring, what diet we should be having so that we can have a sustained remission. Once we have achieved remission with conventional chemotherapy, diet won't give you remission, but it will give you prolonged remission.
Yes, thank you so much.
Thank you so much, sir, for your words of wisdom. We are running short of time.
Question from sir.
In oral cancer, how the tablet azithromycin will be applied?
Oral cancer, it's for the gum hyperplasia. It was repurposed. Yeah, if you can take tablet 500 milligram for 3 days, even can suppress the thing, and there can be a paste formation also.
Only 3 days?
Yes, the physiological dose that we give in pneumonia.
Multiple myeloma, what is the duration of azithromycin treatment?
It is to be given along with pomalidomide and lenalidomide as a regimen with Velcade, that is bortezomib, lenalidomide, along with clarithromycin, and that can be given on weekly basis, just like we give it in another drugs. So that protocol is called as DRIM protocol.
Thank you, sir. Now I request Dr. Chavan and Dr. Deshmukh, sir, to please felicitate Dr. Garante, sir. I request Dr. Dange, sir, to please felicitate today's chairperson, Dr. Chavan, sir, and Dr. Deshmukh, sir.
Hello. Thanks, Dominic. Now we are moving to the second session of Pravara. I'd like to make one announcement. We have also concurrently we have started lectures in the Godavari Hall also. Now session 2, the grey matter. We have two lecturers, Dr. Ashish Gandhi and Dr. Ganesh Jagdale. So for that, I will request Dr. Dange sir to chair the session. And Dr. Mekar sir, please come on back and chair the session. We'll start with the first lecture, Advances in GI Endoscopy. I will call upon stage our young and dynamic Dr. Ashish Gandhi.
Dr. Ashish Gandhi, MBBS, DNB Medicine, DNB Gastroenterology from Mediator, Delhi. Later, Advanced Endoscopy and Fellowship at Mangeshkar Hospital, Pune, under Dr. Anand Papai. He is also interested in interventional endoscopic ultrasound and third space endoscopy. He has published multiple original and review articles in international journals. I request Dr. Ashish to please start the lecture.
Thank you, IMA Master for arranging this conference, MASTACON, IMA Shetty, IMA Shirampur, Dr. Kute sir, and all my senior mentors and colleagues present over here. The very first talk of Dr. Dudat mentioned something very important, that was organ preservation, and there have been few terminologies where organ preservation, minimal invasiveness, these have come up. No one likes colostomy or tracheostomy or any kind of deformity or more morbid procedures. So I am going to talk about advanced endoscopy, how it is contributing in this particular field where less is more. Hi, I am Dr. Ashish Gandhi. I have been trained in Delhi at Medanta and in Dinanath Mangeshkar Hospital at Pune under Dr. Amol Papai sir. I just wanted to correct his name. He is Dr. Amol Papai. I'll be discussing on advanced GI endoscopy. Just a few minutes. There is some technical error over here. Now, there has been a paradigm shift the way endoscopy has changed. Everyone amongst us, most of us are well aware of how endoscopes look like. You might be doing endoscopy procedures day in and out, and few must have undergone endoscopy on themselves. But apart from the routine endoscopic work like gastroscopy or colonoscopy, there has been a drastic shift from the diagnostic advances which have come up, and also the therapeutic advances which are now helping perform minimally invasive procedures. From laparoscopy, it is now going towards endoscopy, and there are certain procedures which are now being done in combination, that is laparoscopy and endoscopy combined surgeries, and you can discharge the patient the very next day despite performing highly invasive procedures. Yeah, I'm grateful to. Yeah. Okay. Yeah, sorry for the glitch. I'm grateful to my institute, Medanta, Dinanath Mangeshkar Hospital. This is Dr. Amol Papai sir, Dr. Gadikar sir, and the place where I work, that is Gandhi Hospital at Aurangabad. Now, evolution-wise, endoscopy was first performed in a sword swallower because they were trained in swallowing swords. So the doctor himself put in a big metal tube inside to examine the stomach. So that is the diagrammatic depiction which we can see on the right, and on the left, these are rigid metal tubes. But then the diagnostic work was being hampered. There were significant limitations to all these metal tubes, and that is why there was a need of a more advanced fiber optic scope to come in. Earlier, people were carrying such kind of such. On the left, you can see that the doctor is carrying the endoscope in the right hand. He is carrying a set of big batteries on his shoulder and in the left arm. Later on came the concept of a lamp which was being burnt by an oil, and the endoscope was being connected to it for illumination. And on the right, we can see this charming woman was wife of Mr. Schindler, and it was said that they were not giving anesthesia while putting in rigid tubes. They used to call this guy used to call his wife to as a head holder, and her charm was such that the patient never complained of any kind of pain. So that is why wives are still important. They will always remain an integral part. Now, this is a rigid endoscope. What we can see, a hollow tube is coming straight into the stomach, and whatever parts have been marked 2, 3, 1, 4. These were the blind areas. These areas we were not able to examine earlier because of the rigidity. They couldn't be moved quite comfortably within the lumen. So that is why this person came up with an idea of a fiber optic scope with a camera on top of it. Now, this guy was 29-year-old. He's a Japanese scientist who just placed a simple routine camera on top of a scope and introduced it. And he used to take pictures, develop the pictures, and then assess the mucosa of the lumen. And gradually came this scope, fiber optics. We were able to see from this, most of the endoscopists or the chest physicians are well aware of these scopes, wherein in ICU setting we use such scopes. We used to see from the scope lumen. This was a real-time imaging, no need to develop photos. We use these fiber optic scopes, and the person behind this revolutionary equipment was Hershowitz. Earlier, endoscopy was performed in sitting position. Gradually, things changed. Now, we will come to the advancements which have come up. Now, there are two parts. One is the diagnostic advancement, second is the therapeutic advancement. So, in diagnostic advancement, there is a narrowband imaging. This is a revolutionary technique. We'll speak about it. Then magnification endoscopy, chromoendoscopy, endoscopic ultrasound, and endocytomicroscopy. Now, what we see is the light which is reflected into our eyes. The apple is appearing red because red wavelength is being reflected, whereas the other is being absorbed. And if all wavelengths are absorbed, the apple will appear black. This simple physics principle was applied in narrowband imaging. Here, only the blue and the green light which was being reflected was being picked up. And that is why this was helping in surface characterization of any kind of disease. Suppose there is a polyp within the GI lumen, you need not always biopsy it. You can, from this particular NBI imaging, you can very well say whether it is a benign polyp or whether it is a malignant polyp. How deep is the invasion, and accordingly you can plan the treatment ahead. Now this we can see on the left, this is a small polyp with white and black dots. But if you can see, the surrounding mucosa color is the same like the polyp color. And that is why this is a hyperplastic polyp. You can just leave it behind. You need not touch it, you need not biopsy it. On the contrary, if you can see here, the surface pattern over here, the polyp is darker compared to the surrounding mucosa. This is an adenomatous polyp. This needs to be taken care of. However, the pattern which can be seen over here is quite regular. There are baby vessels we can see, and that is why it is a GNET 2A pattern or relatively benign nature of the adenoma. But as we go ahead, there is some distortion over here of the pattern. This is GNET 2B, that is, there is an intramucosal carcinoma which is harboring there. So you need to take care of this on priority. And this is all amorphous, completely distorted. This is an invasive malignancy. So even before taking biopsies, you can very well predict what is the nature of that particular lesion. And you need not always biopsy. You can completely remove the lesion endoscopically. Only if it is superficial one, you can remove it endoscopically, en bloc, and send it to the pathologist. It can be a curative resection. This is just the way we manage things on NPI. If it is GNET type 1, the first figure which I showed, you just leave in situ. discard it. If it is GNA 2A, that is a simple adenoma, you can endoscopically resect. 2B, you can perform a chromoendoscopy, we'll speak about it. And type 3, that is a deep invasive cancer, you can consider surgical resection. Magnification endoscopy, what we are seeing, 100 to 100 times. With magnification NBI, it can go up to 300 times. So that is the way you can assess the lesion in quite proximity. Now, this is one case which came to me 3 days back. 3 days back, this case had history of corrosive ingestion. 35 years back, presented with dysphagia. There is a stricture, but along with stricture, there is one particular lesion, a superficial flat elevated type of lesion. There is not a big growth over there. Now, our first instinct would be, let's take a biopsy and prove it is cancer. But why take a biopsy? Because it is superficial lesion, you can endoscopically dissect it off completely. If you take biopsies, there will be fibrosis and then endoscopic dissections will be difficult. Then how to prove that it is malignant? In that case, you can perform chromoendoscopy. As the name suggests, it is chromo. You are going to spray some color over it to prove that it is kind of a malignant lesion. Can you play the video? Yeah, so this was a lesion at 20 centimeters from the incisors in the esophagus. We are performing narrowband imaging too. Now I am going to spray Lugon's iodine. This is a simple dye, 300 ml, 300 rupees, 100 ml bottle, which is available at any regular pharmacist. Now I am spraying Lugon's iodine all over the esophageal lumen, including the pathological site. After 3 to 5 minutes, you can see, compared to the surrounding gray-black mucosa, our lesion is relatively less stained or weakly stained. This suggests that it is malignancy. So you can very well see the borders of that lesion. So you can endoscopically dissect this lesion completely. Now, this is one advancement which has just cytoscopy. That means you are going to perform a real-time pathological assessment while performing endoscopy. So you can either have a very good pathologist friend next to you, or you can very well learn this particular technique. Here we can see this. The first image is a Barrett's esophagus. Second image we can see NBI image wherein white patches are seen. These are normal squamous epithelium. On the third image, we can see all the third and fourth image is the endocytoscope image, wherein you are targeting that particular site so closely that you can very well see all the cells, the cellular architecture, the nucleus, the cytoplasm, that ratio, whether it is maintained or not, the visual polarity, everything. Now, this is a very routine pattern or normal regular glandular pattern in the last image. So, this is a benign Barrett's lesion. There is no dysplasia as such. However, now come to this image. First image is very regular, but in the last image, the nuclear cytoplasmic ratio is completely distorted. This is the malignant lesion. So on endoscopy itself, you can decide where exactly the dysplastic tissue is and you can resect it off if possible. Now, this is one revolutionary modality that is endoscopic ultrasound, which has come up. It has a great diagnostic and therapeutic role. This is very close to my heart, along with third space, which we'll discuss later. Endoscopic ultrasound is wherein you can diagnose any kinds of stones. Many a times CT scan or ultrasound can miss a simple, very small CBD stone. And surgeons are fearful of operating such cases because LFT is deranged, but surgeon wants to ascertain whether there is any kind of stone or not. Otherwise, there will be a bile duct leak post-procedure. In that case, we can use endoscopic ultrasound. We can see a stone in first figure with posterior acoustic shadowing. In second figure, we can see a mass sitting at the ampulla of Vetter. The bile duct behind is dilated completely, but the mass is not going inside the bile duct. So you need not perform a complete Whipple's procedure for this lesion. It is a round lesion, well defined. It is not going into, there is no intraductal extension. You can directly remove it endoscopically. You can perform a simple ampulectomy to remove such kind of lesions. Third is any kind of GI or mediastinal or abdominal mass lesions which are in close proximity to the luminal tract. You can very well take a tissue sample for proving malignancy or any whatever the nature of tissue be. using endoscopic ultrasound. And now the fourth picture, this is one of our patients endoscopic ultrasound guided liver biopsy. Earlier liver biopsies or still the liver biopsies are being taken conventionally in percutaneous manner, but many times patient is having ascites, cross ascites or significant coagulopathy. In that case, you can use endoscopic ultrasound to take liver biopsy orally. Because it is Doppler guided, so there is very minimal risk of any kind of bleed because you are performing it under vision, under Doppler guidance. Now, therapeutic endoscopy, basic therapeutics, most of us are aware of, that is foreign body removal, achieving hemostasis, sclerotherapy, stricture dilatation, etc. These are the various accessories. This is one of the foreign body removal. We need not see this video. This is a simple removal of a plum seed. This is a hemostasis. So there are various new accessories which are available to achieve hemostasis in any bleeding case. Sclerotherapy needles, band ligation sets, or hemoclips. Here we can see a large fundal varix in the stomach. The patient, young female, had come to us with GI bleed. We are just injecting glue injection and obliterating the varices. Now these are one revolutionary clips, OTSC clips, over the scope clips. These are why these are revolutionary, because they cause serosa to serosa apposition. They are like claw shaped. They will catch hold the serosa completely. So you can use them for any kinds of leaks, any kind of fistulas, any kind of perforation closure. Now gastroenterologist or as an endoscopist, I'm not really worried about some kind of bowel injury happening during endoscopy or ERCP, because we have clips, hemoclips or such OTSC clips to our predisposition, to our disguise, where we can close the perforations in the same setting. All you need to be calm for next 10 minutes when you are closing it, rather than just call surgeon immediately. You can just wait, hang on there, and then study the site. Stricturotomy, we all know there were dilators which were being used. Now there are a few other techniques like stricturotomy or stricture dilatation. Here there is an anastomotic site stricture. With the help of specialized accessories, we are cutting the stricture. We are cutting the fibrous part completely, and along with that, we will be doing a balloon dilatation of this particular stricture to give a long-lasting benefit. Because many times only dilating with balloon is not going to help. They can come back to you with similar complaints again. Here we are using balloon. This is the end result. So you cut the stricture just like angioplasty. Here also we are doing the stricturoplasty or using balloon, but we are also cutting the sphincter, that is stricturotomy. Now this is a duodenal polypectomy case I recently had last month actually. It was involving the medial wall of duodenum at the ampulla vater just next to it. Important was to identify that the ampulla vater was different and the polyp was arising from a different location. Here we can see that the ampulla vater is just above that polyp. So this was a pedunculated polyp. What we did was we introduced an endoloop. Endoloop, because there is a big blood vessel going through that peduncle into the polyp. We need to catch hold that particular peduncle tightly and only then cut the polyp preferably to reduce the chances of post-polypectomy bleed. So here I am securing the peduncle tightly with the help of endoloop. This endoloop will fall off over time. I am not bothered about it. It is compatible to our body. Here now I'm snaring off the polyp completely. So you need not do any kind of major surgical interventions for such kind of polyps also. Once the polyp is cut, important is to retrieve that particular polyp. It can run off ahead and you have to collect it from stool. So better that you collect it right away. Just a minimum of air can also displace the polyp distally into the small bowel. This is a colonic polypectomy. A young male, 16-year-old boy presented with PR bleed. Here there was a large inflammatory polyp which was involving the descending colon. We again introduced endoloop. Here I am just examining the nature of polyp. The pattern was quite regular. It was a simple inflammatory polyp, but because he was symptomatic and he was quite young, you cannot subject him to a major surgery in this case. You can directly go ahead with minimally invasive endoscopic intervention. Endoloop was applied, cautery, the polyp was snared off, and then the sample was retrieved. So I am securing the peduncle, then I am applying the snare, and then I am cutting the polyp. The polyp was cut, there was no bleed, this was a large polyp which was removed and ground. Now, enteral stems, many a times malignant patients particularly have GI obstruction, whether it is esophageal obstruction or pyloroduodenal obstruction or colonic obstruction because of malignant growth. In that case, you can directly place a stent over there. The second image we can see contrast is passing into distal small bowel. Here we have placed a metal stent, and the fifth image down, you can see the contrast is now passing well into the bowel. The stent has dilated it. So these are revolutionary stents. These are SEMS, self-expandable metal stent. You just place the stent, they will expand on its own. They are all made of nitinol, and nitinol was a material which was being used in naval ordnance factory for making ships, building ships. That particular material was brought into the medical industry, and now they are developing stents from these materials. Now, duodenal wall injury, as I said, while performing ERCP, there was a perforation to the lateral wall, but there was no, you need not be scared because you have endoclips. This was the perforation. We just burned the edges to make it more hard, and then we applied endoclips to that particular injurious site. So it was closed. You have really good clips at your disposal. You can use them and you can save the patient. Now, this is one very good case, very interesting case. This was an iatrogenic tracheoesophageal fistula. Mistakenly, it was thought to be a tumor. We applied cautery. There was an injury to the trachea. The tracheal indentation was earlier thought to be tumor. In that case, we had to save this guy, and we closed this fistula with the help of anal fistula plugs. Earlier, anal fistulas were being closed using fistula plugs. Those fistula plugs were utilized in this case. Here we can see this is a trachea. This is a bronchoscopy. We are just refreshing the edges. This is esophagus. So both bronchoscope and esophagoscope was introduced at the same time. These are fistula plugs which are now being placed directly across the fistula tract. Two fistula plugs were applied. This is carina and this is esophagus. We just positioned them so that it does not cause cough. We also additionally placed a metal stent in esophagus to avoid any kind of leak. After 4 weeks, we removed the stent. This metal stent, which was in esophagus, this was removed. We can see the fistula plug healed site. There is reepithelialization. The fistula closed with the help of two simple fistula plugs. And we can see on table contrast examination, there is no evidence of any leak. Patient is hale and hearty. This procedure was performed 1 year back. Necrosectomy bleeds. Now, earlier exploratory necrosectomy were being performed. Now we perform endoscopically. Whatever pancreatic pseudocyst or large necrotic collections are being formed in stomach, next to stomach, we place a stent directly. We create a cystogastrostomy, which I'll show later, and through those metal stents, we can go into the necrotic cavity. We can remove all sorts of necrotic debris completely. But then there are complications. We can face such kind of bleeds. But then again, no need to worry. We do have really large clips, sturdy clips, stable clips, which stay there for a long time, and they can control the bleeds. You need not re-explore the patient completely. You need not open up the abdomen or do any kind of laparoscopy in such cases. Now, many a times there are bile leaks which happen. In that case, we perform ERCPs, we document the bile leak, we just place in a metal stent, a plastic stent, and it will take care of the leak. You bridge the leak, you create a path of least resistance, the bile will start flowing naturally, and the leak will be secured. Here we can see there is a leak which is happening. Just a stent was placed. This was a plastic stent which was placed and the leak was secured. ERCP is again useful for CBD stones. This is quite conventional treatment which is available. Everyone, most of us are aware of it. Now this is one latest revolutionary technology, that is spy cholangioscope. Using your routine endoscope, you can introduce one more endoscope through that particular scope, and you can go directly into the bile duct or the pancreatic duct. This is the laser lithotripsy. Earlier, large CBD stones were being broken, large CBD stones were being removed after exploring the CBD. Now there is no need to explore the CBD. You can directly enter into the CBD and break the stone out. So this is one such case. This is a stone. This is a laser fiber. We are targeting the stone, just like urological intervention for lithotripsy. There are biliary lithotripsies also, which is now being performed. Additionally, we can do tumor mapping. If there is a cholangiocarcinoma which is harboring in bile duct, you can assess to what extent it is, and you can plan resection accordingly. This is one such case wherein a cholangioscope was passed. We can see all the tumorous tissue which is involving the bile duct. From hilum, we come down into the distal common bile duct to assess the nature of the lesion. And we can also take intraductal biopsies. We can directly go into the bile duct and you can take biopsies and come out. Now this is one topic, endoscopic ultrasound, close to my heart, because it gives us a real-time imaging. Procedures are performed under Doppler guidance, and there have been revolutionary stents and accessories. These are lumen opposing stents. They hold two lumens together. So you can create gastrojejunostomies, you can create cystogastrostomies. All the surgical modalities can be taken care of using this particular modality, endoscopic ultrasound. It can be used for pseudocyst drainage, biliary drainage. You can place in coils, just like interventional neurologists, as they place coils in basilar artery aneurysm for subarachnoid bleed, or even splenic artery aneurysms, interventional radiologists place such coils. We can also use these coils in endoscopic ultrasound. Pancreaticogastrostomy, colophonic anastomosis, gallbladder drainage, and there are infinite possibilities which haven't been discovered yet using this modality. This is one case performed almost 2 to 3 weeks back. Patient was in severe septic shock, 50/20 blood pressure, was started on NORAD on table, and this patient he presented with chronic pancreatitis with pancreatic ascites. There was a large pseudocyst, too much of pus, needle puncture. This is from stomach. I am just puncturing it into the pus collection, the pseudocyst. We see a lot of pus coming out, and 2 double pictal plastic stents were placed. These are the plastic stents which are helping drain the fluid. And in the same setting, a pancreatic ERCP was performed. Pancreatic leak was documented, and a pancreatic duct stent was performed was placed in the same setting. Thankfully, patient got extubated the very same day. He was off NORAD, and he came down to the endoscopy room next day just to boost the morale of our endoscopy team. The patient survived. He went back. This is US gastrojejunostomy. Yeah, just last slide. US gastrojejunostomy. We can perform jejunostomies, directly puncture the stomach and the jejunum and place a stent. This takes barely 10 minutes. So rather than performing invasive laparoscopic gastrojejunostomies, you can directly place in the lumen opposing metal stent. And the last, I'll just skip the slides. Now this is third space endoscopy. You enter the submucosa, that is submucosal endoscopy. These are various accessories. I have published a couple of review articles in the topmost gastroenterology journals in past 2 months' time over POEM and PRAME. This procedure is revolutionary. Actually, this is the last slide I'm going to show to you. You are taking an incision over the mucosa. You are entering the submucosa. The second image. You are cutting down the muscle completely. In achalasia cardia, there is a spastic segment below. You need to cut it. So rather than going anything more invasive, you go it through the natural orifice. Orally, go inside, cut the muscle. The G junction has opened up, and you clip it. And same technique is applied in Hirschsprung disease. Rather than subjecting the patient to invasive 3-stage surgeries, colostomy creation and everything, you go down endoscopically through rectum. And then you cut the spastic segment. You enter the submucosa, cut the spastic segment, and that's it. This was performed at our center actually. You can also remove such benign tumors from esophagus using this particular procedure, that is third space endoscopy. This was perrectal endoscopic myotomy, which was invented by my mentor, Dr. Amol Papai sir. It is now evolving and receiving more validation worldwide. The world has accepted it actually. So the three-stage procedure, procedure for Hirschsprung is now going to be treated within 45 minutes time. Yeah, so there are too many things actually. It is never-ending thing. GI has revolutionized. Endoscopy has revolutionized things in gastroenterology. Too many things to discuss. Some other platform. Thank you very much.
Thank you. Thank you, sir. Really nice presentation. Now I request Dr. Ganesh Jagdal sir to come up on the stage for his presentation. Question and answers are we'll take after both the sessions. Dr. Ganesh Jagdal, MD Medicine, DNB Cardiologist, Interventional Cardiologist at Magnum Heart Hospital, Nasik.
Good afternoon, everyone. My name is Dr. Ganesh Jagdal, and I've been asked to fill in the large shoes of Dr. Manoj Chopra sir, who couldn't come today. So the topic for the day is recent advances in cardiology with special emphasis on the robotic angioplasty. The recent advances I'm going to talk about are not like they have been discovered in last month or the last year, but they have been there since last few years. But they were not available for general public, and recently. Sorry for that. So those advances have been made last few years, but now they are available for general public use. So is loading the slide. The So science always has been advancing. In this diagram, the center slide is how the auscultation was done maybe 200 years back. And now we have come to stage where we have cardiac MRI, nuclear scanning, we can replace the valves by a transvascular route, there is 4D echocardiography and whatnot. So I will start with the advances in echocardiology. So in echocardiography, I'll emphasize on the two things. First is spectral taking or stain imaging, and the second is 4D echocardiography. So initially, generally we estimate the left ventricular function or the cardiac function in general by the 2D echocardiography, and it's a visual estimation of ejection fraction. But along with that, now they have developed what is called as Pickett taking or the stain imaging. Initially, it was tissue spectral taking, but now 2D and 3D spectral taking is available. So with this, what they calculate is the stain. So stain by definition is the change in length upon the initial length. So the heart has 3 layers of the muscle. So the internal muscles or the subendocardial muscles, they are responsible for longitudinal shortening. The middle muscles, which are the radial muscles, they are for radial shortening, and the outer muscles they are arranged obliquely. So they are responsible for the circumferential strain. So generally, we are more bothered about the longitudinal strain because these subendocardial layers of the muscles, they are innermost from the outer surface where the arteries are. So the coronary arteries are epicardial, and these subendocardial muscles are the innermost muscles, and hence they are more prone for the ischemic damage. So that is why this longitudinal strain, it is studied more in depth, and it is more accepted parameter of the heart function. So the normal value is -20, and here we can see in the first diagram where the this longitudinal strain is near normal, and it is decreased in the diagram below. So along with this, 4D echocardiography is another great advancement. So initially it was just N mode, then there was 2D echocardiography and 3D, and now we have come to the 4D echocardiography. What it helps is potentially faster image acquisition, and we can acquire very good images. So here we can give the this is the 2D image of the mitral wall. This is a transthoracic transesophageal echocardiography. Sorry. So, and the this is the 3D image. Generally, the 3D image we get very good spatial resolution, and we also get to know the three-dimensional anatomy. This is especially important in the cases of suppose mitral devegetation. Now we all know that mitral wall has anterior leaflet, posterior leaflet. Each leaflet has 3 scallops: A1, A2, A3, B1, B2, B3. And in mitral devegetation, because of the collapse of the scallop, generally 1 or 2 scallops are involved. So 4D echocardiography helps in identifying exactly which scallop is collapsing, and hence the surgeon can plan the surgery, mitral wall repair surgery, in a better way. So now from 2D echocardiography echocardiography in general, we will move on to the advances which are there in the cardiac angioplasty. So the initial angiography was kind of labor-intensive procedure, and now we have moved on to the cardiac angiography, which can be done, and patient can be discharged within few hours of admission. The angioplasty also, initially it was just balloon angioplasty, and then there were bare metal stents, and then first generation, second generation, third eluting stents, and now we commonly use third generation, third eluting stents, and bioabsorbing stents are also available. But this is just how the angioplasty in general is done. But now we have come to this precision angioplasty. So we just don't want to put the stents, but we want to make sure that the stents which we have put, they are of accurate size, they are well opposed, they are of the exact dimension of the vessel, and there is no stent edge dissection. So for this, what is developed is intravascular imaging. So intravascular imaging, generally what is used is this IVUS, which is in the last lecture it was shown that endoscopic ultrasound. So this is intravascular ultrasound. And then there is OCT, that is optical coherence tomography. Now they have far more spatial resolution compared to the CT angiography or the conventional angiography. You can see how beautiful the picture of OCT looks as compared to this CT angiography. Next. Sorry, the videos are not playing. Okay. So the ultrasound image looks like this. So this is the vessel, the outer surface, that is artificial, and then this is the media, which is different because there is plaque or deposition over here. This is the actual movement of the vessel. Now this diagram is to show the more advanced in the field of IVUS imaging, and this is virtual histology. So as you can see, the upper diagram and lower diagram, the amount of plaque burden of the lesion appears more or less same. So here this whole is the lesion, here this is the lesion. So they quantitatively they are same, but if we go for the histology, then we can see how they are differing from each other. So this lesion is more of this whitish is fibrous tissue, and the yellowish is fat. So this lesion is mostly fibrous, and few slight amount of fat is there. But as compared to this, that the lower one, the upper lesion is full of fatty tissue. There is necrosis, there is inflammation, and this is a histological slide. But the similar thing, the similar information we can gather from the virtual histology. So the reddish is the inflammation, the greenish is the fat deposition. So this can be available with the help of virtual histology, which is done by the IVUS. And then what we have is the OCT. So OCT has far more better resolution than the IVUS itself. So this is the 3D rendering of the stent. After putting the stent, we can do the OCT and find out how the stent is inflated. The stent studs, which are not very well opposed to the wall, they are labeled red, and the normally opposed tissue, normally opposed stent studs are rendered as white. Also, we can see the side branch, how they are open. So everything is very neatly, cleanly available with the help of OCT. Now you can see how there is a flap over here because of the rupture of the endothelium, the cavity. Here there is another flap with hematoma. So everything is very nicely available after OCT, and hence we are sure that how the stent placement has been adequate, and we can expect least amount of complications afterwards. Then there is FFR, which is for physiological measurement. So here this is the RCA. Now this lesion is definitely tight. We generally call lesions more than 70% as tight, less than 50% are non-significant, and between 50 to 70% they are called as borderline lesions. So this lesion definitely requires attention. This lesion over here, it is appearing 30-40%, so this doesn't require anything. But now this lesion, it is looking 60-70%. That is the visual estimation. But whether we really need to treat it, whether we should be putting a stent for this kind of lesion, that remains a kind of guess. So to improve this kind of guessing, what we can do is the SFR. So FFR by definition is the ratio of the distal pressure by the proximal pressure. So if the lesion over here is significant, then the distal pressure will be far less compared to the proximal pressure. And this ratio is calculated with the help of this rota wire, the FFR wire. It is like a routine wire, but it has the pressure measuring sensor at its tip. So initially the proximal pressure is taken, then the distal pressure is taken, and continuously the ratio is displayed on the monitor. And if the ratio is more than 80%, the lesion is deemed insignificant. If it is less than 75%, then that means the lesion is significant. Between 75 and 80, there is still the gray zone. And then what we need is rota ablation. So sometimes the coronary lesions are very calcified. The calcium is protruding in the lumen of the vessels. So if we use a normal balloon, the lesions don't get dilated. Also, there is a chance of balloon rupture. So that the different balloons have been developed, like high pressure balloon. Then what we have is scoring balloon, fitting balloons. But when the calcium is very significant and circumferential, then these balloons don't work. Then what we need is something more. So this rota ablation machine is for cutting the inner calcium of the vessels. So this is the console of the rota ablator. These are the pedal controls, and this is the advancer. And at the tip of it, the rota bar is attached. This is a newer Rota Pro machine in which the pedal controls have been shifted to the hand, and hence the it makes the life easier. I think the video won't play, but this is how the Rota burn looks like, and it goes inside. It rotates at the speed of nearly 180,000 per minute, and it cuts the calcium and dilates the lumen, and hence the stent placement becomes easier. There's an actual picture of actual video of it, but videos are not playing. So The rota ablation, as we saw, it is for the interstitial calcium or the calcium which is protruding in the lumen. But the calcium which is in the media or adventitia, it can't be accessed with the help of rota ablator. For that, we need something more, and that is the short wave lithotripsy. In the last lecture, we saw that how the lithotripsy, which was previously being used for the renal stones, has been incorporated in gastroenterology. The similar technique has been incorporated in the cardiology also. So this is the this is the ideal console. Then here is the ideal wire, and then the balloon. So this balloon is placed across the lesion, and the pulses are given. Generally, the length of the balloon is 12 millimeters, and the diameter of the balloon is 2.54 millimeters. So the balloon is kept across the region, and the pulses are given so that the region dilates, and once it is dilated adequately, the pulses are stopped. We won't go into details for the sake of time. And now the robotic angioplasty. So this is how the console of robotic angioplasty looks like. So here is the patient lying down on the table. Then here is the C arm. Here are the monitors of the cath lab, and this is the robotic arm. This is the robotic drive, and here it is magnified. So here are the slots for putting the wire. Then here is the okay. Here is the slot for putting the balloons and the stents. And the cardiologist, after assembling these all things, can sit in the console and do the angioplasty sitting in a chair comfortably. So these three are the knobs. One is for catheter, one is for wire, one is for the devices like balloon and stents. And here is the monitor, which shows the movement of balloon, wire, and everything millimeter by millimeter. And there is a high resolution monitor over here. So everything is seen neatly and cleanly. We saw how the devices for angioplasty have developed, but the basic procedure, how it is done, hasn't changed since last so many years. So this is the first angioplasty being performed by Andreas Gersing, and it was done in 1977, and now in 2022, nearly 45 years. But though the hardware, everything has changed, but how the cardiologist stands next to the patient and how he performs the procedure hasn't changed. But that has been changed with the help of robotic angioplasty. So rather than standing next to the patient, wearing lead apron, which is weighing more than 15 kgs, and constantly exposed to the radiation, now the cardiologist can sit in a comfortable console and do the procedure. This was the initial device, robotic device, that is CorePack 200 system, which was introduced in 2016. This is the precise trial in which they included 164 patients and 9 centers were there. And the primary endpoints of the procedural success were very good with robotic angioplasty. And now the system which is there is the second generation, that is CorePath GRX. So what are the advantages of robotic angioplasty over the manual angioplasty? So the close approximity and the automatic visualization. So here you can see that the normal manual angioplasty, the cardiologist has to stand at one side of the patient, then there is a table, then there is a monitor. There has to be some space between the monitor and the table so that the table's movement is possible. So the distance between the cardiologist's eye and the monitor is more than 3 feet or something, sometimes more than 4 to 5 feet. So he has to really strain his eyes to see the monitor. But with the advancement of robotic thing, now he has clear visualization. The monitor is high resolution monitor and very much next to his eyes. Then precise point and shoot predictability. So normally while doing the angioplasty, one has to maneuver the wire across the lesion. So if I want to give 180 turn to the wire, I can't just judge with the help of fingers. But on the robotic console, we can exactly measure 30 degree, 40 degrees, what amount of turn we want to give, and hence the wire navigation is simpler. Then robotic assisted sub-millimeter measurements. So sometimes the stents, which particularly when we want to put the stents at the ostia of the vessels, the stent placement has to be very accurate. And in normal angioplasty, then we have to move the stent with the help of hand and again check whether it has been adequately and precisely placed or not. But with the help of robotic angioplasty, we can exactly measure how much ahead or back we are coming with the stent. So that distance is displayed on the monitor, and hence the sub-millimeter or millimeter movements of stents and other devices is easily possible with the robotic angioplasty. Then fixed devices during deployment. While doing the angioplasty, the machine, the arm, it holds the wire, it holds the catheter, and it holds the stent, everything in place. And whatever you want to move, that can be moved. The other two things, they remain stationary. So that is another advantage, so that the stents and the balloons can be moved easily. So geographic miss, the longitudinal geographic miss can be avoided with the help of robotic angioplasty, because there is accurate movement of the stents and everything. The sizing also. Now this is the lesion. It was deemed 44 millimeters visually, and 2 stents were planned. But when they measured it with the robotic assistance, they found out that the lesion is just 28 millimeters, and they could do away the angioplasty with single stent. Another great hazard of manual angioplasty is the risk of tumors, the risk of cataract and orthopedic injuries. The risk of tumors is not theoretical; it actually occurs, and few of the cardiologists have suffered the blood cancers and the brain tumors because of the radiation. So 85% of the brain tumors in interventionalists originate in the left side, because that is the side which is exposed to the radiation. And subcapsular cataracts is also a thing. And orthopedic injuries they nearly occur in more than 50% of the orthopedicians who are practicing, in the cardiologists who are practicing for a number of years. So this thing can be avoided with the help of robotic angioplasty. Okay, I'll just this doesn't only reduce the cardiologist risk, but the patient risk of the radiation is also decreased. Here is another chart or another study showing that the use of contrast media, fluoride, radiation, everything was reduced with the help of robotic angioplasty compared to the manual angioplasty. So at present, though this thing is still in its start, the future possibilities are like improved capabilities, better lesion assessment, and automation. Integration of artificial intelligence would help in prescriptive analytics and procedural automation. Video, but I will show you. Then more. Two things. Okay. This TAVI, just stick 2 or 3 minutes. The TAVI, it has come up in a big way. So TAVI means transvascular replacement of the aortic wall. So previously the aortic walls were replaced only surgically. Now they could be replaced with the help of transvascular route. It's a fairly easy procedure, and in the expert's hands, when the patients are selected neatly, the procedure can be completed within 30 minutes to 1 hour, and patient can walk the next day itself. So indications, everything, we won't go into the details. This is a real patient which we did. The mica clip is for the mitral regurgitation. The clip can be applied to the leaflets of the mitral wall, and the regurgitation can be decreased or closed. This is another thing which is appendage, LA appendage closure. So atrial fibrillation, the patients are at risk of embolization because of the thrombus formation in the atrial appendage. The patients who are not tolerating the anticoagulation or who are still showing showers of emboli on being on anticoagulation, for them this device called atrial appendage plug is available, so that appendage can be closed off and the entry of the thrombus into the main LA can be prevented. just last thing I would show is the leadless pacemaker. It's not moving. So now generally the pacemakers are, this is the pacemaker battery, then there's a wire and the pacemaker needs to go into the heart. But with the help of leadless pacemaker, okay. So the pacemaker is like this, which can be introduced into the RV and kept there, and then there is no lead or there is no battery generator. The lead pacemaker will just stay there and pace the heart. So I will end my talk over here. Thank you for giving me the opportunity to talk over here.
Now I request Dr. Mekalkar sir to please felicitate Dr. Ganesh Agar and Dr. Gamli sir to please felicitate Dr. Gamli. Now we have concluded this session and the forum is open for question and answer. Please. Now I request Dr. Dev sir to please felicitate Dr. Mekalkar, Dr. Gamli sir.
And just take a minute. Okay, sir. I just wanted to address one of the questions. So the question was how common is H. pylori in the clinical setting and what all treatment modalities are available. So H. pylori is notorious. Only if it is notorious to you, it is causing you symptoms, only then you will treat that particular bacteria. Otherwise, H. pylori is a commensal in our stomach. 60 to 80% of us will be having it because of the very clean water and food supplies we have. Apart from that, if there is an ulcer, there is no other contributing factor. You always treat for H. pylori infection. And the 3-drug regimen which is available, there are combination kits which are available these days. Easy to take, but sometimes tolerance can be an issue. In that case, we can give amoxicillin, clarithromycin, and then ornithazole as a sequential regimen that can be given. There are quadruple therapies or newer molecules like bismuth which have come up, but then sequential regimen is quite well tolerated. Thank you.
My question for Dr. Jagdishan. What is the current status of robotic angioplasty partnership at your practicing this? First question.
Extra to the patient. Generally, the cassette is of 50,000. We don't charge anything extra. It is still in the infantile or child kind of stage. Not very commonly or commercially available thing. But it has great potential, like telecoptering, telestenting, and also if the artificial intelligence can be incorporated, then we have the CTO regions, we have the difficult regions, and not all the cardiologists are available in those kind of regions. So the machine can be given the advancements from cardiologists who are practicing it. So what they have done is they have tried to copy the hand movements of the any cardiologist, and those kind of movements they are trying to involve in the machine. So at present, we have two kind of taking movements within the mind. So we can just press the button and then the machine will do the packing movement as what ideally needs to be done. So if that kind of thing really picks up, then it will be a useful thing. As of now, very useful.
Second question. If that comes here, the choice first.
Anything better, anything better for the patient. So if we are able to enhance the possibilities of robotic angioplasty or the robot itself, when the robot would self-analyze the kind of lesion it has, lesion there is, and would describe the kind of bias should be taken, the kind of movement which should be done, then maybe see right now if you like in chess, so the great computers they can't be beaten by the humans. So, because there are so many possibilities and there are so many movements, the next move incorporated in them. So if robot becomes far more superior or kind of better than the cardiologist who's doing it, then it may be better to do. But of course, the cardiologist needed next to it, giving orders, see exactly what is being done, and if some complications are there, they are to be handled manually.
Both are available. Points will be given as a first choice as a robot.
It depends on the kind of see, everybody has its mastery or everybody has its plus point and minus point. What kind of vision is there? What exactly we want from the robot? Suppose the cardiologist is not able to stand. Suppose he has got some orthopedic problem and still needs to be operating. Then of course the robot would be a tool because cardiologist can sit and do it in a easy way. So that situation, then robot can do plastic if needed or if must. Or suppose one has to perform the angioplasty in a remote place. Now, in remote place, robot won't be available. But suppose there is a place where the cardiologist is not there, you can't go there. So there is a possibility that the things are actually in place where suppose the angioplasty can be done 3 or 4 or maybe 50 kilometers away with the help of the robotic integrated system where the joystick is at one place and the robot is at another place. So we can actually perform the angioplasty sitting 50 or 60 or more kilometers away from the patient.
The last question. All different
Actually, the robot is around 4.5 CR. The cassette is around 50,000. Procedure cost is the same. The procedure cost is the cost of the cassette. The other thing, the arm is there. The cost of the arm. Everything which needs to change for each patient is the cassette. That is around 50,000. We are not charging anything extra. There's no skill as such. It is just because we want to learn and we want to have the system. We want to develop it as a program. Because initially there was only one robot in India that was available with Dr. Patel and my mother. This was the second robot which was available. And now there are maybe 10 or 15 robots available. Once the whole system develops, there might be good integration that one robotic center can perform the procedures and another robotic center because the robots might be integrated. All these things are future possibilities. As of now it is nothing. It is not very commercial thing which is in practice. It is more of education kind of. Of course,
how many robotic surgeries you have done up till now?
Robotic angioplasty is around 7,500 or I don't have the exact number, but it must be more than 70.
So if anyone has any questions, please contact the speakers personally. We have to move on to the next session. I declare that this session is over.
Thank you, sir.
Okay. For next session, I would like to invite Dr. Rahul Holkar and Dr. Ajay Shah as a chairperson. Please come on the line. Sorry, it's Dr. Joy Shah. And the next session is we start this session with the lecture of Mr. Sudhir Bhagat. Mr. Sudhir Bhagat is investment coach and director of Mahan Finance Service Private Limited, Pune.
Thank you so much. तुमचा मी जास्त वेळ घेणार नाही 15-20 मिनिट्स आज कंप्लीट करेल. बेसिकली माझा जो 25 वर्षाचा अनुभव आहे, इट इज व्हेरी डिफिकल्ट टू एक्सप्लेन इन 20 मिनिट्स, बट आय ट्राय माय लेवल बेस्ट. जो माझा मेसेज तुमच्यापर्यंत जायला पाहिजे तो मी कव्हर करण्याचा प्रयत्न करतो. सेशन इज फॉर द वेल्थ क्रिएशन. देर आर 3 गोल्स. एक आपला बेसिकली आम्ही सांगतो की एज्युकेशनल गोल, रिटायरमेंट गोल, पण त्याच्यापेक्षा पण वरचा जो गोल असतो तो गोल असतो वेल्थ क्रिएशनचा. And if you take an example of Rakesh Jhunjhunwala, then you take any example like Radhakrishna Damani or Warren Buffett. They say that we have gone for the wealth creation, and then wealth creation केलंय. पैसे कमवण्याबद्दल तुम्ही खूप एक्सपर्ट आहात, पण पैसे मॅनेज करणं तेवढंच एक्स्ट्रीमली इम्पॉर्टंट आहे. आणि म्हणून मी अशी आर्थिक साक्षरता, फायनान्शियल लिटरसीचे प्रोग्राम्स IMS साठी भरपूर घेत असतो. तर हे लेक्चर एक इंट्रोडक्शन म्हणून मी तुमच्यासमोर प्रेझेंट करतोय. सेन्सर कुठे? Okay. So this is about me. I have experience of 25 years. For many years I am writing in newspaper on the financial literacy and managing personal wealth. त्याचबरोबर माझे काही कार्यक्रम रेडिओवर कधीतरी होतात आणि जवळपास 300 लेक्चर्स मी फायनान्शियल लिटरसीवर आतापर्यंत घेतलेली आहेत. त्यातली बरीचशी लेक्चर्स IMA साठी पण घेतली आहेत. सो तुमच्यापैकी सगळ्यांना वॉरेन बुफे माहिती आहे? जस्ट क्विक हात वरती करा. माहिती आहे सगळ्यांना? राईट. वॉरेन बुफे 2008 ला जेव्हा फायनान्शियल क्रायसिस झाले, सो त्यांची धनसंपत्ती साधारण $80 बिलियन होती. अ सिंगल इंडिव्हिज्युअल पर्सननी बँकांना बेलआउट केलं. बेलआउट करणं म्हणजे काही बँक्स करणं संपूर्णपणे निष्ठाभूत झाल्या होत्या. एका सिंगल माणसाने त्यांना फंडिंग केलं आणि त्या बँक्स US मध्ये वाचवल्या. आज 99% धनसंपत्ती वॉरेन बुफेटनी डोनेट केलेली आहे. आणि जगातला श्रीमंत व्यक्ती ज्यांनी फक्त इन्व्हेस्टमेंट करून श्रीमंती बनवली तो म्हणजे वॉरेन बुफे. वयाच्या 11व्या वर्षी त्यांनी प्रथम शेअर घेतला आणि इट टू ऑलमोस्ट 40-45 years फॉर हिम टू बिकम वन ऑफ द रिचेस्ट गाय. सो त्यांचं असं म्हणणं आहे की पैसा कमवणं काही पाप नाहीये. म्हणजे एखादा माणूस श्रीमंत असेल तर काही पापी वगैरे नाही. आणि प्रत्येकाचा इथे बसणाऱ्या प्रत्येक माणसाचा नैतिक अधिकार आहे की त्यांनी श्रीमंत व्हायला पाहिजे. कारण चांगल्या लोकांच्या हातामध्ये पैसा आला तर तो फक्त चांगल्या कामासाठी जाऊ शकतो. आणि अजिम प्रेमजी, वॉरेन बुफे, राकेश झुनझुनवाला, राधाकृष्ण दमानी यांच्यासारखे दिग्गज, ॲलन ग्रीन, नंतर यांच्यासारखे दिग्गज टाटा, नारायण मूर्ती यांच्यासारखे दिग्गज बिझनेसमन आणि श्रीमंत माणसं, दे हॅव मेड लॉट मेनी थिंग्स फॉर द सोसायटी. सो प्लीज श्रीमंत होणं हा आपला अधिकार आहे आणि श्रीमंतीबद्दल विचार करा. पैसा कधीच वाईट नसतो. कदाचित पैशाचे मार्ग वाईट असू शकतात, पैसा लाईफ मध्ये कधीच वाईट नसतो. त्यांची कंपनी आहे बर्कशायर हाथवे. मुद्दाम नाव मी कट केलेलं आहे पण कंपनीचं नाव आहे बर्कशायर हाथवे. तर बर्कशायर हाथवे या कंपनीचं एक शेअर घेण्यासाठी तुम्हाला किती रुपये मोजावे लागतील आज अंदाजे? एक शेअर तुम्हाला समजा बर्कशायर हाथवेचं घ्यायचं असेल तर किती रुपये द्यायला लागतील? जी वॉरेन बुफेटची कंपनी आहे US मधली. साधारणपणे 3.5 कोटी रुपये तुम्हाला एक शेअर घेण्यासाठी खर्च करावा लागेल. भारतामध्ये सर्वात महाग शेअर कुठल्या कंपनीचा आहे? MRF चा, राईट. सो तुम्ही विचार करा की बर्कशायर हाथवे आणि MRF मध्ये गॅप किती मोठी आहे. सो दिस इज व्हॉट द वॉरेन बुफेट, दिस इज व्हॉट द US इकॉनॉमी, दिस इज द ग्रोथ ऑफ अ स्टॉक मार्केट or a stock in a US market. सो वेल्थ क्रिएशन साठी सर्वात इम्पॉर्टंट पॅरामीटर आहे ऍसेट अलोकेशन. ऍसेट अलोकेशन म्हणजे तुमच्याकडे समजा 1 कोटी रुपये असतील तर तुम्ही कुठल्या कुठल्या ऍसेट्स मध्ये इन्व्हेस्टमेंट केली पाहिजे. नॉर्मली आपण काय करतो, एखाद्या गुंतवणुकीचा स्टँड अलोन रिटर्न्स बघतो. तुम्हाला तुमच्या कम्प्लीट इन्व्हेस्टमेंटचे रिटर्न्स किती आहेत ते बघायला पाहिजे. आणि बेसिकली asset allocation मध्ये the major component one should allocate is into the equity and equity mutual fund. We'll see why. Okay. Real estate 25%, gold 5% आणि bond FD fixed deposit 25%. हे ideal asset allocation composition आहे. हे सगळ्या काही तज्ञ मंडळींनी सांगितलेलं आहे. सो आयडियली असं असायला पाहिजे, पण अनफॉर्च्युनेटली इंडियामध्ये बरोबर उलट आहे. आणि 90% लोकांची 90% धनसंपत्ती फक्त लँड अँड प्रॉपर्टीज मध्ये आहे. तुम्ही समजा काही दिग्गज इन्व्हेस्टर बघितले, जसं आपण आता वॉरेन बफे बघितलं किंवा राकेश झुनझुनवाला, तर तुम्हाला कळेल की 99% त्यांची इन्व्हेस्टमेंट ही फक्त फायनान्शियल ऍसेट आहे आणि प्रिडॉमिनेटली इक्विटी आणि इक्विटी रिलेटेड प्रोडक्ट्स मध्ये आहे. इक्विटी म्हणजे बेसिकली शेअर्स किंवा मार्केटमधले बिझनेसेस जे आपण बाय करतो. तर तुम्हाला ऑलरेडी माहिती आहे की तुम्ही ऑलरेडी श्रीमंत आहात, तुमच्याकडे पैसा आहे फॉर एक्झाम्पल, तर त्या पैशाची एक्सपोनेन्शियल ग्रोथ होण्यासाठी एक्झॅक्टली काय करायला पाहिजे किंवा वेल्थ क्रिएशन म्हटल्यावर कुठले फॅक्टर्स तुम्हाला प्रॉब्लेम क्रिएट करू शकतात त्याच्याबद्दलच मी थोडक्यात तुम्हाला आज सांगणार आहे. त्याच्यापैकी एक गोल्ड, रिअल इस्टेट आणि फिक्स्ड डिपॉझिट हे वेल्थ क्रिएशनचे रिअल किलर्स आहेत. म्हणजे आपण टोटल तुमच्या ऍसेट मध्ये इन्व्हेस्टमेंट मध्ये बघितलं तर तुम्हाला कळेल की जो जास्तीत जास्त आपल्याला कमवून देतोय, जो आपल्या घरातला मुलगा जो सर्वात जास्त कमवतोय तो घराच्या बाहेर आहे आणि न कमवणारी मुलगा सगळी आपल्या घरामध्ये आपण ठेवली. आणि म्हणून टोटल वेल्थ क्रिएशन मध्ये तुमची त्याला वाढ होत नाही. सो हे 3 किलर्स तुम्ही जर काढले तर तुमची वेल्थ क्रिएशन फास्ट वाढायला लागेल. आणि ह्या तिन्ही गोष्टींमध्ये सर्वात मोठा इश्यू असा आहे की इन्फ्लेशन इज अ सायलेंट किलर. इन्फ्लेशनमुळे ह्या तिन्ही ऍसेट क्लासची ग्रोथ झालेली नाहीये. आता तुम्ही एक एक्झाम्पल गोल्ड घ्या. भारतामधील स्त्रियांकडे आणि भारतामधील देवळांकडे एवढं सोनं आहे, त्यांनी समजा आंतरराष्ट्रीय मार्केटमध्ये ते विकायला काढलं तर सोन्याचे भाव 2000च्या खालती येते. एवढं सोनं फक्त भारतामध्ये. आणि सोन्याचा काहीही उपयोग या कंट्रीसाठी नाहीये. सोन्याला एक इमोशनल व्हॅल्यू आहे. तर इन्व्हेस्टमेंट व्हॅल्यू म्हणून सोन्याने गेल्या 10 वर्षामध्ये इन्फ्लेशनला सुद्धा बीट केलेलं नाहीये. सो तुम्ही सोनं घ्या जे तुम्ही घालू शकता, त्याला इमोशनल व्हॅल्यू आहे म्हणून घ्या. नेक्स्ट जनरेशनला सोन्यामध्ये इंटरेस्ट नाहीये. तुम्ही तुमच्या मुलीला समजा लक्ष्मी रोडवर घेऊन गेलात आणि तुमच्याकडे 50,000 असतील, तिला सांगितलं तुमच्याकडे राईटला ऍपलचं शॉप आहे, लेफ्टला पीएनजी आहे, तर ती म्हणेल मला ऍपलच्या शॉप मध्ये घेऊन जा, मला आयफोन घ्यायचा आहे. तिला तुमच्या सोन्यामध्ये अजिबात इंटरेस्ट नाहीये. आता काही मला डॉक्टर्स भेटतात, त्यांचे मुली 5 वर्षाची 10 वर्षाची असतात आणि म्हणतात माझ्या मुलीसाठी मला दर महिन्याला सोनं खरेदी करायचं लग्नासाठी. आता बेसिकली माझा पुढचा असा प्रश्न आहे की अजून 20 वर्षांनी मुलं लग्न करतील की पण नाही आपल्याला माहित नाही. ती पण पॉसिबिलिटी खूप कमी आहे. काही लोक म्हणतात की माझ्या सुनेसाठी मी सोनं घेऊन ठेवते, मी त्यावेळेस मंगळसूत्र लागेल. ह्या सगळ्या वल्गर आहेत, त्याला म्हणजे काही बेस नाहीये. फ्युचर आहे ना ते फार मोठ्या प्रमाणामध्ये झपाट्याने चेंज होत चाललंय. आणि फ्युचर मध्ये गेल्यानंतर तुमचा मुलगा किंवा मुलगी की कोणाचाही मुलगा किंवा मुलगी घरामध्ये सून म्हणून किरण जोहर आणतो की करण जोहर आपल्याला माहित नाही. तर त्याच्यामुळे तेवढं त्याला व्हॅल्यू त्या दृष्टीने देऊ नका. हा, तुम्हाला वापरायचं सोनं वापरा आणि विसरून जा. आणि सोनं आपण इम्पोर्ट करतो त्याच्यामध्ये आपल्या करंट अकाउंट डेफिसिट आहे कंट्रीच्या, त्याच्यावर खूप मोठा परिणाम होतो. करन्सी व्होलेटाईल होते आणि त्यातनंच तुम्हाला सोनं घ्यायचं झालं तर म्युच्युअल फंड मार्फत किंवा ETF गोल्ड ETF मार्फत तुम्ही सोनं घ्या आणि जास्तीत जास्त त्याचा वेटेज तुमच्या ऍसेट अलोकेशनला 5% द्या. आता रिअल इस्टेट बघा, भारतामध्ये रिअल इस्टेट 90% लोकांकडे 99% म्हटलं तरी सांगितलं तरी हरकत नाही आहे. रेंटल म्हणजे भारतामध्ये येणारं रिअल इस्टेट मधनं उत्पन्न जे आहे ना ते फक्त 3% आहे. आणि आपल्याकडे लोनची कॉस्ट आहे ती 8%च्या वरती आहे ऍव्हरेज. म्हणजे 5%चा घाटा, 5% अॅन्युअल लॉस इज कन्फर्म. सो तुम्ही म्हणजे ते पैसे नुसते बँकेत जरी ठेवले तर तुम्हाला 7-8% व्याज मिळेल. आणि लोन घेऊन रिअल इस्टेट मध्ये इन्व्हेस्टमेंट करणं त्याला तर काहीच अर्थ नाहीये. सेकंड थिंग, तुम्ही रिअल इस्टेट मध्ये जेव्हा इन्व्हेस्टमेंट करता तेव्हा तुमची लिक्विडिटी जाम असते. म्हणजे तुम्ही पेपरमध्ये तुमची नेटवर्थ 10-20 कोटी असते, पण ऍक्च्युअली जेव्हा तुम्हाला पैसे पाहिजे असतात तेव्हा ते अवेलेबल रिअल इस्टेट मधनं होत नाही. नेक्स्ट जनरेशन जिओग्राफिकली मोबाईल आहे, ते एका ठिकाणी थांबणार नाही. तुम्ही 4, 5, 10 फ्लॅट त्यांच्यासाठी घेतले, त्यांना काही इंटरेस्ट नाहीये. आणि तुम्ही घेतल्यानंतर सुद्धा समजा ते अब्रॉड गेले तर त्यांच्यासाठी तो एक मोठा हेडेक आहे. माणूस एकाच फ्लॅट मध्ये राहू शकतो. आतापर्यंत फ्लॅटच्या किमती ज्या वाढल्या आहेत, ज्यांच्याकडे 2 फ्लॅट आहेत त्यांनी 3 घेतले, ज्यांच्याकडे 3 आहेत त्यांनी 4 घेतले, ज्याच्याकडे 5 आहेत त्यांनी 1 विकलाय, म्हणून फ्लॅटच्या किमती वाढल्या. पण जो एंड युजर आहे त्याच्याकडे फ्लॅट नाही, कारण त्याच्याकडे फ्लॅट घेण्यासाठी तेवढी ताकदच नाहीये. सो म्हणून रिअल इस्टेटचा भाव जास्त आहे. अदरवाइज तुम्ही रिअल रिटर्न्स काढले तर दॅट हॅज नॉट इव्हन बिटन अप इन्फ्लेशन लास्ट 15 इयर्स. सो अलोकेट करा, पण तेवढंच करा जेवढं तुम्हाला राहता येईल. सेकंड थिंग, तुम्ही लँड प्रॉपर्टीज ओपन लँड घ्यायला हरकत नाही प्रोडक्शनसाठी, पण तुम्ही इन्व्हेस्टमेंट म्हणून घेतली तर अजून 2-3 वर्ष 2-3 जनरेशन नंतर तुमच्या नावाने फक्त फोटोमध्ये हार घालून तुमचे नातू किंवा बंधू त्या फक्त जागा विकतील आणि तुम्हाला थँक्स बोलत राहतील. त्याच्या व्यतिरिक्त काही होणार नाही. आणि आयुष्यभर आपण फक्त त्याच्या EMI त्या जागा बघून जगत राहू आणि उपभोग त्याचा घेणार नाही. पण फायनान्शियल ऍसेट्स मध्ये भरपूर ताकद आहे. तरी मी रिअल इस्टेट घेऊ नका असं म्हणत नाहीये. दॅट पर्सेंटेज शुड बी व्हेरी रिझनेबल, 20-25%. ओके, सो निगेटिव्ह रिअल इंटरेस्ट हा तुम्हाला अजून एका गोष्टीमध्ये मिळतो, किंवा तुमची ग्रोथ पैशाची होत नाही, ती म्हणजे फिक्स्ड डिपॉझिट. इन माय ओपिनियन इट इज अ फेल्ड डीड. इट इज नॉट ओनली एफडी, इट इज अ फेल्ड डीड. फॉर 5 years तुम्ही एफडीचा व्याजदर कसं वाचता 6%, पण त्याच्याबद्दल तुम्हाला काय करायला पाहिजे की 5% इन्फ्लेशन मायनस करायला पाहिजे. सो व्याजदर किती झालं? 1%. आणि यू पे 30% टॅक्स, किती झालं? निगेटिव्ह. सो व्हेन यू इन्व्हेस्ट इन फिक्स्ड डिपॉझिट, तुम्ही ट्रेडमिलवर जोर जोरात धावताय, तुम्हाला 5 किलोमीटर 6 किलोमीटर तुम्हाला खूप घाम येतोय, उतरून बघितलं तर तिकडेच आहे. मी पैसे वाढणं आणि पैशाचं मूल्य वाढणं याच्यामध्ये फरक आहे. आणि पैशाचं मूल्य तेव्हाच वाढू शकतं जेव्हा तो इन्फ्लेशनला बीट करतो. आणि 5 years I don't think that any fixed deposit going ahead will also beat the inflation. Okay, so FD is what is FD? IRM, GIRM. इंटरेस्ट रेट आला, इन्फ्लेशन घेऊन गेला, बाकी तुमच्या हातामध्ये काहीच नाही लागत. आणि तुम्ही जसं सरांनी सांगितलं की 30% टॅक्स ब्रॅकेट असेल, युअर रिटर्न्स आर निगेटिव्ह, म्हणजे तुमचे पैसे ऍक्च्युअली कमी झाले. सो 5 वर्ष इन्व्हेस्टमेंट करताना ट्राय युअर लेवल बेस्ट टू यू अवॉइड फिक्स डिपॉझिट्स. ओके, अजून 5 वर्षांनी फिक्स डिपॉझिटला फिक्स व्याज दर कुठेच मिळणार नाही, जगामध्ये कुठेच नाहीये, भारतामध्येच आहे. सेव्हिंगचा व्याज दर बंद होईल. सेव्हिंग अकाउंट मध्ये पैसे ठेवायची बँक तुमच्याकडनं वेगळे पैसे घेईल. एफडीचा व्याज दर क्वार्टरली चेंज होईल, तुम्हाला माहिती नसेल, ब्रांच मॅनेजरला पण माहिती नसेल. सो तुम्हाला समजा लॉंग टर्म एखादा कॉल घ्यायचा असेल 10-15 वर्षाचा, तर पहिली चौकडी एफडीला मारा, नो म्हणून. ओके, सो दॅट इज नॉट गोइंग टू हेल्प यू फॉर युअर वेल्थ क्रिएशन. सो गोल्ड तुम्ही अवॉइड करा जास्तीत जास्त घेण्याचं. इन्व्हेस्टमेंट म्हणून सांगतोय मी, पुन्हा सांगतोय इन्व्हेस्टमेंट म्हणून. रिअल इस्टेट तेवढीच घ्या जेवढी तुम्हाला गरजेची, किंवा मॅक्झिमम 25% वेटेज द्या. आणि फिक्स डिपॉझिट महत्वाचं आहे वेन यू हॅव अ शॉर्ट टर्म रिक्वायरमेंट. जसं 1 वर्ष 1.5 वर्ष तुम्हाला पैसे पाहिजे असतील तर तुम्हाला एफडी शिवाय सारखा चांगला पर्याय दुसरा कुठलाच नाहीये. अँड इन्फ्लेशन इज अ सायलेंट किलर. तुम्ही बघा, 1 लाखाची व्हॅल्यू 5,000 रुपयांवर 2020 ला आलेली आहे. 1984 ची 1 लाखची व्हॅल्यू 2020 ला फक्त 5,000 रुपये. म्हणजे विचार करा की इन्फ्लेशन तुमचे व्हॅल्यू किती डिटोरिएट करते. सो तुम्ही इन्फ्लेशनला जोपर्यंत बीट करत नाही तोपर्यंत तुमची वेल्थ क्रिएशन होणार नाही. आता आपण मी अशी म्हटलं, घर तुम्ही घेता, घरामध्ये इन्व्हेस्टमेंट करता. मी सांगतो ठीक आहे, तुम्ही घरामध्ये इन्व्हेस्टमेंट करा, पण व्हर्च्युअली करा, किंवा तुम्ही घराच्या इन्व्हेस्टमेंटला प्ले करा थ्रू स्टॉक्स किंवा इक्विटीज. आता घरासाठी आपल्याला काय लागतं? घरासाठी आपल्याला पिडीलाईटचं फेविकॉल लागतो, अल्ट्राटेकचा सिमेंट लागतो, एसीसीचं सिमेंट लागतं, टाटा स्टील लागतं, बँक लोन घेतलं तर HDFC बँक, ICICI बँक, कजारिया, अशा बर्जर पेंट्स लागतं, फिनोलेक्स लागतं. घर बनवायला ज्या ज्या वस्तू लागतात त्या वस्तू बनवणारे हे लीडर्स आहेत. दे आर द रिअल मॅन्युफॅक्चरर. दे आर ऍक्च्युअली क्रिएटिंग अ रिअल व्हॅल्यू टू युअर प्रॉपर्टी. म्हणजे ज्यांनी फ्लॅट घेतला त्याला इनडायरेक्टली ज्यांनी फ्लॅट घेतलाय त्याला इनडायरेक्टली ह्या कंपन्यांचा सामान घ्यायचंय, त्या कंपन्यांना प्रॉफिट करून द्यायचंय. ओके, आता साधारण हे मी एशियन पेंट, बर्जर पेंट, पेडीलाइट, अल्ट्राटेक सिमेंट, कजारिया सिमेंट, दालमिया सिमेंट, एसीसी, फिनोलेक्स केबल्स, जेएसडब्ल्यू स्टील्स, हे एक्झाम्पल मी तुम्हाला देतोय. या फिगर खऱ्या आहेत पण ऍक्युरेसीची मला 100% गॅरंटी नाहीये. आणि मी असं हेच फक्त नाहीये की तुम्ही हे शेअर्स घ्या म्हणून. कन्सेप्च्युअली तुम्ही बघा की समजा 13 लाख रुपये इन्व्हेस्ट करून मी हे सगळ्या कंपनीचे शेअर्स घेतले असते 10 वर्ष 2 महिन्यापूर्वी, 10 वर्ष 2 महिन्यापूर्वी, आणि त्याची व्हॅल्यू 2022 ला, म्हणजे आता एवढी पण नाही साधारण पकडा, 2022 ला त्याची व्हॅल्यू तुम्ही काढली असती तर एक्झाम्पल घ्या, एशियन पेंटनी 57% रिटर्न दिले, 1 लाखाची व्हॅल्यू साधारणपणे 3 करोड 63 लाख रुपये झाली आहे. अजून एक्झाम्पल घ्या फिनोलेक्स, विच इज नॉट दॅट ग्रेट कंपनी, नो वन नोज की फिनोलेक्स एक्झॅक्टली काम काय करतं, पण कन्स्ट्रक्शन मध्ये अत्यंत महत्वाची कंपनी होती. त्याची 1 लाखाची व्हॅल्यू साधारणपणे 14,16,000 रुपये झाली आहे 10 वर्षामध्ये. टेक एन एक्झाम्पल ऑफ कजारिया सिमेंट, 47% रिटर्न दिले, 1 लाखाची व्हॅल्यू साधारणपणे 49 लाख रुपये झाले. सो 13 लाख रुपयाची समजा तुम्ही व्हॅल्यू काढली 10 वर्षाची, 13 लाख तुम्ही घरासाठी डाऊन पेमेंट दिल्यावर तुम्हाला 1 कोटीचं लोन मिळतं. म्हणजे तुम्ही 1 कोटीचा फ्लॅट घेतला 10 वर्षांनी, तो जास्तीत जास्त मी म्हणतो समजा टाइमचं करेक्शन झालं तर सुद्धा तुम्हाला 1 कोटीचे 2 कोटी रुपये मिळतील मॅक्झिमम. 13 लाख रुपये तुमची व्हॅल्यू 8 कोटी 27 लाख रुपये. सो आय एम नॉट सेइंग दॅट यू डोंट प्ले रिअल इस्टेट, यू प्ले रिअल इस्टेट बट प्ले थ्रू अ प्रॉपर व्हॅलिड गुड क्वालिटी कंपाऊंडिंग स्टॉक्स. सो दीज आर द फ्यू एक्झाम्पल्स. आणि जास्त काही ब्रेन लागत नाही, आपल्याला माहिती असतं की अरे ह्या गोष्टी आपल्याला वापरल्या नाही तर आपलं घरच बनणार नाहीये. सो दिस इज conceptually what I'm saying, to give higher weightage to the equities. तर लाला 1980 मध्ये लाला आला, लाला काही फार्मर्सना म्हणाला की 10,000 रुपये आमचे शेअर्स तुम्ही घ्या आणि 10,000 फेस व्हॅल्यू आहे आणि त्यांना 100 शेअर्स आहेत, 10,000 रुपये, 100 रुपये फेस व्हॅल्यू आहे, 10,000 रुपयाचे शेअर्स घ्या. तर 10,000 रुपयामध्ये 100 रुपयाच्या व्हॅल्यू प्रमाणे 100 शेअर आले 1980 ला. 81 ला लालांनी एकाच एक बोनस दिला, द नंबर ऑफ शेअर्स रिच टू 200. then 85 ला लाला गे बोनस 1:1 अगेन 400 शेअर झाले. 86 ला लालांनी परत स्प्लिट केला स्टॉक, 100 रुपयाचा स्टॉक 10 रुपयाला केला, 4,000 शेअर झाले. 87 ला परत बोनस मिळाला, 8,000 शेअर झाले, 10 रुपयाचा शेअर होता एक. 1989 ला परत एकाच एक बोनस दिला, 16,000 शेअर झाले. 92 ला एकाच एक बोनस दिला, 32,000 रुपये, 32,000 शेअर झाले. 1995 ला 32,000 चे 64,000 शेअर झाले. 1997 ला साधारणपणे 1,92,000 शेअर झाले. 1999 ला 9,60,000 शेअर झाले. परत स्प्लिट केला म्हणजे 10 रुपयाचा एक शेअर 2 रुपयाला गेला, त्याच्यामुळे नंबर ऑफ शेअर्स परत वाढले, 9,60,000 शेअर झाले. 2004 ला 28,80,000 शेअर झाले. 2005 ला 57 लाख शेअर झाले. 2010 ला 2:3 बोनस दिला, 96 लाख शेअर झाले. 2017 ला एकाच एक परत बोनस दिला, साधारणपणे 1 करोड 92 लाख शेअर झाले. आणि 2019 ला विच वॉज द लास्ट नंबर दॅट आय रिमेंबर, आणि पुढे पण अजून असतील नंबर्स, तर एकाच 3 बोनस दिला, 2 कोटी 56 लाख शेअर झाले, 2 रुपयाचे एक शेअर. ह्या कंपनीचा आजचं साधारण मार्केट प्राइस 393 रुपये, म्हणजे 2 रुपयाचा शेअर 393 रुपयाला आहे. 10,000 रुपये इन्व्हेस्टमेंट केली होती, गेस किती रुपये अंदाज झाले असतील? इट इज मोर दॅन 7,000-8,000 crore. So this company is Wipro. The Lala is Azim Prem. So एक फार्मर अजून आहेत, त्यातले काही फार्मर अजून आहेत, डेफिनेटली आहेत. कुठे आहेत? आपल्या महाराष्ट्रात आहेत. कुठे आहेत? अमळनेरला आहेत. सो अनफॉर्च्युनेटली मला 20 minutes झाले ना. हा, सो अनफॉर्च्युनेटली वी हॅव नॉट गिवन एनी वेटेज टू इक्विटी. गिव्ह वेटेज टू इक्विटी. इक्विटी इज लाईक अमिताभ बच्चन. भारताची स्टोरी अनलिमिटेड आहे. भारतामध्ये 125 कोटीची लोकसंख्या आहे, 33 कोटी देव आहेत. आपल्याकडे प्रत्येक 2.5 माणसांच्या मागे एक देव आहे आणि म्हणून इन्फ्रास्ट्रक्चरची डेव्हलपमेंट माइंड ब्लोईंग इंडियामध्ये होणार आहे. 12 LNT कमी पडतील एवढी इन्व्हेस्टमेंट इंडियामध्ये होईल. भारतामध्ये 1 कोटी लोक लग्न करतात, म्हणजे साधारणपणे 2 कोटी लोकांचे लग्न होतात. 100 लोक ऍव्हरेज जेवली तर 200 कोटीचं फक्त लग्नाचंच लोक जेवतात. एवढी तर चायनाची पॉप्युलेशन नाहीये. त्याच्यामुळे इंडियाच्या ग्रोथ स्टोरीवर तुम्ही पूर्ण विश्वास ठेवा. तुम्ही ऍज अ डॉक्टर मी तुम्हाला हंबल रिक्वेस्ट करतो. I meet so many doctors. The cash component is actually a killing component. It's a dead component. From bottom of my heart, I'm requesting you to convert everything into the white. You have ample opportunities to make money. आणि तुम्हाला चांगली झोप लागेल. आता ऑडिट माझ्याकडे 4 चार्टर्ड अकाउंटंट क्लायंट्स पण आहेत. त्यांनी सांगितल्याप्रमाणे लाईफस्टाईल ऑडिट खूप जोरात चालू आहे. देर इज नो एस्केप नाव. 10 वर्षांचं सिच्युएशन पूर्ण वेगळी असेल. तुम्हाला जे शॉर्ट टर्म मेजर आता आवडतात ना, ते लॉंग टर्म मध्ये खूप धोकादायक आणि त्रासदायक आहे. तुमचं 30% टॅक्स वाचवेल, पण 70% तुमचा लॉस घेऊन जाईल. सो प्लीज ट्राय टू मेक complete white practice so you get a good opportunity to invest in equity, because equity is only asset which can create a wealth for you. तुमचं चांगल्या प्रकारे ऑलरेडी वेल्थ असेल तर मी सांगेन तुम्हाला की तुम्ही पूर्णचे पूर्ण पैसे इक्विटी म्युच्युअल फंड मध्ये इक्विटीमध्ये टाका. यू मेक लॉट ऑफ मनी. ओके, माझी काही आर्टिकल्स नंतर पाठवून देईन सरांकडे वगैरे. राजाबाबू म्हणण्याचा साधारण प्रयत्न करू नका. वी कॅनॉट हँडल सो मेनी रोल्स इन लाईफ. So try and appoint a good financial advisor which can help you, So who can help you for a good wealth creation. The message is that try to underweight gold, fixed deposit, real estate, and overweight equity as a component to create wealth. Trust me, तुमच्या प्रत्येकाकडे एवढी कॅपेबिलिटी आहे की तुम्ही येणाऱ्या 10 वर्षामध्ये वर्स्ट कंडिशन मध्ये 10 ते 15 करोड फायनान्शियल ऍसेट्स बनवू शकता. वर्स्ट सिनेरियोमध्ये 7 वर्षामध्ये भारतामध्ये एवढी ग्रोथ स्टोरी जबरदस्त आहे, पूर्ण जगामध्ये नाहीये. साधारण तुमची वेल्थ वर्स्ट कंडिशन मध्ये पुढच्या येणाऱ्या 7 वर्षामध्ये इक्विटी म्युच्युअल फंड मध्ये 12% कंपाऊंडिंग ग्रोथ देऊ शकेल. सो हा माझा नंबर आणि ईमेल आयडी आहे. माझ्याकडे 80% क्लायंट डॉक्टर्स आहेत सगळे, आणि साधारण 128 कोटी मी मॅनेज करतो. 3 वर्ष झालं मला कंपनी फॉर्म करून. तुम्हाला कधी कोणाला अपॉइंटमेंट हवी असेल तर मी आनंदाने येईल. इन्व्हेस्टमेंट करणं मॅन्डेटरी नाही, कोणाला फोन येणार नाही. पण तुम्हाला फायनान्शियल प्लॅनिंग करायचं असेल, वी डोंट चार्ज एनिथिंग, काही चार्ज नाही करत. इफ यू आर कम्फर्टेबल वी कॅन गो अहेड, असोसिएट. अदरवाइज विल हॅव अ गुड टी अँड कॉफी. थँक्यू सो मच. थँक्यू.
And I will like to invite Mr. Subendu Harishchandran. Mr. Subendu Harishchandran, please. He is Executive Director of Anand Rathi Wealth Limited.
Good afternoon. Can I start? Good afternoon, everyone. So he has explained a lot of things about wealth creation. What I would try and do is to tell you what is the first step towards that wealth creation. So primarily, as a Anand Rathi wealth management company, we are 25 years old company. We are a listed company both in NSE and BSE. We are a 3,000 market cap company. Today, the objective here to meet all doctors is to understand what is the health of your wealth. So I would address 2 things. First is what is the first step in creating wealth, and second step, what is the health of your wealth. The first step is traditionally what happens, whenever we have some money which we get by way of practice, especially the professionals, or by way of salary if he's working with a particular hospital, then after getting money in the bank account, traditionally we try and find that should I put this money into fixed deposit, should I put this money into real estate, should I put this money into gold, or should I put this money into
equities, etc. So over a period of time, what happens that we sort of collect various of this asset class which is available in the market, and then after 10, 15 years, we sort of see what is the wealth I have created out of this collection of various products which was available then to me. Maybe recommended by a friend, maybe recommended by a financial consultant, or maybe recommended by a LIC agent. Right? This is the traditional way how we look forward to the journey of our wealth creation. However, when we say wealth management, there are two words to wealth management. First is understanding what is your wealth, where do you stand, and bring the process of management. Correct? So what is your wealth? For every individual, it is important to understand what is the sum total of money you have accumulated into various asset class, be it real estate, be it gold, be it fixed deposit, be it any place where you have put your money into. Once you understand, four important questions will come to your mind, or you should ask this four question once go back from here. First, if I keep everything as it is where today, what would happen to this money in next 10 years? Yeah, which is nothing but expected rate of return out of the money which I have accumulated. Right? That's the first question we need to ask ourselves. Second question we need to ask, what is the risk associated with this expected rate of return? Which means, let's say I have accumulated 100, whether this 100 is going to become 200, 400 or 800 in next 10 years or not. If it is, then what risk am I taking? And that risk is calculated mathematically and not in English. We should not look forward to see that whether I'm taking a medium risk or I'm taking a low risk or I'm taking a high risk, because those English words are different for everybody. What we need to see, and all the professionals here sitting, you understand what a standard deviation is. That this is what I'm expecting. I could deviate this way or this way, which is a mathematical number. That is point number 2. Point number 3 is liquidity. If I want this money, how quickly am I accessible to this money? Yeah. For example, land. If you need a particular goal or an objective to be fulfilled, can I get money in my bank account the very next day? No. Correct? So therefore, the third thing we need to examine in our investment balance sheet is liquidity. Yeah. Fourth, pre-tax and post-tax return. What is the tax implication to the balance sheet which I have formed? Be it, all the asset class which is available. So in India, there are only 4 asset class which is available for us to invest money into. First is fixed deposit. Second is gold. Third is real estate. Fourth is equities. Beyond this, I don't want to talk about bitcoins today. Yeah. So therefore, when we say that all these 4 things are the constituents of our balance sheet, examination of these constituents are very, very important, and the first step towards the journey of wealth creation in next 5 years, 10 years down the line. Yeah. To understand this, let me quickly play a small AV, and after that I'll be happy to take questions and share you how a balance sheet looks like. Yeah.
do, I'll quickly share you what should be the starting point for everybody to examine what is the health of the wealth which you are. You could see, you just have to take pen and paper and put everything as it is, how much you hold in direct equity, private equity, PMS, ULIP, insurance policies, fixed deposits, PF, everything put together. Then for every money which you are holding, there will be an expected rate of return. PF will not give you 12%, it will only give you 8.1%, right? A fixed deposit will not give you 15%, it will only give you 6%. So when you put everything against the amount which you hold today, and when you sum it like a weighted average, expected weighted average return, you would understand at what rate my money is growing. If it is not growing beyond 12%, then you are actually eroding your money which you have accumulated over a period of time, right? So this is the first step, everybody here who wants to have that journey of next 10 years in wealth creation must have. And then the second and the third and the fourth step is equally important, which is what is the risk, what is the liquidity, and what is the tax to this, because every component of the balance sheet of yours has a different tax implication. Yeah. So everything has a mathematical answer. I'm sure every doctor sitting here study very, very hard, because my dad is a doctor, so I understand what kind of study you would have gone through. Yeah. So for your personal investments, you have to apply all this mathematical aspect, and then only you would be able to get the answers which you think would be very, very great in next 10 years, 15 years down the line. The setting up objective after this is important, that at least every 5-year cycle the money should double, the balance sheet should double. Yeah. How do you set up the objective? When you are bringing the objective or the management aspects to the wealth, setting up objective is the first step. Yeah. The objective should be that every 5.5-year cycle the balance sheet should double. Yeah. Then when you are creating wealth, it is important that you are likely to consume some portion of money during your lifetime, and some portion of money is likely to go to the next generation, right? So it is important that a legacy plan is prepared. One of the things which we said, 19,000 crores of money, which is lying in various places like banks, like insurance companies, because there are no nominations, there are no will written by us, and therefore all this money are lying there. Yeah. So it is important to have creation of wealth and then take it to the next level, which is giving it to the next generation without having any leakages in between. Right. So these are the two important aspects we thought is important and highlight it to all of you. Thank you very much for allowing us the opportunity to meet. Thank you, IMA. Yeah, if anyone has a question.
Thank you.
Yes, ma'am. Yes.
Generally, insurance is not investment.
Absolutely correct. Yes.
So what ULIP will
So everyone will have their balance sheet. It is not what we are recommending.
Yeah.
It is what you have, ULIP. And you are right in saying that the ULIP is not a wealth creation instrument. It is a risk mitigation instrument. But first we need to understand, or everybody sitting in this room needs to understand where their money is lying today. Because you will have different investment, sir will have different, I will have different investment.
Here's an FX fund, which is best.
I think in India, both of them you should not invest, because there is still huge alpha creation by professional fund managers. Therefore, ETF and EA. If very, very mature markets like US, you go, 98% of the mutual funds don't create that additional return vis-a-vis the index. But in India, there is huge scope of creation of that 2 to 3% more than that of the index. Therefore, you should avoid and choose right funds. Yes, sir.
Talk of design.
Yes, sir.
Example.
Right, sir. On your? Yeah. Correct. 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 Yeah. Yes. It is a bad investment. You should change your advisor. It is a bad investment. Yes. Yes.
Thank you. Now,
Yes.
I think many would think in terms of retirement. You have not touched on that. I'll ask you one question. If your expenses are going to be, say, 1 lakh per month, retirement, what should be your amount from which you can get 1 lakh per month without eroding your principal?
So, two things, sir. We need to first, calculate that what is the accumulation I have done. And the question which you're asking that if I need just 1 lakh, we need to sit and see and take the assumption on the inflation. That 1 lakh, what would be the value of the purchasing power of that 1 lakh every year, which I need to account for, because that same I cannot use after 5 years. It is going to be more, right? So we just need to make that calculation. But broad number, if you ask me, somebody has 2 to 3 crores of money, it is good to go. But the most important aspect of inflation in India is going to be healthcare expenses. So I would say that everybody sitting here have a brilliant bright future, because the maximum amount of money is going to be spent in healthcare, and the highest inflation is there in healthcare.
thank you. Now, I request Dr. Rahul Holkar to please felicitate Mr. Subendu Harishchandra and Dr. Joy Shah to felicitate Mr. Sudhir Bhagat. Okay. There is only one lecture remaining before lunch, so please be seated.
Friends, I am Dr. Pingle, President IIMS. Sorry for interruption, but I have to hand over the award of Dr. Asha Dadav, Best President among big branches. So please bear with me for a minute.
Sir.
Has been a very dynamic and very active president of big branch, Kolhapur branch, and done so many programs under her presidentship, not only CMEs but also public health, especially during the deluge in Kolhapur and areas around. Thank you very much. We are a lot of women.
Support. You supported me so much, so I could do this. Actually, I dedicate this award to him.
Right. 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 She is not only a surgeon, she is a surgeon. Okay. Right.
Now, I request Dr. Pandita Vattamwar, please come upon the stage. Only one lecture remains. Dr. Pandita Vattamwar, consultant, interventional neurologist and epileptologist. He is done his MBBS from Mumbai, MD from Sotapur, DM Neurology from Trivandrum, and PD of Epilepsy from Trivandrum. Currently, he is practicing in Aurangabad. Please welcome Dr. Vattamwar.
So, thank you very much. I will not take much time. I will directly go to my
talk. It's lunchtime and we are already getting late. So in neurology, few years back, maybe 10-15 years back, most of the neurological disorders, especially the stroke, IC bleed, that you had a very realistic approach. Okay, stroke ho gaya, okay, what drugs we used to give is Manitol, Dexa, and whatnot. And the patient was left alone for his recovery and all that. But in last 10-15 years, it has revolutionized significantly. The treatment, the approach has changed. The interventional neurology, the concept started in 1980s, but because of rapid advances in neuroimaging, like advancement of in DSA, roadmaps, 3 rotational angiography, and also with the development of the revolutionary medical devices, it has become a treatment of choice for most of these neurovascular diseases. So these neurovascular diseases can be ischemic or hemorrhagic. So I will go case by case to depict how the intervention has changed the management. Coming to ischemic neurovascular diseases first. This first case, 67-year-old male presented with history of acute onset weakness in left upper limb and lower limb. 6 hours prior to he presented to the hospital, he had severe dysarthria and left hemiplegia that was grade 0. This was MRI. You can see, in fact, in the internal capsule on the right side, as the patient was in 6 hours after the onset of the symptom, he was not an ideal candidate for intravenous thrombolysis because it is given only up to 4.5 hours. And his MR angio was normal, so neither he was a candidate for mechanical thrombectomy, where if the major vessel is occluded. So in this case, if we give intravenous thrombolysis, the chances of bleed is very high. So we decided to go directly into the cath lab and give intra-arterial thrombolysis. Intra-arterial thrombolysis is given after the window period for intravenous thrombolysis, and if mechanical thrombectomy is not required. So why it is given intra-arterial? Because the dose of thrombolytic agent is required is very less, and hemorrhagic complications are significantly low. After thrombolysis, this is the next day morning. Patient was conscious of in command. There was no dysarthria. There were no focal neurological deficit, and patient could be discharged after 4 to 5 days. So this is the result of intra-arterial thrombolysis. I will go to next case. 58-year-old male presented with he had a history of mitral infarct, for which he was thrombolized outside, and 1 week later he had acute onset weakness in right upper limb and lower limb, and he presented 3 hours after the onset of the symptoms. He had global aphasia and he was quite drowsy. Now in this patient, he underwent MRI. MRI showed right MCA, middle cerebral artery evolving infarct with right MCA total occlusion. Now he had already underwent thrombolysis for 1 week back. Now again giving thrombolysis is not recommended. So straight away patient was shifted to intravenous thrombolysis was not possible. Patient was shifted to cath lab, and here you can see DSA. Here this MCA is totally occluded. We decided to go for mechanical thrombectomy. The micro wire and the catheter was crossed across the occluded segment of the MCA, and this is the catch device which extracts the thrombus was placed, and after 1 pass there was complete recanalization of the MCA, and patient started improving on table and improved significantly over a period of 3 to 4 days. Except for mild word finding difficulties, there were no focal deficits. He underwent coronary angiography and angioplasty 2 weeks later. This third case, 31-year-old male presented with acute onset weakness at left upper limb and lower limb, grade 0, and patient reached within 30 minutes. So MRI showed evolving right MCA territory infarct, and the DSA showed right MCA total occlusion. And this patient also underwent mechanical thrombectomy. With a single pass, the artery could be opened completely. So there was a thrombus in the MCA, and this thrombus was extracted, and there was complete recanalization. And this was the next day morning. There were no focal deficits. Patient was conscious over it. The first case of mechanical thrombectomy presented 3 hours after the onset, and this case presented 30 minutes after the onset. So the time is gray in patients with acute ischemic stroke. Earlier we intervene, the less likely is the disability, and the complete recovery is possible if the patient presents early. So this was another case, 60-year-old male patient, acute onset giddiness, vomiting, altered sensorium. BP was quite high, unconscious, NIH score was quite high. So patient was intubated for airway protection, immediately shifted to cath lab, and patient had basilar occlusion, the posterior circulation stroke. Here, he also underwent mechanical thrombectomy, and patient was extubated 2 days later and discharged on 5th day. So posterior circulation stroke, here the disability is very high. Not only disability, mortality is also very high. But because of mechanical thrombectomy, patient could walk home after the 5 days after the onset, and this is at the time of discharge. Another case, 43-year-old male, acute onset slurring of speech, imbalance while walking, mild right-sided weakness. This patient had presented 12 hours after the onset of the symptoms, and MRI showed few infarcts in the pons and bilateral cerebellum. The basilar was totally occluded. In spite of being 12 hours after the onset of the symptom, we went for mechanical thrombectomy because the window period for posterior circulation is more than 12 hours, sometimes up to 24 hours. And here you can see there was a stenosis. The next day morning, patient deteriorated. And again, we went inside the cath lab. Patient, again, mechanical thrombectomy was done, and we had to put a stent in the basilar artery. And this is after the angioplasty, we could see. And this is 1 month later, except for mild dysarthria and mild gait instability, there was no focal deficit, and patient was quite all right. So clinical pulse from these few cases is, in first 4.5 hours, intravenous thrombolysis is the treatment of choice. If there is a large, what options we have is altiplase, and now the tenecteplase is also been approved for intravenous thrombolysis. After 4.5 hours, what option we have is mechanical intraarterial thrombolysis or mechanical thrombectomy. But if the patient presents within the window period for intravenous thrombolysis, if there is a large vessel occlusion, the mechanical thrombectomy is the treatment of choice. The window period for anterior circulation is up to 8 hours, but depending upon the penumbra, we can extend up to 10 or 12 hours also for anterior circulation. But for posterior circulation, depending upon the penumbra, we can go inside and do the mechanical thrombectomy or angioplasty even after 24 hours. So it decreases the mortality and morbidity. So this next case, 78-year-old male presented with a history of chronic smoker and hypertensive, recurrent episodes of left-sided weakness. The MRI showed watershed infarcts in MCA and AC territory. MR angio there was total occlusion of right ICA. But in spite of total occlusion, what we thought we will go for DSA. DSA showed it was not a total occlusion, but it was a very tight severe stenosis. And because of that, patient had watershed infarcts on the right side. After discussion with relatives, patient underwent right carotid angioplasty. And after this angioplasty, there were no further episodes. So whenever there are watershed infarcts, we should suspect carotid disease, and MR angio should be done. In all cases, not only intracranial but also neck vessel angiography should be done.
Many times, MR angio can either overestimate or underestimate the stenosis. In this case, the MRI showed a total occlusion, but it was not a total occlusion, but it was a severe stenosis. And DSA is the gold standard for diagnosis of this vessel disease. Carotid angioplasty can be done in patients with symptomatic carotid disease if it is more than 50% stenosis, and it can be done even if it is asymptomatic if the stenosis is more than 70%. And if it is safe even in elderly as it is minimally invasive. Next case, 58-year-old female had recurrent episodes of posterior circulation strokes. We did DSA in this patient through radial, by radial route because she had significant fungal infection in the groin and femoral puncture could not be done. Radial vertebral artery showed a 98% stenosis at ostium, and through radial route, patient underwent radial right vertebral angioplasty and stenting. Now, many of the interventional procedures, neurological, can be done through radial route as well. And this was the first case in our region. Next case, 43-year-old male, known hypertension, diabetes, recurrent right hemiparesis on dual antiplatelet, had right mild upper limb drift, and he had a left MCS severe stenosis. So now he was on adequate medical management. Still, after that, he was getting recurrent episodes of stroke. So he underwent DSA. There was tight stenosis in the left MCA. We decided to go for MC angioplasty and stenting. This is the stent deployment, and this is the images after the stenting. There was complete recanalization, and after this procedure, there were no further episodes of ischemic strokes. So, intracranial atherosclerotic disease. This is the one of the commonest cause of stroke in Asia and as well as in India. Intervention is required, is usually done only if the patient is symptomatic in spite of best medical treatment, or if there is more than 70% stenosis in the symptomatic territory. The interventional procedures can be offered for middle cerebral artery, vertebral artery, basilar artery. Coming to hemorrhagic strokes, so this is 30-year-old male, acute severe headache and neck stiffness. So it's classical presentation of subarachnoid hemorrhage. He underwent DSA. This is the rotational 3D angio. Here you can see an aneurysm in the anterior communicating artery, and we decided to go for coiling. Now the coiling is much safer than clipping, where you don't have to open the skull. Keep a flap in the abdominal wall or thigh. Here, this is the patient underwent balloon-assisted coiling, and this is the post-coiling which runs complete obliteration of the aneurysm. And as it is least invasive, no craniotomy is required. Patient can be discharged as early from the hospital as possible. Next case, 56-year-old female, acute onset headache and vomiting, had one episode of seizure. On examination, there was no neck stiffness. And again, this is another case of subarachnoid hemorrhage. Patient already had a DSA at another hospital, conventional DSA that was reported as normal, but we went ahead for another DSA. This is the rotational angio. Here you can see the rotational angio. There is a blister, small blister aneurysm that was the source of bleed in her case. For blister aneurysm, we cannot coil, we cannot clip. The only treatment option is flow diverter stenting. And patient underwent flow diverter stenting, and this is the images after the flow diverter placement. And 3 months follow DSA. There was no blister. Patient recovered completely. Another case, 67-year-old, acute severe headache, vomiting. The patient had third cranial palsy and mild left hemiparesis. CT scan showed small hematoma in the crux of the midbrain on the right side that was causing the third lobe palsy and left hemiparesis. Now you can see this bleed is quite, the location is unusual, less common. So to understand why he has bled in that location, he underwent DSA. The DSA showed a PCOM aneurysm, wide neck PCOM aneurysm. The wide neck PCOM aneurysm.
Whenever there is a wide neck, the options are balloon assisted coiling or stent assisted coiling. The patient underwent stent assisted coiling. This is the deployment of the stent, and then coils were placed inside the aneurysm. And this is the post-coiling run. So there is complete obliteration of the aneurysm. Another case of giant paraophthalmic artery, giant aneurysm, which patient underwent stent-assisted coiling. So in distal aneurysm, we use triaxial system. We use triaxial system to help for the stability. One catheter is placed in the MCA for a stent, another microcatheter is placed into the aneurysmal sac for putting the coils. This stent is being deployed across the neck of the aneurysm. Stent is deployed, then after that, the aneurysm sac coils are being deployed. In stent-assisted coiling, we need to be careful that the aneurysm sac should be packed completely. Otherwise, recanalization of aneurysm is possible. So the aneurysm sac is packed completely now, and the aneurysm is completely obliterated. So next case, 65-year-old female presented with acute onset headache and vomiting. CT scan showed subarachnoid hemorrhage. And this is the DSA, 3D rotational DSA, a basilar artery, and top of the basilar artery, there is aneurysm, basilar top aneurysm, and this is very complex aneurysm. Why complex? Because both bilateral posterior cerebellar arteries are arising from the dome of the aneurysm. From the dome of the aneurysm. In such cases, the treatment is quite difficult, both surgically. Posterior fossa is very difficult to approach. Clipping is difficult. Putting a flow diverter is difficult. The basilar top aneurysm. So the newer device have come, like contour device, and the patient has had underwent contour device placement inside the sac of the aneurysm. This device is like this inverted umbrella-like device, which are deployed inside the sac of the aneurysm, which spares the branches and doesn't occlude the branches. Here you can see the device. The aneurysm is completely occluded, and all the branches are filling properly. So this was the first contour device which we did in our region. 67-year-old female, acute onset severe headache. She was drowsy, had left bite weakness. Again, CT scan showed severe subarachnoid hemorrhage. The DSA showed a very large aneurysm with wide neck. Whenever there is such kind of large aneurysm with wide neck patient presents, the treatment options are stent-assisted coiling or flow diverter assisted coiling or clipping. Clipping is very difficult in such cases. So whenever we put stent or flow diverter, patient needs to be loaded on antiplatelet. And on one hand, patient has bled. Another hand, we want to put a stent and patient needs to be loaded on antiplatelet. So the timing of the intervention is very critical in such patient. In this case, we thought we should wait for intervention. After 10th day, after the bleed, patient developed severe vasospasm, which was managed with imodipine and milrinone. Patient was intubated because of adult sensorium, because of vasospasm. And once the patient got stabilized, improved, became again alert, conscious, extubated, then patient underwent FD assisted coiling. Here you can see the ICA was quite tortuous. In this tortuous anatomy, triaxial system is very helpful for the stability of all the wires and microcatheters. This guiding is being placed in the distal internal carotid artery. One micro wire is being placed in the MCA for placement of the deployment of the flow diverter, another microcatheter into the aneurysm sac, and flow diverter is being deployed across the neck of the aneurysm. I don't know whether you are able to see the flow diverters.
20 minutes.
Yeah, just finished. And coils are being deployed. With flow diverter assisted coiling, the most important aspect is flow diverter itself diverts the flow of the blood away from the aneurysm. So in such cases, we need not pack the aneurysm completely because it already diverts the flow away from the aneurysm. You can pack it loosely. In these cases, loose packing is also enough. And this is the final run. And this is the outcome. No focal neurological deficits. So clinical pulse from these cases is DSA is the gold standard. Aneurysm coiling option depends upon the size, location, and the neck. The options are single microcatheter coiling, balloon assisted coiling, stent assisted coiling, flow diverter assisted coiling, and newer devices in complex aneurysm and parent artery sacrifice in some cases. This is the last but one case, 19-year-old female presented with intracranial bleed. DSA showed AVM in the left frontal region. Patient underwent embolization of this AVM, and this is the treatment of choice for intracranial AVMs and neural fissulas. This is the post embolization images. This is the cast, and this is the clinical outcome. No focal deficits. The last case, 80-year-old male. No, I will skip this case. This is the case of spinal neural fistula. Patient presented with acute onset paraplegia. MRI showed a long segment demyelination, but there were multiple flow voids along the spinal cord. And this is the neural AV fistula in the spinal canal. And this was immobilized with 20% glue. And this was the outcome. 3 months follow-up, there were no significant focal deficit except for mild spasticity in the lower limb. So interventional has given whenever there are non-hypertensive hemorrhages, always suspect underlying aneurysm, AVM, fistula, or DSA is the gold standard. This is the last case. 60-year-old male presented with history of head injury, nasal bone fracture, and improved. But 2 weeks later, he had swelling of the right eye with diminished vision in the right eye, and this was the picture. The right eye swelled up. The carotid cavernous fistula was suspected. Patient underwent DSA. There was a direct carotid cavernous fistula. Patient underwent embolization of the fistula. This is the post-embolization images. So this is the before embolization and after embolization. So complete recovery with sparing of the vision. Thank you. So most of the now the open surgery clipping has become day by day, it's becoming more and more obsolete. Most of the cases can be managed with interventional procedures. Even complex aneurysms can be treated nowadays with intervention. Thank you.
Thank you. I request Dr. Shah to felicitate Dr. Pravala. Yes. Dr. Shah and Dr. Holger. I request Dr. Garu to felicitate Dr. Shah and Dr. Holger. It's meal time now. We will meet after 20 minutes. Enjoy your meal. Thank you.
Oh.
A very good morning to all. Very good afternoon to all. I would like to request Dr. Bhekar and Dr. Vardan, please come on the dais as a chairperson. And I also request Dr. Rathod, please come on the dais as a chairperson. Request Dr. Nagarkar to please come on the dais to present his lecture. Dr. Professor Raj Vasan Nagarkar, Managing Director and Oncology and Robotic Service, HCG Manavta Cancer Center, Nasik, a competent professional with nearly 21 years of experience in the field of oncology. Dr. Raj has been serving the entire nation, especially the Maharashtra region, in all avenues of oncology.
Just trying to, no wonder how much you try for technology, but sometimes you have to depend on human interference. So even though we just try and fix the laptop in my control, because I do not wish that he runs the videos and I try to talk from him. Thank you, Uday sir, for giving this wonderful opportunity. And it's a pleasure to be in this place. And as part of MASTACON, I will be talking about the place of robotic surgery as part of a surgical armamentarium.
is fixing up. Just for the sake of discussion, I recollect 3 years ago when I started my robotic surgery practice. After being involved in surgical oncology for almost 2 decades. So one of my senior anesthesia colleagues with whom I started my practice in Nasik, who was there involved with me. So I requested sir that sir, for my first robotic surgery, I wish that you should be in the theater and bless me that I am embarking on a new journey. He said की राज सगळं चांगलं आहे पण मला वाईट वाटतंय की आता पेशंट्स एका चांगल्या सर्जनच्या सर्व्हिसेसला मुकणार आहे. सर मला असं का वाटतंय की आता तू ऑपरेट थोडीच करणार रोबोट ऑपरेट करणार. So then I think I will change the sequence of my slides. How many of you all feel that robotic surgery at this point of time is a part of the master-slave technology? Master-slave technology means wherein we say that the robot is actually a slave in the hands of the surgeon. As of now, we always feel that the robot doesn't perform anything independently. The surgeon is one who is taking care and the robot is a mere slave in the hands of the surgeon. However, STAR is actually coming up to change that scenario. We are talking about smart tissue autonomous robots also, which are there. And this is not today. The first publication for this thing came in 2016, where they realized that when it comes to soft tissue surgeries, the independently performed autonomous robot does surgery much better than skilled surgeons. So with the invent of AI, with the invent of artificial intelligence coming in, I think it is going to be a major thing. And even when it comes to intestinal anastomosis, they found out intestinal anastomosis done by AI-enabled robotic technology is much better as compared to human hands. So, in fact, today morning, I did 2 surgeries, and I had two surgical colleagues who had come from Israel. And I did 2 laparoscopic surgeries using a 270-degree scope. The first scope in the world, which is a 270-degree scope, and I am very happy that in India, the first 2 surgeries which have been done by me today morning in Nasik. So technology is there, and technology is really going to change the way in which surgery has been thought about or practiced. But we have moved ahead from the era of freehand surgeries to minimal invasive surgery to robot-assisted surgery. And as I said, that tomorrow's era is going to be micro-robotics. Earlier, we used to feel that trying to anastomose one artery or one vein would be a big challenge. But now we have colleagues, like we have a surgical colleague, a Nasik product proudly, but we know now he's become a Mumbaiker, who has done hand transplants. We have Amol over here who does fantastic liver transplants. In fact, the first heart-lung transplant in Maharashtra was done in Pune. So life is really taking a different turn, and if one is not aware about the advances which are going on, then one really needs to keep up to the pace. In fact, in oncology, we say on a daily basis, there are 365 new publications. Publications means path-breaking publications, which can actually change the way in which you should be thinking of changing your patient-related care. They said that we till date, when it comes to minimal invasive surgery or open surgery or robotic surgery, we have been following the master-slave system, wherein all technology is a slave in the hands of the surgeon who is the master, and the robot or the laparoscope cannot think for itself. It cannot do anything independently. The surgeon has to take care of it. If you look at the timelines of robotic surgery, the first robotic surgical procedure, which was a robot-assisted brain biopsy, was done in 1985. from 85 till 2020 when CMR launched robot. Now in India, SS Mantra, Dr. Sudhir Srivastava, cardiothoracic surgeon from All India Institute of Medical Sciences, has made the first Make in India robot as a part of Make in India initiative. So there are so many new things which are coming up around the corner. These are 3 video clips of the same procedure. This is a radical lymphadenectomy, ideoperative lymphadenectomy for a carcinoma endometrium, which has been done by the open technique. The second video is that of a laparoscopic technique, and the third video is that of a robotic technique. So many times people feel that if you are doing something with a laparoscope or you are doing something with a robot, are we going to be removing the tissue in a piecemeal fashion, or are we going to be doing less as compared to open surgery? जे लॅप्रोस्कोपिक किंवा रोबोटिक करत नाही त्यांना असं वाटतं आपण ट्यूमर काढणार कसं किंवा अपेंडिक्स काढणार कसं, आपण तुकडे तुकडे करून काढतोय का? Or we always feel what about the haptic feedback, because as surgeons or as doctors we always had a feeling जोपर्यंत आपण पल्स वरती हात ठेवत नाही, जोपर्यंत पोटात हात घालत नाही किंवा टिश्यूला फील करत नाही, you cannot get that haptic feedback. However, in robotics we call it as a visual haptics. Even if you are not feeling the tissue by your own hands, you can actually develop a visual haptic by looking at the screen. You can make out what is the tissue consistency and how it is going to be. Again, I will play this video. If you look at the laparoscopic video and robotic video, what you are seeing over here is a 2-dimensional image, but when I'm operating, I'm getting a 3-dimensional image. There is a limitation in the range of movements of the laparoscopy instrument. Robotic instrument gives me a 720 degrees range of movement, not 360. I can take one full turn, lock it, and again take another second turn. Now, how does that actually reflect when you do a surgery? This is a video. On the left-hand side is the robotic instrument, right-hand side is the laparoscopy instrument. Laparoscopy instrument can open for around 120 degrees and has 90 degrees range of movement, up, down, left, right. Whereas a robotic instrument, I can move it the way I want. This actually gets converted into a better control and better surgical positioning each other, or better suturing also. The first robotic surgery, which was technology, which was approved by FDA, was in the year 2000. That was a Da Vinci robot, and it was initially used in prostatectomies, gynecological procedures, minimal invasive cardiac valve repairs. But however, now it is used in almost every anatomical position. As compared to the surgical era where we have been talking about, where you need to scrub up, maintain all the hygiene, sterility, and then operate while being standing next to the patient. Robotic surgery is slightly different. Here, the surgeon is not sitting or not standing next to the patient. The surgeon is away from the patient. You are sitting on a chair and operating while viewing on a console, and that console controls all the robots which are being placed by the side of the patient. In fact, this is a CMR versus robot which we are using. It's a Cambridge Medical Robotics. As of date, Cambridge Medical Robotics has more than 120 installations world over. And till date, they have performed almost 6,500 procedures worldwide in the last 3 years. And I take pride and privilege in telling you all that out of these 6,500 procedures, 720 procedures have been done in Nasik in last 35 years. But that is the reason. If you go on the CMR website, the first page which comes up happens to be my photograph with a footnote that the most experienced versus user in the world. That is all. Now, in CMR, we have 4 bedside units which actually are placed by the side of the table, and it is ergonomically much better. We have always been talking about technology for the benefit of patient, but for the surgeons who are there in this auditorium, you realize while operating, particularly while doing laparoscopic procedures, it is really taxing when it comes to the surgeon. The discomfort which is there at your neck as well as the shoulder pain, because you don't, that fulcrum effect is gone. It actually reduces the lifespan of a surgeon. That's the way. In fact, way forward, you tend to develop fine tremors also. But all those things can be taken care of by doing a robotic procedures. And these are the usual port side placements, which is, or the OT scenario which is being followed. At this point, while I'm talking with you, there are 96 companies in the world which have a robot waiting for FDA approval. So probably in the next 3 years, if you feel that I do not do robotic surgery as a surgeon, then probably you need to be really updated. You need to go back to science, to the medical schools to understand that there are robots for the eyes, for dental, thyroid. There's separate robots for thyroid. Nowadays, I've done a couple of them. You don't need to do a neck incision to do a thyroid. A young girl I operated, 24 years old, not married, and she had a small thyroid nodule, which was a follicular adenoma. So she was advised a surgery. But she was very clear, I don't want an incision on my neck. I said, fine, we took an infracalcular incision and operated the thyroid without taking any incision on the neck. So this is easily possible without compromising any of the surgical principles and safety principles. Most important part of robotic surgery is the endo-wrist movements. You can perform movements which are practically not possible to be performed by the human hand. And laparoscopy also has a limitation in the amount of dexterity which can be given to the surgical area. I showed that this was the video. But seeing is believing. This is a video of a TME dissection of a carcinoma rectum who has undergone radiation. This is how a robotic surgery is performed. Now again I say that this is a two-dimensional image which you are seeing. When I'm operating, I get a three-dimensional image. I have the luxury of magnifying the image. I can magnify it up to 16x. So 16 times magnified image I can do. And I can go on dissecting deep into the plane. You are seeing that fluid little bit. That fluid is because of post-radiation tissue edema. If you have a look at the tip of my hook, I can move it in the direction where I need. As compared to laparoscopic surgery and open surgery, the energy settings, the cautery settings which are required for robotic surgery are almost 50%. So the thermal damage to the surrounding tissues is significantly less and recovery is faster. I had shown this video, few of my videos to someone on another platform, and one of the surgeons just got up over there and he asked me, is the patient alive? So I said, sir, what makes you feel that I'm operating on a cadaver? He said, there is hardly any bleeding you can see over. So if there is no bleeding, how can a surgery be performed? Are you giving hypotensive anesthesia? I said, there is no hypotensive anesthesia. Normal anesthesia, we do not recommend any hypotensive anesthesia. However, when you are operating with a magnified image, all the small blood vessels, these are the seminal vesicles which are getting lifted up. Now, in an open surgery, the way seminal vesicles being lifted up at this level, in open surgery, majority of this part of the surgery is a blind procedure, where you just put your hands in the pelvis and you go on dissecting. But robot gives you that comfort that you can magnify, and most important, it's a stable image. You have an image which is under the control of the surgeon. The camera is under surgeon's control. You don't have to depend upon your anesthetist or your assistant to show because the assistant tries to show which he feels is right, not what the surgeon requires. Second part about pelvic surgeries or more so in pelvic surgeries is about nerve dissection. You always know that rectal surgeries, prosthetic surgeries, the major part used to be urinary incontinence or retention which occurs after surgery. It is not only about preserving the nerve, it is about preserving the blood supply to the nerves also. If you have a look at this small clip, while you are operating, you get into the right tissue plane, you dissect it out, and while you are dissecting the nerves, you ensure that along with the nerve, the blood supply of the nerve also should be preserved. And if that can be done, you can safely remove the catheter after 24 to 48 hours, and you will not have any disturbing night phone calls at night. That's a nerve which is there, and there's a small blood vessels which are lying over there. How many times can you see these type of blood vessels in an open surgery or a laparoscopic surgery? Even if you use your loops and operate, it is still practically not possible. So any surgery which is done with minimum tissue damage obviously translates into better surgical outcomes for the patient. Now, evidence also has clearly suggested that robotic surgery is definitely better as compared to laparoscopic surgery, both in terms of the recovery of the patient. Pain is significantly less for the patients. This is a video of a robotic assisted low anterior resection rectum of a 60-year-old lady. Nowadays, majority of our rectal surgeries, rectal malignancies, we first give radiation to the patient and operate the patient later. The opening of the pelvic peritoneum. Once you open up the pelvic peritoneum, the pneumoperitoneum is such that it creates the own planes which go on beginning over there. All these blood vessels cannot practically be seen by the naked eye. Here I am using a magnification which is around 12 to 13x. That is why this is being seen. Otherwise, I can go up to 16x, which is there. Just rush through the videos, understanding the time constraints. Once the dissection is complete, this is how we dissect. As the uterus which is being retracted up by the third instrument. We always used to feel that rectal surgeries or cancer surgeries are very morbid procedures, lot of bleeding. I know that people used to feel that if you are doing a major rectal resection, then probably 3-4 minute blood cross match. None of our patients we cross match blood. We don't even ask the blood bank to do a blood group cross matching, because it rarely happens that you would have a major bleeder, because most of the bleeders can be very easily be taken care of and tackled over there. This is how the dissection goes on. When we do the complete pararectal dissection is done, we call it as a TME plane. Once the TME plane is being dissected, you undertake the dissection of the colon at the level at which one has to dissect to cut the colon. So the mesentery is being dissected over there. And distally, you can apply a stapler. Earlier, tumors 5 centimeters, 6 centimeters from the anal verge, it used to be a permanent colostomy APR. Nowadays, it is absolutely not required. You can do a coloanal anastomosis even for tumors as low as 2 centimeters from anal verge, provided the sphincter is clear. If the internal sphincter is free, no need of any permanent colostomy. This is a wound manager from which we deliver the tumor out. That is the stapled colorectal anastomosis which is being done. This is about 3 centimeters from the anal verge. And once the stapler is fired, you just check about the anastomosis. Because it's a post-radiation patient, we do a covering ileostomy for 15 days. After 15 days, that is closed. This is the final outcome of the patient. Patient is free to walk after 6 hours and can be discharged on day 3 after removing the catheter. No bleeding, and obviously, if you do a good surgical outcome, things are better. Many times, your colleagues do ask me, robotic surgery, fine, it looks good, everything is fine. What about the cost of the surgery? Are our Indian patients affordable enough to take care of that extra cost of surgery? Had it not been effective, had it not been affordable, I practice in Nasik, which is a tier 3 city in our country, and 720 surgeries in 35 months would not have been possible had it not been truly beneficial to the patients. So this was a question asked by a senior colleague, and he said, how do you take care of that extra 75,000 rupees of expenses for the robot? He said, if you use a stapled anastomosis for laparoscopy, the cost of staples goes around 40,000-45,000 rupees easily. You can do this is a anastomosis intracorporeal done with a 20Y3, no fancy suturometrics. 20Y3 which costs around 340 rupees. In 340 rupees, you can do anastomosis, do a leak test. Leak test is there, fine. You can shift the patient out of the OR into the ward. Next day, you can start the patient on liquid diet. No need of keeping the patient NBM for 5 days. So you can save on the cost of that surgical staplers by using maybe a Vicryl or a Statafix. I would not use Vicryl for every patient. I prefer using a Statafix because it is a self-locking suture material. But with this type of technology, if you can save the patient's time, if you can reduce the patient's morbidity, reduce the risk of post-operative complications, you are reducing intraoperative blood loss. There is no blood transfusion required. Obviously, all of these gets converted into a significant advantage when it comes to post-operative recovery for the patients. You must have seen laparoscopy videos. You just compare this to a laparoscopy video, you realize the vision is so clear, steady camera. The camera is not moving suddenly because the camera is being controlled by the robot. It is not controlled by the assistant. There is no human interference in that. Second part, as compared to laparoscopic surgery, the pain in robotic surgery is very less, significantly less. Now, why is it that the pain in robotic surgery is less as compared to laparoscopic surgery? One is you are using 5 millimeter ports. Second part, when the patient is under anesthesia, you are operating, you tend to exert lot of pressure on the ports. The assistant wants to exert pressure. The patient, poor patient, he is lying down under anesthesia, he cannot yell back or scream on you saying, you won't exert pressure. In robot, how much pressure should be applied at the port side is already predetermined. As a result of that, the pain at the site of the port is significantly less. Majority of our patients, we recently published a data of hysterectomies, 115 hysterectomies we did. Not a single patient required analgesic after 24 hours. After 24 hours, not even an oral paracetamol was given to the patients. They were good enough to get back to their routine within 48 hours after the surgery. We always say about fine pelvic surgery is okay. This is a video of esophagectomy. Thoracic is part of the esophagus. Something quite challenging because here the major part is the heart is continuously beating. You cannot be operating every time on a single lung ventilation. With that pulsating heart, you are dissecting close to the aorta. You have the great vessels next to you, and the margin of error is in the range of few millimeters. You cannot just go in and that's the aorta which is moving transversely at the upper part of the screen. You have already opened up once your pleura. If you see the depth, that is the pleura on the opposite side. Because it is oncological outcomes, we need to be very, very clear about removing all the lymph nodes and the lymphoareolar tissue. The continuous beating of the heart has to be taken care of. So this is we call as the fine tremors. While operating without the robot, some amount of tremors are there in every human being. It is impossible to be operating without tremors. As the age goes on increasing, even with experience, but unfortunately because of aging, the tremors tend to increase. But I know a very senior gynecologist at Max Hospital, Delhi. She's almost 73 plus, on the verge of retirement. She was always used to say that after a couple of months, maybe I'll take a retirement because I am not enjoying surgeries now. So one of her relatives needed a hysterectomy. So she requested her robotic colleague over there that because she's my relative, would you please do a robotic procedure? So he did the robotic surgery. She was very impressed looking at the surgery. In the next 1 week, she referred 2 more patients for robotic surgery. And Arun, who is my friend over there, Arun did those 3 surgeries 1 week, was very happy. And she's a wonderful referral colleague. If she's sending 3 hysterectomies in 1 week, it cannot be anything better than that. Next 1.5 months, there was not a single patient who referred. So he walked into her clinic. That, ma'am, why is it that last 1 month you have not referred any patient, anything problem? Hope I have not tried to hurt you in any way. She said, no, I have started doing robotic surgeries myself. Because I realized while doing laparoscopic surgery, whatever the tremors were there, they are taken care by the robot. So now I don't want to retire soon. I might operate for another couple of years. So it actually adds up to the surgical skills of an individual. It is not that robot is going to do something, it's out of the, everyone used to say that the robotic surgery adaptation or learning robotic surgery will be very difficult. For an open surgeon with some experience about laparoscopic surgery, it is a very, very easy technology to be adapted. Someone who is an open surgeon to learn laparoscopic surgery takes a longer learning curve. For robotic surgery, the curve is much shorter and much better is what I would say. This is a video of a abdominal part, the entire abdominal dissection which can be done. You see, I do around 20 to 25 robotic surgeries per month, and these are random videos which are picked up, any one of them. So majority of them will be, I have not converted a single of my robotic surgery patient into open surgery because of bleeding or because of breakdown of the robot wherein I could not complete it. The technology is very, very robust and usually takes care of most of the minor issues which can be created. This is again for those who are from the surgical background. When you are using we hardly are using scissors and knives now. We are one of the days. Even the skin incisions are taken with pure cautery now. The blade is not there in the OT majority of the times. But so with cautery settings, you ensure that because you are dissecting very close to the vessels, you are just taking the vessels, you are not taking major fibrofatty tissue close to that. You can dissect it out very nicely, and along with the dissection, you ensure that you are not causing any bleeding. That's the pancreas which is being dissected. This is a D2 dissection, as we call it, where we have to remove all the lymph nodes which are behind the pancreas also. There's a left gastric pedicle which comes up over there, which has to be taken up behind the pancreas, and usually only for the pedicle, either for a vessel sealing device or many times we apply clips. The clip application part of the procedure is usually done by the bedside assistant who is there. At SCG Manavata, I'm lucky to have, apart from my surgical colleagues, we are a team of 6 surgeons, but I have 12 post-MS registrars who are doing a DMB surgical oncology with us. So most of these things are taken care by surgical colleagues, and I wish if you have a surgical assistant, everyone, then surgery becomes very much enjoyable because you don't have to every time scream because that surgeon is thinking the same way as you are thinking. There are many more videos, but I know that we are running short of time, so I will stop over here. I can only add up and say that in the years to come, robotic surgery is going to play a major part, and it is going to be a major armamentarium in almost all OTs. It is not only for cancer surgeries, but it is for all benign surgeries also. Nowadays, we have started to talk that transoral robotic surgeries also are possible. Be it nephrectomies, radical cystectomies, prostatectomies, bladder preservations, all these things can be very easily be performed using the robot. Thanks to the colleagues who have been there very supportive across Maharashtra, who have been supporting me, that in the month of September, we could do 53 robotic surgeries in 1 month in one center. Very few centers in the world have been able to have this sort of a landmark. And this could not have been possible without the support of the patients and also the support shown by the medical fraternity. Thank you very much for this opportunity, Pute sir, and wish you all the best for the forthcoming year, for many more activities. In fact, in between, I met Pute sir in Nasik, and the first thing he mentioned, he was there for a talk which I was giving at the conference. He said that when during my tenure, I will make sure that there will be a rotating fellowship for robotic surgery, and a few of the residents will be posted to learn about robotic surgery, because this is a technology which has to be embarked. In fact, unfortunately, our educational curriculum is such that what you learn, it usually happens to be only platform. Many times what you practice is the entirely real world scenario is different as compared to the academic scenario. Thank you very much.
Thank you so much, Nagar.
As of now, that's not my specialty. I will be investing on an area which is not my core competence. However, we do perform a lot of neurosurgeries in our hospital. There are neurosurgical colleagues who come and do. This particular robot cannot be used for that. As of now, robotic surgery for brain is mainly being done for stereotactic brain biopsies. Stereotactic brain biopsies can be very well performed using a robot. As of date, to the best of my knowledge, very few centers are doing it. I'm not sure. I would be happy to be corrected. No.
Thank you, sir.
Thank you, sir. Your session was full of valuable knowledge and enthusiasm. Now I request Dr. Babaskar sir to please come on stage. Padma Shri Dr. Himmatrao Babaskar sir is well known for his innovative ideas and research in medicine faculty. His devotion and research on snake bite and scorpion bite is not only known to Maharashtra but also known to all over the globe. Over to you, Babaskar sir.
Now we are learn the robotic surgery, artificial intelligence. I think it is not too much useful to conduct physicians OPD. So we'll come to the grassroots people of physicians OPD because this robotic is actually less important to be carried out in physicians generally. This is good for the surgery. So let us come to the grassroots of the physicians OPD. So I will talk only on clinical medicine. What is the clinical medicine? Because irrespective of all intelligence, artificial intelligence, everything, clinical medicine cannot be substituted. Clinical medicine occupies always topmost role. We cannot substitute the clinical medicine because you see, चमच्याने खाणं आणि बोटाने खाणं हे फार महत्त्वाचं. Because in the brain, mouth, tongue, and fingers are simultaneously. So when you touch the food, the fingers, it will go in brain immediately, and that will brain will stimulate. Yes, I will produce energy. So that is the reason why we want a clinical touch. Huh? Cancel करायचं ना? Cancel करायचं ना? हाँ लैपटॉप है तो वही इधर दो अच्छा In part patient died by this time. You know, your scorpion bite pulmonary dies in couple of minutes. The subject is search of a research. Now, clinical medicine is learned in the ward, not in the classroom, not in some areas, not in the classroom. Digital library is highly volatile. That's important. And easily deleted. Visit to the bed in the ward, the visit to pilgrimage, it will remain gold standard word till we exist. Learn from recent textbook PubMed is more beneficial than Googleitis. Never be Googleitis. Now this is important. Namaskar. The sign is same, but the disease differ. One is a Hansen, another is diabetic neuropathy. So this is called clinical medicine. Next important, look at. One is the herpes zoster, another is the chickenpox. Disease is same virus is responsible, depends upon the individual immunity. So this is a daughter and this is a mother. They come simultaneously in OPD. One is herpes zoster, another chickenpox. Now the important is you see, never keep the assistant. If you want to keep the assistant, you should regularly check him. That's a very important. Otherwise, he will commit a mistake. You will have to attend the court. The most important is this patient was 63 years, 71 years, gone to the orthopedic surgeon. He said, I suddenly get black out, sudden loss of consciousness. He diagnosed cervical spondylosis, routine diagnosis. After he given a collar, and next, the third day again, he come symptom persist. And the fourth day, he said, we can do MRI of the brain. MRI of the brain was normal. Carotid CT angio was normal. Still, he never consult to other. Typically, you see, in Indian form, the surgeon, physician are afraid. Can I lose a patient? That is worst dilemma, worst habit of our consultant. If you got a, you see, in my OPD, first consultation, second consultation, if I'm not diagnosed, I say I'm incompetent to diagnose your disease. Now, ultimately, this wife of this patient said, can I take him to Dr. Bavarskar? He said, no, Bavarskar do nothing for cervical spondylosis. The assistant has taken the BP, said normal, everything is normal. So patient was got on 7th day from me. So I diagnosed, he said, suddenly blackout, loss of consciousness. It is Stockholm syndrome, Stockholm attacks. I took just a pulse rate, it was 27 per minute. ECG shows complete heart block. Immediately he was saying, and the pacemaker out and patient improved. So this is very, very important. That's why you limit yourself. It should not be at the cost of the life of the patient. Next important, conferences. You see, what is conferences? Many times, I rarely attend an away conference. When there is cocktail at dinner, then there is more audience or more rush. I have seen there is few in the cocktail and few audience to the lecture. That is happening today. Because this is everything is on Google, everything on PubMed, everything what the new teacher is telling, what robotic he will taught. So this is a dilemma, this is a great difficulty to get our physician to attend the conference. Because conference is a gathering of important people who can singly cannot do, but together decide nothing can be done. Just to enjoy food and meet the free. This should not be conference. Next important look at. Now HIV is over. During my time, the poor patient used to come with HIV. How is I diagnosed? If a single patient, oral candidiasis, fungal disease, same patient herpes zoster, viral disease, tuberculosis, so bacterial, viral, fungal in one patient, immunocompromised diagnosed HIV. Now we don't get HIV. We don't get HIV, but we are getting lipodystrophy, lipodystrophy. Now patient on ART, they are coming the bump with the neck, that is lipodystrophy, which becomes stigmatized. It has no treatment. So if the patient are chronic, this ART patient gets lipodystrophy or the back of the neck, and that becomes stigmatized. Most important, of this patient, this child of say 7 years child has a running fever for 12 to 6 days. Gone to the pediatrician. Pediatrician examine, admitted. You see, we are very hurried. How much we get admitted the patient rather than detailed examination. First, get him into bed. That is important. Occupy the bed. Because there was one of my friends, he says, the assistant says, Dr. Sahib, don't bed khali asle तर आमच्या physicianला फार त्रास होतो, become disturbed. So this is not. Now this patient has gone to pediatrician. Mother was telling she is running fever. Conjunctivitis there. Urticaria was there. He has given augmentin for 7 days. Patient has improved. And mother has shown. Mother has shown Isha on the back. And here you can apply some ointment. He has not diagnosed. This was a rickettsia disease. Patient has come to me. He said, and just the voice of the cattle say, and what rickettsia. We just give 3 doses of erythromycin, 3rd day patient of Pravara. Doctor said because of backslacking patient has pediatric, so this is typical rickettsia. Isha is the most diagnostic. Now, how is it COVID? When there was a COVID, in June, I think December, Wuhan, there was a COVID. Then I came to know COVID come to Maharashtra. Anything which happened in Bombay, it come to Maharashtra. HIV, Bombay, HIV come to Maharashtra. But I was preparing. If the patient come to how to manage the things. January 20 to June 20. All the Lancet, BMJ, DNJ was flooded with the COVID article only, no other than article. Lancet got impacted after 200 because of COVID articles. So I read and I prepare myself. If the patient comes, I will have to help. I will have to close it. I will have to treat the patient. Because that time what happened? Doctor दरवाजा बंद करायचे, door लावायचे, बाहेर जगायचे, तिकडे तिकडे. व्हिडिओवर बघायचे, yes, हे औषध घ्या, पैसे भरा. This should not happen with me. What? So what happened? There was no vaccination for them. So how to protect myself or my, because we both are doctors. First thing what was said is pediatric COVID was less because of MRI vaccine. Because measles and mumps virus molecular mimicry with the coronavirus. So we take MMR vaccine. BCG, most versatile vaccine. Inert immunity, cellular immunity of various antigens can be prepared by the BCG vaccination. We took BCG. In American Journal of Laryngoscopy, there was publication in the March. This virus which entered to the mucosa of the nasal cavity, it is killed by the protein iodine, and he advised protein iodine nasal drops. We started using nasal drops, and we started treatment from day one. All the COVID patients we treated very closely, only double blind box. Patient आमच्या तोंडावर पकडलं पण आम्हाला COVID नाही. Only one thing I do, I take regular exercise to recruit my cells, neutrophil cells. That's a very important thing. The patient will come from RT-PCR positive. I was daily against of the quarantine. You see, when patient come RT-PCR already has infected to the time. What is use of keeping me quarantine? So when the patient will come, the relative, मी त्यावेळेस काय केलं, मी स्पॉन्सरशिपला जात नाही, त्यावेळेस स्पॉन्सर एमआरला मागितलं, मला 2000 बेटाटीच्या बाटल्या आणून दिल्या. So when the patient come, relative come, I used to do 2 bottles to them, add a nasal drops. 500 relatives did not develop COVID, they were exposed to the RTSR and COVID patients. So that is very important to it. No more than the rapid examination of the patient, early noted by lymphopenia, eosinopenia, blood, important. Irrespective of normal HbA1c, Hyperglycemia was treated with insulin. That's very important. No oral hypoglycemia was used. Available. X-ray insulin. Both never use PP and other thing. And you remember, I have not seen a remdesivir and tocilizumab. I treated 3,000 patients. What if treatment was totally different? Whatever I used by study, number one, after anticoagulant aspirin, better another drug which is metformin. Now the paper is coming and metformin inhibit the ACE receptors. Then we colchicine, the biggest good anti-inflammatory drugs, indomethacin and methylene blue. How? Because instead of and the fluoxamine, now fluoxamine is alpha receptor agonist. There are two types of alpha 2 and alpha 1. Alpha 2 causes stimulation resulting in adrenaline cytokine storm. Alpha 1 receptor inhibit alpha 2. So fluoxamine is alpha 1 agonist. So persistent inhibition to the alpha 2 cytokine storm is aborted by the fluoxamine. Then very important is methylene blue. In addition, हे बघा प्रत्येकाने वाचायलाच पाहिजे. तुमचे केस पांढरे हो, तुम्हाला ट्रेमर हो, तुमच्या लक्षात न राहो, but you must read at least, you will remember 24 hours. So very important. Doctor is student till day. When he ceases to be student, he dies. We must be subscribed to the Lancet, NGM. Now methylene blue, in addition to cytokine storm, it's a bradykinin storm. Now the bradykinin stimulate the nitric oxide in the lung capillaries, and nitric oxide causes venodilatation, exudation, lungs, and ARDS. Now the methylene blue inhibit the bradykinase enzyme, so there is no synthesis of nitric oxide, so ARDS reduce. Now methylene blue convert the ferric acid to ferrostate in the hemoglobin. The hemoglobin which are pure carrying oxygen improves. No, so you give methylene blue by nebulization, patient oxygenation improves. So you arrest the process of ARDS. Now methylene blue can be administered at home by nebulizer. Simple, it is a non-toxic drugs. Next important, what we see is COVID vaccine. Now many were afraid that COVID vaccine is causing infarction in my area. My part is infarct, my part arrhythmia. But we forgotten whether this patient even COVID was ongoing corona infected. Nobody took the history. COVID vaccine. Nobody took this. Are you history of fever last week? Are you history of body ache? Are you some another symptom? That COVID has added infection or resulted in myocardial infarct. Next important, now we get post-COVID patients. Herpes zoster, this indicates COVID has a chronic immunological disorders. COVID itself can cause liver diabetes. COVID itself can cause hypothyroidism, which were published in long back. So COVID still, we are with the COVID now. Many patients are coming stroke. Many patients with abnormal mental behavior. This is a post-COVID manifestation. Next important, which I study, you see. We are talking clinical medicine. The mother brought to the young daughter that she is refusing to go to the college because her peer teaches her because of ugly teeth. And the ugly teeth we diagnose is fluorosis. And the fluorosis, dental fluorosis is irreversible, but skeletal fluorosis is reversible. We gone to the village and the bore were 180 and the foot was deep, it was deep, which contains a high content of fluoride. We publish in tropical water, WHO ban this fluoride. Even them village of good water, at least skeletal fluorosis is prevented. Because there is a rule you should know. No more than 100 feet bore to be digged by the government resolution. But farmer doesn't listen. Now this we publish now, but now look at this patient has come with headache and vomiting. I do a endoscope, there was pathology. So as a routine pathology, we do MRI. Now MRI shows the hypotensation of the basal ganglia, the external corporate. This confirms this is nothing but the layer toxicity. And we take a history, patient was working on this battery factories. Now this patient was given penicillamine, the patient totally improved. Then still look at the dental. Burton line. This is a typical Burton line. So this is OPD, simple OPD. Look at the borderline, headache vomiting, see हमारा the leg toxicity, history वो डिगा बार लिए and confirm the diagnosis. Now let us say this patient has come early in the morning at 10 a.m. Dysphagia, difficulty in deglutition, unable to talk. When I examined, you was touching the base of the tongue. He got the history study, he has a Chinese food. You see, at 8 p.m. he the Chinese food. Why you should refer to it after 10 hours? Because now food poisoning I thought within couple of hours. 1 or 2 hours we get a food poisoning sign. But in this case, MSC monosodium gluconate, go to the brain, stimulate the hypothalamus. And hypothalamus stimulation results in clinical manifestation. So you should know this is an important of Chinese restaurant syndrome, which is probably in critical care medicine. Now another patient. See, this is very interesting. Patient of young man who is routinely going to the gym, come with a quadriplegia, profound paralysis, no plantar palpation, no rib chassis present. We take the ECG, show U waves, potassium of 1.3, less potassium. So ultimately, I was digging what is the cause of hypokalemia in this case. They said, he's going to gym and taking any tablets? No. I said, we'll lodge a complaint, police complaint. Yeah, at least we put a FIR, that patient is a coming quadriplegia. Then wife say, she bring the tablets. And these tablets, we took loose tablet to the chemist, it's what Dexona or cyproheptadine. Now Dexona will increase the weight, Dexona causes Cushing syndrome. Now, how cyproheptadine will cyproheptadine? Cyproheptadine inhibit the serotonin level at the ACTS to hypothalamus, thalamus to the pituitary gland. That's why Cushing syndrome treatment is cyproheptadine. This Cushing syndrome is prevented by cyproheptadine and he was put the way. So buffalo-like manufacturing prevented. So wise people say India, so brilliant people in India. So that's why cyproheptadine. Now hypokalemia, 1.3 potassium was too low. We have to go supplement this potassium in mannitol. Remember, do you want to rapid extracellular load? We have to give in mannitol the potassium. Next important, this patient, this is simple research society, clinical research. Now this payload mother, they had a oral malignancy. I put her because the dysphagia rise to predict. Then this young man of son says, what is cause of this cancer oral cancer? He said, he was very wise. While washing the morning teeth, he looked at the glass and he looked at the white patch where he keep the tobacco. He said, run to me. I have seen a bright white patch in my mouth where I keep the tobacco. I learned the lesson of research. I took a mirror in my consulting room. Those who are typical change, shown them. Look at this pre-cancer leukopenia. Direct, non-invasive oral biopsy. And many patients left the tobacco chair. This is simple. याला ग्रँड लागत नाही, याला ज्ञान लागत नाही, याला पैसा खर्च होत नाही, पण सामाजिक मोठं काम होतं. Next important, this now, very important thing, this often, why the rural people are developing ILD? Why rural patients develop this stroke? This is because of B12 deficiency. Now the way B12 is synthesized in intestine by bacteria. They are not prepared by anywhere. In our meat, green vegetable content B12 is wrong. Because on these green vegetables, these bacteria flourish and synthesize B12. Pesticides routinely used or destroy the B12 and B bacteria. Now, no vegetable is used without washing. And that's what called B12 is lost. Next important, in my area, we treated across a tribal community, no B12 deficiency. Why? I never seen their hand the distillery water. Birth of distillery water, the birth of B12 deficiency. Now they use half-boiled food. They never wash the vegetable. And that's why B12 deficiency is very common. Loss of hair, loss of memory, weakness, hyperhomocysteine, coronary heart disease is common in B12. Deficiency is very common now. One should remember the B12 and remember B12 deficiency करायसाठी ज्याचा पुरी असते ना रस्त्यावर ती खायला पाहिजे. हॉटेलमध्ये गेल्यानंतर बिस्तर मागू नका पहिल्या महिन्यात तेच पाणी प्या, you'll get B12 quota. Now, look at the this published in the Lancet long back. Look at visual pigmentation knuckle. Oral pigment knuckle is very common. That megaloblasts and hypermature polymorphs, the diagnosis of visual deficit. Just replace. Patient will recover. And replacement is important. If the patient has a chronic gastritis, if patient chronic vomiting because of a deficiency of gastrin or intrinsic factor, visual may not be absorbed. If the patient is chronic, that's how we got absorbed sublingual still now. This is absorbed by mucosa. Don't give injection. Because the absorption is the available drug which can stabilize the visual. Next important, see, very common. So raise in homocysteine is raised cardiovascular manifestation. Many cardiac surgeons do the plastic, very nice plastic. All three vessels are open, very good revascularization. After 6 months, again, we don't know why. They fail to take the history, family history, and they say, for this homocysteine of the atherosclerosis in Indian situation, maximum they forget to be homocysteine. Many patients come to me, we diagnose homocysteine, treatment of simple hyperhomocysteine, patient improve. Again, the same thing now. This you see, this is now in New England Journal of Medicine, likely to publish in 1 or 2 months. Thrombosis and pigmentation, active extensive anterior myocardial infarct. Fetal dyslexia, hyperhomocystinemia. Many times we get S1, QT3 syndrome or pulmonary embolism, hyperhomocystinemia. Now we keep. Everybody says non-veg is a rich in B12. We took three various meats, pre-cooked, sent for B12. B12 level is 100% good. After cooking, it will do more than 75%. So your meat doesn't contain B12. Cooked meat is lack of B12. So again, another simple sign because the clinical medicine. Ear crease. If a young man come in with the ear crease, diagnosis is ischemic heart disease. Because of atherosclerosis, more fibrosis, local retraction occur, and ear crease, diagnosis anterior infarction, arterial 3 vessel disease. So simple ear crease. Don't examine yourself now. Now this sample. Again, look at the ear crease and 3 vessel disease. Next important, see, what are the coronary strangulator? What strangulate factors? One is the male. Now female is also more. Double chin, obesity, baldness. High baldness is dorsal baldness, one of the cause of coronary. Acanthosis nigra. Even knuckle can be stick knuckle is the diagnosis acanthosis nigra. Not over back, but thick knuckle also acanthosis. Increased weight, hyperglycemia, C-peptide, low, and last is height. If the height is more, the height is less than 180. Indians' height is low. That's why they are more ischemic heart disease than the Western people. Because the blood which is block our coronary, that size of blood may not block the coronary. The high-grade people, their coronary size is big size. So it is a close to the nature to we people who have small height, small coronary, more back. This faulty diet, early atherosclerosis, and more ischemic heart disease. Now here is how to how to diagnose this potassium hyperkalemia, acute infarction, and chest pain. This is a different very TVO diagnosis can be done. Now this is very disease. This patient has come to me 3 days. Doctor Sakal Kumar BDMS chocolate. He has gone to neurologist. He diagnosed TI pain. Take out the masala so sakal statin pain. 4 दिवस 5 दिवस 8 दिवस करणे म्हटलं मी आपण फास्टिंग ब्लड शुगर करू. This fasting blood sugar is 40 and random blood sugar म्हटलं 200. So it's very difficult. He's not taking hypoglycemia, non-diabetic. How this can be? So during insulin, antibodies and insulin level was very high. Insulin, so it is autoimmune hypoglycemic syndrome, Hirata's disease. A simple we take it in steroid for 1 month, totally cure diabetes. So this is which is diagnosis. Now diabetes is increasing. Why diabetes is increasing? Taking OPD more than 100 patients. OPD इंडोर मध्ये झालाच पाहिजे ऍडमिट. संध्याकाळी काय सगळं झालंच पाहिजे. रेफरन्स केलेच पाहिजे एमआरआय इथले म्हणजे काय प्राइस एवढी भेटत. हे सोडा आता. आप एज ऑफ 50 से आनंद पिक्चर में चांगलं जिंदगी उंची होणार म्हणते ते झालं वय आपलं आता 50च्या आत जे शिकलं ते शिकलं आता पण आता जिंदगी लंबी होणार म्हणते that you can achieve by stress free life. You must have stress free life. Dr. Piglet become young and younger because he has lost the stress. Stop the practice. So it should be diabetes, hypertension, itching heart is above 65, above 70. If you suffer below 40, you kill your profession useless. Okay. Stop it now. Let's stop that. No, we can stop there. Now look at hypothyroidism. The physician will understand why hypothyroidism is increased. Everybody thought of it. Now I did antibody levels of OPD, routine OPD patient at TSS level. Anti-TP was very, TSS was also higher level. And the tribal community, TSS was antibody because of iodinated salt. Now this iodine is inorganic iodine. If combined with thyroid peroxide, is formed antigen, an antibody against the thyroid is thyroid. Now the organic salt, which is eaten by this raw material, raw salt doesn't contain iodine or is organic, doesn't form the antibody, and no hypothyroidism. Why the iodine was given? Because of cold area where the iodine is leached out from the soil. Iodine go to the crops, and we get the iodine gray in Maharashtra. Because of that area, iodine leaks out, there is no iodine. That's why it is called an iodine deficiency. But government, national program, universal national program, it is published in the International Journal of Clinical Medicine. So that's why we should see. This is the last case I will tell you. What is clinical medicine? हे पेशंट माझ्याकडे आला सकाळी पण डॉक्टर असं पाहत राहिले की ऑब्जेक्ट the objection becomes slowly clear. Fundoscopy shows stability. Physician must have ophthalmoscope. You must have ophthalmoscope. It's a very important. यामर तर भेटतच नाही हो. यामर सांगितलं मी गाळाकडे अरे बघा कुठे यामर म्हणते की बाई आणखी जायचं तुकडा करून हे यामर. This clinical medicine never forget. Now we did hypothyroidism, got hypothyroidism. We put 1,000 microgram Rylex to feeding hypothyroidism, a patient improve, her papilloma disappear, vision improve. She married and happy. So this is typical clinical examination. We should know. Now this woman again hypothyroidism. Brought in the morning, she had a fever, comatose. It is soon when the doctor said, "Yes, so but it is she has given diagnosis. Spot here, easy pulling up share here, hypothyroidism, the rise to patient improves. So this is very, very important clinical diagnosis. And this, I think we should stop here now because there are many subjects to discuss here, over 18 subjects. Okay, thank you. So any question, you can ask me any question. Any question in clinical medicine? What?
साहेब तुम्ही क्लिनिकल मेडिसिन मध्ये फार थोरो सांगितलं. यू आर परफेक्ट मॅन, यू आर अनदर यंग मॅन इन क्लिनिकल मेडिसिन. व्हॉट अबाउट युअर पद्मश्री अचीवमेंट? कॅन यू एनकरेज द ज्युनियर डॉक्टर्स? पद्मश्री तुम्हाला पद्मश्री जी मिळाली, मला असं वाटतं हे तुमचं रुरल एरियाचं संशोधन आहे. ते
urban area.
Yeah, of course. Medical medicine म्हणजे practicing in rural area with the urban thoughts, with the digital.
Headache patient are MRI ante dauri MRI patient headache patient. That is wrong. To take this is important. You see, this is a practical thing. When sparkle by better less than 1%. Take by less than 1%. What yes I have. You see, I don't think more value to the person. Most value the day on which my patients are. That was highest happiness. Now the शेवटी गव्हर्नमेंटला वाटतं काहीतरी याला उचला. आणि हे बघा, you see, प्रत्येक गोष्टीचं डॉक्युमेंटेशन पब्लिश झालं. Public 138 my publication. Out of 34 in the Lancet. What are these cover मेडिसिन तुम्ही शपथ घ्यायला पाहिजे की आता इथलं लाईफ गेलं पण याच्याकडच्या लाईफ मध्ये तरी एकदा तरी लँडसेट मध्ये यायलाच पाहिजे
कारण मला इंडियन जर्नलने तुमचं इंडियन जर्नलने कसं ते काही हे नाही केलं.
My paper of partnership was sent to Indian journal because you see there was board extremity, no local print, constitution local print. Indian editor says we don't believe this partnership because there is no local print. Same paper gone to the High Control and said and we get they say full publish you. आपल्याकडे काय एडिटर कोण आहे, ऑथर कोण आहे, त्याचा डाटा काय, डाटा वाचूच की कोण ऑथर.
So we are little bit lacking of time.
Thank you, doctor.
No question.
Yes, and we will be and Dr. Next program will be Dr. Rajendra Malpani Memorial Innovation Program. And for that, I would like to request Dr. Ram Arankar sir, past president, IMA Maharashtra State, Dr. Santosh Khattare, IMA Aklus president, to chair the session. I would like to invite Dr. Manohar Inamdar sir. Dr. Manohar Inamdar, senior physician, Aklus. He is having 100-bedded hospital, Ashwini Hospital in Aklus. He is also fellow in American Association of Cardiology.
Hello. It is my privilege to introduce Dr. M.K. Inamdar, who is Managing Director of Ashwini Hospital, Aklus. He is a person who is practicing for last 42 years. He has treated serious 1 lakh cases. He has treated everything. Foreign bodies in the lungs, foreign body in the stomach, all other types of operations, accidents, cardiac emergencies, and poisoning, snake poisoning, all types of other poisoning. So the important thing in this is, he is a person who is doing all type of treatment under one roof, single-handed. This is most important. Thank you. I would request Dr. Inamdar to start his lecture.
Thank you, MASTACON organizers and IMA office bearers for selecting me for this oration of Dr. Malpani, who was astute pediatrician, very good human being, social worker, and he was very respected person. I'm very happy that I'm talking to you for his own issue. I started my practice in 1980. My talk will not be as much creative as Dr. Himmat Rao, but practicing in rural areas is equally a joyful movement. Till 40 years, I'm feeling that practicing everything in medicine is such a wonderful thing. I started in 1980. That was 17th of March. It was started of summer season, and every 2-3 days I just started my clinic. First physician in that area. So morning patient used to come with throat pain, salivation, difficulty in swallowing. So I used to put all my MD medicine knowledge, saying that pulmonaritis, cranialis, infective pulmonaritis, and this. And then afterwards I came to that this is great bite. And that time, intubating the patients, sending this patient to district level was very painful. In the initial phase at 1980s, I lost almost 3 to 4 that rubber tubings and almost 4 or 5 MBVacs. So that was very costly in this. So I decided that it should not work like this. I should start my own treatment. At that time, I purchased an MMV ventilator, the stand model, which was that time costing about 20,000 rupees. And on that, I have almost saved thousands of snake bite patients. Now I have almost 50 ventilators, 40 non-ventilators, 45 critical care beds, and almost every facility. So if you go in a village, start practicing there, you have to be there. And you cannot say that send these patients, because I first 4 or 5 years, I learned that sending these patients to bigger cities will have more mortality. Half of the patients will die on the way. So instead, I have taken good clinical knowledge in Madras Medical College, so why not to use this? And that's why I started doing my this. So in practicing in rural area, you have to have some vision which is beyond physician's duty. As a physician, if you start doing duty, there are many duties which are beyond physician's duty. You have to have more, you have to give more to the patient. Because why I say that, these are recent figures, may not be that accurate, but in Mumbai, almost 5,000 to 6,000 physicians, Pune around 1,500 physicians. So they are increasing DNB and all this. In Kolhapur, Solapur are about 100 to 300, 500 physicians. And in rural area, remaining all rest of the rural area, there are about 9,000 to 10,000 physicians. So most of the population resides in rural India, and almost half of the physicians are not available for their practice. That's very important. So 70% of population resides in rural India. Just we notice that more than half of the physicians work in areas where there are no subspecialties or super specialties at all. Now the picture is changing. Now in Akuluz, there are about 2-3 cardiologists, 1 or 2 super specialty surgeons have come, but that time it was not there. So this is my work is in 1980. After that, or 1990, 2000, physicians in semi-urban and rural Maharashtra have to face more emergencies, less with less medical infrastructure. In 1985, first CT scan came in Pune. So every day my van was going to 2 or 3 patients with Dr. Sudhir Kothari. He used to see it, he used to do it a CT scan, and half of them they used to send back, half of them we used to keep this. So that was very difficult. So in 1990, I purchased a CT scan machine in Akuluz, where there is a Gram Panchayat area. There were not many CT scan machines, not even Solapur, there was one, Kolhapur, it was not there that time. So working for the patient and having a good diagnosis earlier is main motto. It should be a main motto of the treatment, your treatment. Hence, there is an increased burden of transferring the patients to multi-specialty hospitals in bigger cities. So that should be prevented, and if it prevents, then only this works very well. So duties of physician at periphery, what it will be, good clinical application. One has to be very good physician, no doubt about that. Whatever you learn, you have to have very good physician's characters, or you have very good physician's knowledge, and you should always go into the patients, see the patients all the time, and then decide this quick action in emergency situation. Perfect advice to the other specialists. So many patients, so many times patients come, you have to put your foot down and don't operate this, because this I feel that this you can see so many patients in that. So you should teach the general practitioners. So if you see a general practitioner's prescription in that area, that will show you on the face that how good your physicians are in that area. If your physicians are very good, then general practitioners naturally will catch up, and they will do more good prescription and good work. We place upon preventive medicine in day-to-day life. You should always teach in this your consulting. For example, if HIV/AIDS patient comes, his relatives come, you should always tell them, teach them that how it should be prevented. So you can go and tell that it should be prevented. So always continuous updating is must. So physician's role, primary role as a clinician, as I told that it should be, it is very good. And one has to acquire that very earnestly and very sincerely. Outreach to the community at large. Whenever there are epidemics, whenever there is some disease, you have to go in front and tell them and teach them that this should be done or this should not be done. Updating current knowledge and dissemination this information to other specialties or professionals. That's very important. When I started in 1980, I came with only a stethoscope and single trace monitor. Everything, whatever in the last 44 years I have, 42 years I have learned is through experience only. So doctor has to be always updating doctor. Then only it is like you are going on an airport, you are going by walk, and the conveyor belt is going on. The person who is on a conveyor belt, he goes ahead if you stand there. So standing alone there means you are not stable, you are going back. Other people are going ahead. That's why you have to be more updating this tendency every time. Physicians extended role as a part of super specialty. As I told that in rural areas, if there is no super specialty, if there is a neurophysician, no cardiologist, then you should always go into that role and help at least little. I always tell my junior physicians that whatever you start practice, at least in one specialty, you should make some effort that you should become more specialist for this. For example, physician comes and not many respiratory patient should at least have some knowledge, some experience, some courses, and then buy a bronchoscope, do more service, and do a betterment for the patient. So extended service also is very important. And updating current knowledge is very important. That's what I tell always. So scope in physicians in rural area, as I told that, this is different than city physician. Physician working in Pune, Mumbai has different role, and physician working in Appalachia, rural area, like some years ago, this area also, where there are no specialties. So there the work was different, and you have to have more this. In this situation, person has to do an extended work of a physician to some extent to that of super specialty. This is just a so all including this, I decided that everything whatever possible for me, I will do for the patient. So in just 2 to 3 years of my practice, I purchased a time model of ventilator, and I ventilated so many organ hospital poisoning patients or so many snake bite patients, and so this continued my effort. Every time one patient had ventilated on that stand model for 25 days, and patient went home. That gave me so much of courage that I should do this. So some of the cases I showed this. Some what physicians can do, you can definitely think about this. So 30-year-old female with hemorrhagic viral fever with severe thrombocytopenia and right leg extensive DVT. You know that in hemorrhagic viral fever there is thrombocytopenia, but simultaneously there are so many thrombophlebitic instances. There are so many embolism experiences we get. So she developed pulmonary embolism and she was treated. She had a DVT. So this is a simple one. I had a cath lab that time, and this was putting a stent, putting the IVC filter was more easier that time.
20 minutes.
So this is a simple this you can prevent like this patient came to me with a hemorrhagic viral fever. My radiologist told me that thrombus is such extensive in a day. She developed from to almost thrombus peaking in the IVC. He said that within 2-3 hours it may just this and night time that one plaque went. She had a pulmonary embolism. So again emergency ultrasonography was done. He said that the top is gone. It has gone, but still there is a lot of thrombus remaining. It can go again. So
last 2 minutes. 2 minutes are the
2 minutes, okay. So this IVC filter was it was tried afterwards. This was another patient. This was Steven-Johnson syndrome following ART with a HIV patient. Nobody was touching this patient, and then afterwards she developed in severe Steven-Johnson syndrome and strictures. So I put a esophageal stent there, and she survived very well. After 5 years, she came back. She had again stricture, and I saw that there was a little stricture above the previous stent. So I put another stent, and then another next 10 years she survived very well. So mentally retarded child came to me for 12 years girl, said that point गेले काय after radiology नेहमी मला बघायला की एपी विविध चालत नाही तर दोन्ही बाजूने घ्यायला पाहिजे पेन लाईट. Actually she had taken a bunch of coins, almost it was 5 coins, and that was removed with the scope. The 7-year-old I purchased my cath lab in 2004. And this care patient came in some 2005 or this. There was no specialist available. I was doing permanent pacemaker, temporary pacemaker, but not this. So patient was absolutely helpless. So I thought that I will just try. And then I did a pacing. I did an angio. Left angio was normal. Right angio had right pulmonary blockage. Then I did a first plastic without anybody saying. And patients were home happy. The complete heart block was reversed. That gave me so much courage that up till now I have completed almost 15,000 angioplasties. Being a physician, I'm not cardiologist. And almost 4,000 to 5,000 primary angioplasty in my hospital. Primary angioplasty done within 30 minutes of admission. Shortest time is 6 minutes. Patient came in inferior infarction, complete heart block, taken to cath lab, put up this pacemaker, and immediately stenting was done.
Hello.
So physician can do everything. This one, I'll take 2 minutes more. This is a very important video. I just wanted to show. This patient was he had left subclavian block, and please excuse me, I'll take 2 more minutes. So this was totally blocked subclavian. Just cut short this video. So from subclavian to brachial, it was totally blocked. This. So my surgeon was afraid. I said, no, you have to open this. If I send this patient to Pune, that time his fingers will be black. Patient will come, the vascular surgeon will come next day morning. Till that time, everything is lost. So we took the patients, and this was the first Hogarth case we did in about 20 years. Since then, we have done almost 50-60 Hogarth cases. So this was the incision which is taken is a physician, me. And assistant is my surgeon. He was very much afraid. I said, no, I will do it. Don't worry. Dr. Sanjay Varam will be laughing because he knows me. And this was Hogarth number 5 was put there. I measured the length of the this. So 21 months. Half a minute. Snake bite treatment specialist. So I brought on another snake from the subsidiary. So this is almost 30 centimeters on this. The last 2 seconds, the spurter starts to flow very well. Catch it again, flow. Just like all the thrombus. Median side and normal side was flat. It was not much there. Patient happy, but pain had gone, everything had gone. These are routine emergencies. Bleeding is happening or assistance. Every time we have to go and we used to save this patient. Till the patient goes to bigger city, he will be dropped dead or what happens. So it's better. I have done almost 1,500 bad ligations. Almost 40,000 endoscopy.
Thank you so much.
Physician finish. This oration should give me little time. This was a lady, this is the last one. She consulted physician. She consulted first. Diagnosed the bilateral cataract ophthalmologist. She consulted dermatologist. Is with scleroderma with little derma changes. Consulted cardiologist. She said that is the primary pulmonary hypertension (PPH). She consulted gastroenterologist. She said that it is a stricture esophagus, Barrett's esophagitis. And then last day she came to physician. I said that altogether this is a collagen disease, collagen disease, and then she was treated with steroids, and she could survive another 5-6 years. Ultimately, she died because of this. So, being a physician is very good thing for me. If somebody says me that what will be in your next life, I will always say that I would like to have a physician's list, because physician can see elephant as a whole. Instead of not due respect to all super specialties. I'm not underestimating this, but sometimes good physician is required in a difficult case where he can handle all these situations and he can keep super specialties in control, so that patient can come out. Thank you. Thomas, my teacher at Mirror Medical College. We should have some extracurricular activities. I am a pilot.
I request Dr. Arankar and Dr. Santosh Khadtare to please felicitate Dr. Vinamdas.
Thank you. Thank you very much.
I'd like to call Dr. Manoj Dongre. His topic is liver transplant surgery. Dr. Manoj Dongre.
Sir. सुशील हो रहा है सर एक
Good afternoon, everybody. I thank the IMA Association of the State of Maharashtra and Dr. Professor especially for giving me an opportunity to have a talk on overview of liver transplantation. So let's talk about topics, the history, indications, what are the types of transplants and complications associated, immunosuppression associated with it, and the outcome as well. So history from the first transplant in the world was done by Thomas Tarzer in 1963, and it was not successful, unfortunately. 67 it became successful, and overall, I think till 3 years back, 25,000 years liver transplant have been done. Whereas in India, our first transplant was done in Chennai in 1995, which was also not successful. 1998, we had our first transplant, which was successful in India, and now we've done over 1,500, probably now crossing over 2,000 per year. So as you can see from this chapter, this slide, that the transplant activity, which was very minimal in 1995, has gone significantly high. And now India is, you can say, one of the top 3 or 4 transplant centers in the world, countries performing transplants, with big centers in India doing over 250 to 300 transplants a year as well. So unfortunately, still most of the transplants are still concentrated Delhi, Chennai, Hyderabad, Bangalore. In Maharashtra, Mumbai, and Pune are doing well in transplants. Now, this slide I'll go on. So most of the transplants worldwide are more cadaveric transplants. However, the cadaveric donation rate in India is still not very acceptable because of faith, religion, and all other circumstances, where we are very low as compared to the other countries. So this is like where we stand. So distribution-wise, if you see, I'm going slightly fast because of a shortage of time. Most of the work in India is still in LDLTs, that is living donor liver transplantation, whereas outside it is America, Europe, it is all cadaveric donor. So what are the indications for transplants? So most common indication is cirrhosis. The common causes are in India is alcohol, hepatitis B, hepatitis C. And the new indications which are coming now, many people will say, oh, I never drink alcohol because smoking transplant. But most common cause nowadays which is coming up is obesity and diabetes mellitus. Both of them are causing cirrhosis to a larger extent. And even worldwide, they say it is going to overtake alcohol and hepatitis as a treatment, as a cause for transplant in the future. Most like what I spoke all are chronic liver indications where people have developed cirrhosis and they slowly decompensate. But there are some conditions which is called as acute liver failure. It rarely happens. Hepatitis A, which we see is a very common virus, but in a very significant, I mean, small number of cases, it can become really permanent with your enzymes going in 4,000s, 5,000s, lactic acidosis, renal failure as well. Nowadays, another cause which is coming up is herbal medications. People are taking Ayurveda. I don't want to criticize any of these, but other medicines, they try other forms of treatment and they take some medicines. And sometimes our livers are very sensitive to them and they land up in acute liver failure requiring a transplant within a couple of days. Other indications of transplant is when the patient has cirrhosis but is not decompensated, but you need to treat that, and that is hepatocellular carcinoma. Autoimmune hepatitis, when leads to cirrhosis, can also cause. Then other cholestatic liver diseases like PSC, PBC is caused, and some metabolic disorders like Wilson's and children biliary disease. So the signs of decompensation, as you know, in cirrhotics, most common is ascites or hydrothorax with recurrent ascites, recurrent tappings, and decompensation. You get SBPs as well. You have encephalopathy where the patient becomes unconscious, disoriented as well, or recurrent variceal bleeding is one. And then you have hepatorenal syndrome where the blood flow to the kidney decreases, or hepatoportal syndrome causing that. So why do you do a transplant in cirrhosis? Because now what's known is if a patient has a cirrhosis and he gets decompensated, his chance of mortality is 50% in 2 years. If he is compensated, he may live like that for 10 years as well till he decompensates. Once he decompensates, the chances of that are less than 50%. So these are the risk of complications with cirrhosis when any of these happens. So when should you do a transplant? As soon as a patient liver cirrhosis or line, he comes to your OPD, do you tell him a transplant? No, you don't need a transplant right now. We have certain times, means we have certain parameters to dictate when a patient's transplant is over. Because transplant itself has a risk of mortality. The ideal timing of a transplant is when they say when at that time your risk of mortality is more than 50% in 2 years. So that is the time you start. Transplant itself has a mortality of 3 to 4% in the perioperative period. So you don't want to take that risk when he doesn't have that much need of a transplant. So if the patient is very sick, but you can't wait very long, because then your chances of post-operative complications, renal failure, all that increase, and your chances of success with the transplant also go down. So not too late, not too early. So when do you do? So you have certain scores that you use. One is the child tube Burford score or the MELD score. Or if a patient has HCC, then there are criteria for that. Or if a patient develops pulmonary hepatic failure. So this is the child tube score where you take into factors like encephalopathy, ascites, bilirubin, albumin, and INR or prothrombin type. So divided into A, B, C according to the points that are come. And if it goes into class C, that means he is an indicator for a transplant. Similarly, you have a MELD score. It depends on basically creatinine, his bilirubin value, and his INR. There's a formula for that which we cannot tell you. It's just a formula, you put it and it will tell you. And if the score goes more than 15 or 15, he is a candidate to be listed for a transplant at least at that time. And higher the MELD score is, the higher is the chance for need for a transplant, sicker the patient for that time. With HCCs, now you might say, oh, patient already has HCCs, why do you do a transplant? He's going to die anyway. So you select those patients in which your chances of cure are high. So you select those candidates where you can and scarring all over the body. Refractory ascites, if he has is required to tap twice in a week like that, or bleeding which is recurrent and you are unable to do that. Which patients should you not select for a transplant? Okay, you have a candidate who comes with all these factors, but he's got so much of cardiac problems where he's not going to be able to tolerate a major surgery. That is one criteria. Or he has some history of malignancy spread outside the liver. Or a person which you are doing for an alcohol liver disease and is actively consuming alcohol. These patients, you should tell them that your chances of failure are going to be high. So you should discourage them further. Also, patients who have an active infection. So if your patient comes for a cadaveric transplant and you do a diagnostic tap and it comes SBP positive, means then because you are going to give them immunosuppression, these patients cannot be treated for a transplant at that time. You have to treat their infection once they're culture free, only then you can take them for a transplant. Acute liver failure, I don't. In the European countries, it's mainly paracetamol poisoning where that's the only drug that is available over the counter for abuse or suicide is what they use most of the time. Our side, it is rat poisoning and other OPP drugs. And others are this like hepatitis E and A virus or drugs like even tuberculosis drugs also have cause liver transplant, liver failures as well. So there are certain criteria so most of these liver failures will recover on their own, but you have certain criteria that okay, then this patient has his pH is less than severe acidosis, pH less than 7.3. Even if you give all fluids corrected, everything it's not improving, or INR goes more than 6, or he is in persistent HE. Then you have to offer them a transplant, saying that the chances of recovering on their own are less, and you have better chances of survival with this. So, like I told you, there are two types of transplant. One is a cadaveric transplant, and one is a living donor transplant. cadaveric transplant is not someone like you take a liver from a person who is dead and just take him out. It's certain brain dead patients, which means that all their other organs are functioning except for the brain. Usually, this is because of a stroke or an intracranial bleed or some trauma to the head which is causing, but all these other organs are dead. The patient has to be certified as brain dead, which is cannot be done for anybody like that. You have a committee assigned to each hospital. Usually there are 2 neurophysicians or 1 neurophysician, neurosurgeon or intensivist who have to certify that it's bed. They have to conduct certain tests and only then they can certify that. The other thing is a living donor transplant where it's a first degree relative most of the time, mother, father, sister, brother, uncle. These people can give them. So this is the organ. So like I discussed to you, they have to be certified by a neurophysician that or an intensivist that he is not going to survive and it is an irreversible brain damage in this. And you have to rule out other metabolic, circulatory and endocrine causes for the same. So before coming to the donor, now like once we said that this patient is a suitable candidate for a transplant. So what these people have to do is either they have to get a living donor or they have to get themselves listed for a cadaver. So there's a state and a zonal listing for criteria where the patient has to register himself. All his details have to be sent on the system and then they go on a waiting list for it. So once that's 2 minutes. So I'll just discuss about cadaver then in 2 minutes with that. So once the donor is available, the consent and is certified as brain dead, then we cannot. So there's a coordinator who counsels the patient, and if the family agrees to it, then we proceed ahead with the donation. So probably the donation happens in some other hospital where the donor is available. Similarly, you admit the recipient at that time as well. So organs, multi-organs, you have to use flights or cars. This is the equipment that we use for this. So opening of the abdomen where you observe all the organs, the liver as well. They see that there's no tumor, and then you harvest the organs. So this is how you identify, you look at the quality of the organs to see how they do well. You can see the orange ones are really fatty livers, whereas the brown ones are good livers. And then they're stored in ice and then they're taken to the transplant center. They're cleaned on the table. I'll show you this is the liver. The liver surface vessels and all are cleaned. And then we start with the recipient procedure. And this is how the liver is removed from the cava. That's the liver out. Then you start implanting the organs where the liver with the cava is implanted. This is, if you can see, is the cava below. That's the hepatic veins on the top. And then you join the cava of the donor onto this system. This is a side-to-side venoplasty. And then you join the hepatic artery, portal vein, and the hepatic artery, portal vein, and the cava. And then you start flushing and start. These are the pictures for them. Okay, do the artery anastomosis. Then you do the bile duct anastomosis. This is how the final picture looks like. This is pediatric. I will not go into it. Living donors. I don't think I have time for that if it's 2 minutes. So just to give you an idea, in the living donor, how much liver can you take from a donor? You can take up to 70% of that. You need a minimum 30% of liver for his body to survive. That liver can regenerate. But if you have a donor on calculation where you see that the donor volume is less, then you absolutely reject the donor. You ask them to look for a different liver. And how much liver does a recipient need? It's normally 1% of his body weight. So if a person is 75 kg, ideal weight minimum is 750. They've gone up to 0.8, so it can go up to 650 or something. So this is the anatomy. What we, as surgeons, we have to study. I'll not go into detail. Bile duct as well. I'll go into that. This is how you isolate the vessels on each side. This is how you split the liver. This is the middle vein on which we do. And this is, you have to reconstruct the middle hepatic vein because you cannot take the middle hepatic vein. Either it has to be left with the donor or with the recipient. Most of the times it's kept with the donor. So you just reconstruct it with either a PTFE graft or this. And then you again join similarly artery portal vein. This is how the final picture looks like. That's the liver, that's the cava, that's the middle and the right hepatic vein, and that's the portal vein, and the bile duct on top of that. The red shunts we like it. On table we do Dopplers just to check that the flow is quite good. And what of complications is bleeding, as because these are all cirrhotic levels. Coagulation takes some time to go. Life-threatening problems are hepatic artery thrombosis, for which patient has to be re-explored again, because if the hepatic artery is thrombosed, your graft chances loss more than 80% in these cases. So that is what you have to watch for. Infections, because you put the patient on immunosuppression, risk of infection is high, and because we are giving immunosuppression, there are side effects of immunosuppression as well, where there is risk of renal failure, diabetes can progress further, there can be rejection, which we have to treat with steroids if that does. This is how we do the immunosuppression with 3 drugs stacked, mycophenolate and steroids. Slowly you start withdrawing steroids, and after 2 years you can stop MMF, and long term you keep them on tacrolimus. Supportive treatment, advantages, disadvantages. I'll just go to outcomes. So hospital mortality is between 5 to 10% in the perioperative period, depending on how sick the recipient is. There is a 90% survival, 1 year survival for transplants nowadays, and a 5 year survival is around 80% of this. So it's quite a decent survival. If you compare the life what the patients have before and what they have now, people will say it was really worth taking that risk and going ahead with the liver transplant. This is the overall survival. Thank you.
Call upon stage Dr. Nilesh Sadhvan, and he is going to deliver a lecture on hand transplant surgery.
Good afternoon, everybody. At the outset, मी organizers आभार मानतो मला इथे opportunity दिल्याबद्दल. The kind of movement that we just saw, a lot of people in the hall, this is exactly the difficulty that we face in transplants, and this is exactly the struggle that we have gone through in establishing this program, which actually is extremely crucial for the lives of many. So I am Dr. Nilesh Sadhvan. I am from Global Hospital, Mumbai, and I also am attached to Wadia Children's Hospital. Global Hospital is a multi-organ transplant center in Western India. It is reputed for having most of the transplant programs which are running successfully. Some of it are almost firsts in the country and also some in the world. We all know the importance of organ donation. We all know the long waiting list that the patients are waiting for receiving different kinds of organs. Most of them may not be able to get an organ in their lifetime. It is extremely important that as doctors, as primary care physicians involved in patient care at the grassroots level, each of us becomes an ambassador of organ donation and creates awareness, spreads this information to the needy class. Coming on to hand transplantations, I'll begin by saying that the human hands are extremely special. The one thing that differentiates man from his immediate primate is the opposable thumb. The ability of our thumb to be long, strong, stable, and opposable to all other fingers is the deciding factor which puts us on the top of the food chain. And this hand function is so important. It is considered as a masterpiece of evolution. It is not possible to duplicate this hand function even in today's advanced computer era. However advanced the robotics or AI they have unfortunately not helped in developing and useful prostheses for hand amputees. The main problem with these prostheses will come as we go ahead. So this is the importance of hands. If you see what the brain sees, if you look at the motor and the sensory homunculi, there is a large area in the brain which is occupied by hands. Because we use hands for all our activities, we use hands for talking, expressing, touching, feeling, earning our livelihoods. We use them practically for everything. Only when the hand is injured or it is lost, we realize of what difficulties the person might face. So the evolution of replantation, when a finger or a hand was amputated, there was no treatment available before 1962. The first replantation, that is reattachment of the same part to the same person, was performed in 1962. Following that, several hands, several fingers, digits have been salvaged by plastic and microvascular surgeons across the country and across the globe. But when there is an amputation which is not replanted, or when a replantation fails, then these patients have to unfortunately remain as amputees throughout their life. Depending on what is the level of the amputation, there are certain reconstructive procedures which are performed in order to reconstruct the lost finger or a digit. We often perform microsurgical transfer of toes to the hands in order to reconstruct the thumb or the fingers, or sometimes we do osteoplastic reconstructions. However, when the amputation is at the level of the wrist or above, there is no suitable reconstructive options for these patients. Traditionally, this kind of procedure, which is called as a Krukenberg's procedure, was performed, in which a forceps-like mechanism was created for hand use, but it is not very functional. As I said, the prosthetic hands are not really a substitute for a natural hand. They have several problems. They are insensate. They cannot be used in water. They carry a certain amount of weight. There are problems related to amputation stumps. They provide very poor, inadequate, or primitive function. They are exorbitantly costly. The cost of the most advanced hand prosthesis today is 35 to 40 lakhs, which may not be affordable for most. And plus, they need repair and refurbishment every couple of years, which is a recurring expense. And all these factors ultimately lead to non-compliance. An amputee prefers living with his amputated stump rather than using a prosthesis. So we can only imagine the plight of these amputees, either it is a single hand or a double hand. Double hand amputees are severely dependent. They are depressed. They have lost their works. They have lost their self-esteem, and they are living a very isolated life. So a solution was needed for these problems, and hence hand transplant, I believe, is the best reconstructive option for most of the bilateral amputees and some select unilateral amputees. This is because, as plastic surgeons, we always believe that the quality of life is more important than life itself. If there is life, it is valued only if it has a decent quality. And that is what we aim to reconstruct by performing reconstructions and transplantations. So how do we select a recipient? As I said, any unilateral or most bilateral amputees could be suitable candidates for hand transplants. However, the candidates should be motivated, they should be good general health, they should be psychologically stable, they should have failed the trial of prosthetic use in order to value the transplant and know what worth it is. And of course, the level of amputation and the type of amputation should be favorable. Hand transplants, in contrast to other transplants, are not life-saving transplants. This is the major difference between heart, lung, liver transplant and a hand transplant. So because these are not life-saving transplants, the decision-making is extremely difficult and challenging in order to select who exactly is the suitable candidate to receive a transplant, who is capable of maintaining it, and who will really get a successful outcome. The donor inclusion criteria could be like any other transplants. Yes, of course, this is an external organ, so we try to match the skin tone as well. There should not be any identity marks or hair pattern. But all these factors are very unimportant because there is a severe dearth of organs. There is the shortage of organs is so high that we really can't be very choosy when we come to donors. The donor exclusion criteria are like any other transplants. As I said, the moral and ethical issues involved in hand transplants, these are life enhancing, not life saving. And plus, we know the problems of lifelong immunosuppression. So we really have to make a very careful decision. Very often we come across amputees of this kind. They come in different types, and they are either unilateral, bilateral, or quadruple amputees at times. So to cater to the needs of these amputees, we started our transplant program in December 2016 when we got the license for a hand transplant. Since then, we have been talking on different forums, creating awareness for organ donation, hand donation. Getting hand as donation is even more challenging because it being an external organ, there is a huge social taboo. Giving internal organs has still become easier, but getting hands is still an obstacle which we are trying to overcome. We prepared for this transplant by performing several cadaveric dissections and mock transplants. So coming on to the cases, this was our first case, probably a familiar name, a girl who lost both her hands in a train accident when she was 17 years of age. She was a college student living a very compromised life. This was her profile. We do a detailed workup of all these patients, including all the systems. There is a detailed immunological workup involved in order to ensure that the cross match is suitable and rejection is as minimal as possible. Hand transplants are a logistical challenge because we are working at 4 different locations at the same time. There's a huge manpower involved. We need skilled surgeons, skilled assistants, a lot of coordination of logistics depending on the retrieval of the donor hands, organizing the timelines, maintaining the ischemia. So it becomes a logistical challenge, especially when the donor is out of the city. Similarly, the recipient preparation is done. We tend to explore the stumps, identify all the structures, label them, tag them. Typically, these injuries are very ghastly to begin with, either train accidents, electric shock. So all the structures are scarred, the tendons, neurovascular bundles are scarred. So we need to identify them at a higher level at which they are suitable for anastomosis. The donor hands are simultaneously prepared, so we have 4 teams functioning at the same time, dissecting all the organs, trying to keep the ischemia time to the minimum. In this case, we could transplant these hands within an ischemia time of 7 hours and 7 hours 15 minutes. So this is the dissected picture of the hands, showing all the multitude of structures, the muscular tendinous units, which are identified and tagged. Especially at the distal forearm level, it becomes all the more confusing because we have almost 28 to 30 muscle and muscular tendinous units in that part. So the bones are fixed first. Osteosynthesis is done by the orthopedic colleagues, followed by the vascular repair in order to reperfuse the donor hands. Once the hands are perfused, then we have all the time to do all the repairs sequentially, the tendon, nerves, and superficial veins and other structures. The nerve and muscle repairs are extremely crucial because the survival of the hand is not the target alone, because the nerves have to recover so that the hands get functional. So doing a good nerve repair is extremely crucial to get a good outcome. Repairing as many veins as possible also is extremely crucial. So we need a large number of skilled microvascular surgeons. Typically the surgery is prolonged. It takes close to 14 to 16 hours. So we need a large team members to stay back who are skilled enough to take care of all these technicalities. At the end of the procedure, typically it is a long surgery, so the muscles get bulky and edematous, so the stumps look a bit bulky, but yes, the edema settles down over the next couple of months. This is the immunosuppression regime that we follow, typically induction with ATG and free drug maintenance. The good part is these patients are young and healthy, so the recovery, they tend to sustain the surgery well, they tend to recover well. Our patient did well, she was up and about on day 3 or day 4. And as the time progressed, we could see her taking these baby steps. This typically happens at 3 to 4 months post-transplant when the muscle nerves recover and the early movements start. Being able to use a mobile phone is extremely important in today's time and era. It actually makes the patient very happy. It keeps them occupied. It gives them a sense of belonging, a social connectivity. So this was roughly at 4 to 5 months after her bilateral transplant. So the functional assessment at the end of 12 months, we see that there is a reasonable flexion and extension of the wrist. The long flexors and extensors of the fingers are working well. She's also getting some intrinsic functions of the median nerve in terms of the thumb opposition. The ulnar intrinsics are typically slow to recover. They are still recovering and they are still likely to take some time. You see the thumb opposition, as I said, the thumb is the most important digit of the hand. Getting an opposable thumb actually makes the patient more independent. So we monitor these cases by doing protocol biopsies at regular intervals in order to see if there is any rejection episodes, and we tend to correct them with medications. There are minor complications that we faced in these cases. This case was done in the peak of the COVID pandemic in the first lockdown, so we had different set of challenges for this case. And this is the dashboard by which we monitor the outcome of these patients, and she has shown us sequential improvement in all the scores over the last 2 years. This is the hand transplant scoring system, which also shows that the recovery has been good on all fronts. Yeah, I'm coming to that. So these are the basic milestones. This could seem very simple to most of us, but yes, these are huge milestones for us. She was not able to do this for several years. She had lived a dependent life for more than 6 years. So being able to take care of herself was a huge thing for her. And the good thing is now we have employed her as a coordinator in our hospital, and she's now talking to the patients, counseling them, and she's a source of inspiration for all the patients who are on the waiting list. These are some videos quickly. I'll try to show some activities that she's doing at the office. These are some more patients. I'll quickly run, not much in details. The special part of this patient was he was a quadruple amputee. This, in fact, is the first successful quadruple bilateral hand transplant in a quadruple amputee in India, because there is a different set of challenges in these patients. Because of the lost limbs, there is probably a different cardiovascular physiology which they go through, and hence the recovery of these patients is extremely challenging. So this again was an aspiring kabaddi player, a sportsman by mentality, extremely strong mentally, and that was helpful for his recovery. He recovered really well. So within 8 to 9 months of surgery, he was able to do dramatic activities which really were heartwarming for all of us. This was another case, again a quadruple amputee, successfully transplanted. He's just completed 1 year. He's also recovering well. This is another female with 3 children who was severely in need of hands, and who again underwent transplant in January this year. She's also on her way to recovery. This is the last case, a very special case, I must say. On the left hand, he needed a transplant because of an mid-forearm amputation. On the right hand, we see that there is a partial loss of just the index, middle, and the ring fingers. In normal situation, this should not qualify for a transplant because there are develop the palm. So this patient also is on his way to recovery. These are the dashboards which show recovery. These are the biopsies. So the challenges in our scenario is the dearth of organ donors, a lot of myths and misconceptions in the society, and the socio-economic issues. But yes, in today's day and time, with the cost involved, hand transplant is still the most economical option and the only option that can provide a natural looking and a natural functioning hand. We are always on this mission of creating awareness for organ donation at every possible instance. And I would ask you to help us in this. This is a huge team effort. I would like to acknowledge my team. And these are our ambassadors now in the society who are moving about and spreading the message of organ donation and organ transplants. To summarize, I would say that the transplant is the ultimate legacy that we leave as a person, and this is the greatest gift of community service that we can give. And it is a duty of every doctor in the society to be talking about it and creating awareness of this. The crucial thing is, of course, the recipient selection. It is the appropriate recipient that determines the successful outcome. Thank you so much.
Moving on, I would like to call upon Dr. Meena Bhave. The topic is truths and myths of cosmetic surgery. I request Dr. Prashant Sawan sir to felicitate Dr. Nilesh Sandhu. I request Dr. Manoj Dobre, please.
Sir, sir, समोर.
Dr. Prashant sir, please participate on the look.
Yes, sir.
Yeah, please.
I request Dr. Dalka Kanade and Dr. Andre sir to please chair the session.
I know we are running very late. I would like to take this. I would like to take this opportunity to congratulate. So they are not able to detect my laptop, so they are copying and pasting my presentation, which is going to be a daunting task because it is full of slides. But I would like to congratulate Putte sir for covering 360 degrees of the practice of medicine in Maharashtra that is happening from the grassroots level to the most advanced levels. And I am here to represent one of the most neglected sectors, that is cosmetic surgery. आता 22 सरांनी पण आपल्याला दाखवलं की डेंटल फ्लोरोसिस झालेली मुलगी कॉलेजमध्ये जायला तयार नाहीये. So we have to acknowledge the fact that society is moving fast. Looking good is becoming very, very important. Moreover, it is the lack of health that is leading to lack of beauty. So health is the foundation of beauty, and that is what I would like to show you. If the laptop permits. So most of the patients, there are many myths about the cosmetic surgery. It is always thought that cosmetic surgery is required only by the celebrities. It is a luxury. It has nothing to do with the life of a common man. There are people who are dying because of various infections, this and that. But there is an important segment of normal people who want to pursue their profession. There is a section of housewives who want to be comfortable in the skin they are. There are many times it is thought that cosmetic problems are fiction of someone's imagination, but there are a lot of environmental factors, lot of hormonal factors that are affecting a woman's body. Most of our patients are women. The changes of hormones in the pregnancy, they are really very, very difficult to challenge, and they leave ravages on the woman's body. And most of the cosmetic surgery in common sector, it is directed at the women to make them fitter, more comfortable, to be able to take care of their beauty. For the youngsters to become presentable and present themselves confidently in the society. So the tagline of my clinic is so unfortunately, I think my laptop is not, they are not able to connect my laptop. So So I think I have already given the introduction, and these are the beautiful slides I have created myself. So just take a look at them, but I'll skip them. So reality is that cosmetic surgery is the need of the hour, and it is for common people. Cosmetic surgery, first of all, is incorrect term. Cosmetics are substances that you put on your face and or body to improve its appearance, and that is what the name has given a sort of frivolousness to the whole thing, which is very, very important and much deeper, because cosmetics are associated with women who want to project themselves and flaunt themselves, but the reality is different. Aesthetic surgery is the right term, and it is the surgery done to improve or surpass the beauty of a normal person. This is essentially a branch of plastic surgery. We see many non-plastic invasions, especially from beauticians, aestheticians. Various different names are taken and cosmetic treatments are delivered, but that is not right. Plastic surgery is meant to restore form and function. It has two branches which have the same principles. Reconstructive surgery deals with defects which may be because of birth, cancer, injury, or infection, whereas aesthetic surgery is based on the same principles, but it deals with a normal person to improve form and function both. Now look at this girl who has a hair growth on her cheeks. It is difficult for her to go for a job. In olden times, there was a movie called Circus, where all such hirsute and deformed people were together. They were abandoned by the society, and they started a circus in France to earn their livelihood. But now they can be part of the society with simple laser hair removal. Repair of the earlobe, a very common problem of the women. They wear earrings which are worth thousands of rupees, which fall off. In beauty parlors, there is a sticky that is there is a sticky material that is used, but it burns the ears. So this is how aesthetic surgeons do the. I think from here. Excuse me. Presenter, can you switch off the next slide? No. My next slide is being shown there, so I don't want that. So anyway, I think it is all right. I don't have anything to hide. So this is a. So this is a young man. He is not an actor, but he wants a good nose. If you saw him in the previous picture, you can see him frowning, and that is because nose is deviated. He wants to appear straight, and you can see the change in the facial expression after rhinoplasty. Gynecomastia. These patients are not willing to remove their shirts. They are not willing to mix with peers. And if you really interact them, I have really been told lot of horror stories about peers teasing them. So they lose their confidence, and they lose the focus on studies, and they really suffer. And look at this boy who, after gynecomastia surgery, built his body so beautifully. He actually became a model. It is thought that it is reserved for celebrities, but no, this is a simple housewife with umbilical hernia, and you can see a beautiful result of abdominoplasty, which has taken care of the hernia, given her a flat stomach, and she is able to move around to do housework. This is a young girl from a village near Jalgaon who had inverted nipples, and husband was not willing to stay married to her. Within a month, she was going to get divorced. And this is actually not a functional surgery. She is not going to breastfeed. But I told the boy that even if she can't breastfeed, girls with even normal nipple may not be able to. He was happy with this simple surgery done under local anesthesia at a concessional rate, and the marriage was saved. A lady with twins, delivery, a large abdomen, no fat. She can't help it. So you can see the result of abdominoplasty. Another lady, 65-year-old lady, why she would come to get the cosmetic surgery done? It is not done only to look beautiful, but to treat large stomachs like that. So you can see a wonderful result after 3 years of abdominoplasty here. Another patient, older ladies with large abdomen and urinary problems, they suffer a lot. Here abdominoplasty was done with vaginal repair and TOT, that is transobturator tape for SUI. This patient was wearing pads. She is a widow. She was just brought up courage to share this with her son, which was very difficult and embarrassing. And now there is improvement in breathing, continence, posture, backache has gone, and knee pain has reduced. Another lady with twin delivery, a good result. This is how abdominoplasty is done. The rectus muscles are repaired, so they are put back into the function of breathing that they are meant for. And this is the extra skin is removed. All this extra skin and large breasts, they cause drag on women's body, and they make it very difficult for them to go around with their daily chores. This is a young unmarried girl who had asymmetric breasts, not ready to get married, had one-sided breast implant, and you can see a result after almost 7-8 years. She is happily married now. So we are touching lives basically. Another example, massive weight loss patient, again unable to move around because of the hanging skin folds. This is a result of belt lipectomy. After massive weight loss, she had hanging breasts, so all the sweat was collecting behind her breasts and it was becoming stinky, sticky. She was unable to work. A simple surgery, she is put back. Gigantomastia in a 52-year-old lady. As I said, she was not able to exercise with this size of breast. So a breast reduction was done and a good result. Another lady with severe neck pain. So we are making them healthy first and beautiful later. Similarly, axillary breast, same problem, sweating, sticking and stinking under the breast. Many times the husband says, "नाही काय आहे ते एवढं ठीक आहे, काय बिघडतं, मला तू आहे तशीच आवडतेस." But the problem is that the women are suffering physically. So that is what needs to be acknowledged. These are some of the results of axillary breast. We don't do robotic dissection, but plastic surgery dissections are bloodless. Nilesh will agree. So this is how the dissections are done. Very tiny structures are preserved. The axillary fat pad is preserved and the lumps are removed. This is my publication in our Indian journal, and this is a sort of reference point in the world now for treatment of axillary breast. It has got thousands of reads. Then it is also thought that axillary breast, the aesthetic surgery needs to be done in a very big hospital. But what is more important is the surgeon, his or her qualification, registered degree, experience, a good setup, clean and neat and registered. It should be a registered setup according to local man. Technology has become very important. Man and the machine both have become equally important. And as Dr. Karmarkar showed us, there are some things which machines can do better and we need to acknowledge them. So technology is extremely important. So I think, skip some of these slides. You will know. Then another myth is that only young people should get aesthetic surgery. That is not true. Even in older patients, such small lesions can be removed aesthetically without leaving any marks. Those were xanthelasma. This is the BCC of the nose, a 10-year follow-up. He wanted to die with his normal features and he did that. Actually, in our hospital, because my husband is a physician. This is a nurse with facial nerve palsy. She was unhappy with her brow coming down. She was not able to open her eyes. So she had to undergo aesthetic procedure for functional reason. And you can see a very good contouring of her neck and a brow lift. Now she is able to see properly. Another lady with a large abdomen. Many times these patients have some hidden reconstructive problem like this lady. Only when we did ultrasound, we realized that she had a hernia and she had to undergo surgery. And if you see this picture, you can see how long the skin is. And you cannot expect such a woman to continue to work efficiently through her old age. It is another myth that aesthetic surgery results are permanent. Aging, illness, diet, lifestyle habits all do matter. Aesthetic surgery pulls you back in the slide on the slide of aging, but it cannot keep you there permanently. Our patients have to put in some efforts for healthy life. I will show you some long-term result. This is a breast implant. As you can see, this is a 10-year result, and I have followed her all through pregnancy. The breast shape has changed, but the working life of the woman, she is happily married. So, liposuction patients, they also need to maintain with diet and lifestyle exercise. All aesthetic surgeons, they insist on proper diet, exercise, and maintenance treatment. This patient developed hypothyroidism. I always insist on comprehensive care, so she was diagnosed at our patients should feel free to come back when the problem occurs again. She was diagnosed with hypothyroidism, treated medically, and she lost all the weight she had gained. This is a patient who had a facial fat grafting, because at age of 42 she looked very, very old and thin. So she underwent facial fat grafting, and this is a 12-year result. She looks so beautiful at the age of 57. Moreover, there is no hanging of her face. So she is comfortable in her vision and talk. It is always thought that aesthetic surgery is costly, maybe, but why is it costly? Because it requires arduous training, meticulous sterilization. We need to use top quality materials and technology. But let me tell you that many public hospitals now, aesthetic surgery is offered to the patient, even in teaching hospitals. Our association is making efforts to reach to masses, and basically because we are making people healthy. That is my contention. So some of the results of advanced contouring procedures. She is a sportswoman, and to be a sports teacher, she needed chiseled abdomen. She had 2 children. She had undergone cesarean section, and this is a 1-year result. She is maintaining it well. Whereas this doctor, she required a tummy tuck, but because of the technology of radio frequency contouring, she was about to have a grandchild within 3 months, and she couldn't have taken rest after tummy tuck that is required. So only liposuction, and you can see a very good take-up. So this is what technology does. So don't grudge the cost that is being paid. It is definitely put to good use. So some of these results of difficult cases. Gynecomastia, double chin, these are all because of very good radio frequency technology. The skin can be taken up very well, it can contract back, and it has reduced the need for excisional procedures. This is another 37-year-old lady who underwent a very different type of abdominoplasty, and you can see a 1-year result. So with that, the last point is that there is no risk in aesthetic surgery. Every aesthetic surgeon, when qualified, risk-benefit ratio, age, comorbidities, duration of surgery, and post-operative care suitability, everything is considered. So primary contention is choose a qualified and experienced plastic surgeon to do your patient's aesthetic surgery. So take home message is that it's a boon and blessing. Right patient, right doctor for right reason. It will be mostly predictably successful. Benefits definitely outweigh complications. Thank you very much.
Now I request Dr. Anand Bhavesar. His topic is battle between immune system and virus system.
MASTACON चे सगळे आयोजक आणि डॉक्टर कुटे, मी तुमचे मनापासून आभार मानतो की या कॉन्फरन्समध्ये मला बोलायला आमंत्रित केलं. गेले 3 वर्ष आपण हे बघितलंच की व्हायरसनी किती धुमाकूळ घातला जगामध्ये, आणि आता आपण मास्क न घालता इथे कॉन्फरन्सला आरामात बसलेलो आहोत. आणि त्याचं एक महत्वाचं कारण म्हणजे आपली इम्युन सिस्टम किंवा तर व्हायरसेसचा मुकाबला इम्युन सिस्टीम कशी करतं याच्याबद्दल हे प्रेझेंटेशन आहे. गेल्या 3 वर्षामध्ये इव्हन आपले पेशंट्स इव्हन पेपर्स मध्ये सुद्धा टी सेल्स, बी सेल्स, मोनोक्लोनल अँटीबॉडीज म्हणजे इम्युनॉलॉजी हा विषय सगळ्यांच्या परिचयाचा झाला. पण त्याचं त्याचं रूप कसं आहे आणि इम्युन सिस्टीम कशी चालते त्याचं हे प्रेझेंटेशन. तर नुसत्या पहिल्या एका स्लाइड कडे आपण जर लक्ष दिलं तर त्याच्यात इम्युन सिस्टीम कशी चालते आणि कशी काम करते याचे मी थोडक्यात स्लाइड बनवली. सर्वात पहिल्यांदा म्हणजे व्हायरस जेव्हा शरीरात प्रवेश करतो, तर आता एक असा गैरसमज काही लोकांना आहे की व्हायरस किंवा बॅक्टेरियाचा प्रतिकार करायला आपले स्पेशलाइज्ड इम्युन सेल्सच पाहिजे असं नाहीये. प्रत्येक आपल्या शरीरातली पेशी जी आहे म्हणजे नॉर्मल पेशी ज्या आहेत त्या सुद्धा व्हायरसचा मुकाबला करतात. तर पहिल्यांदा वरती दिले PRR अलर्टेड. PRR म्हणजे काय? पॅटर्न रिकॉग्निशन रिसेप्टर्स. हे काय असतात की व्हायरस आत शिरलाय हे समजतं कसं, तर त्या व्हायरसच्या सरफेस वरती जे स्ट्रक्चर्स असतात, समजा विशिष्ट अमायनो ग्लायकोसाइड्स आहेत किंवा त्या मेम्ब्रेन मध्ये जे स्ट्रक्चर्स आहेत ते रिकॉग्नाइज करणं, म्हणजे ते त्या रिसेप्टरला जोडले जातात आणि मग आतमध्ये पेशीच्या आतमध्ये सिग्नल येतो की व्हायरस येऊन आपल्याला चिकटलाय. त्याला म्हणतात पॅटर्न रिकॉग्निशन रिसेप्टर्स. असे अनेक आहेत. काही पॅटर्न रिसेप्टर्स काय पिकअप करतात की व्हायरसमुळे एखादी पेशी डॅमेज झाली तर त्या डॅमेज झालेल्या पेशीमधनं जे रसायन बाहेर पडतात ते डिटेक्ट करतात. तर ते डिटेक्ट झाल्यावरती तो एक वॉर्निंग सिग्नल येतो की व्हायरस आतमध्ये आलेला आहे. ते ओळखायला हे पॅटर्न रिकॉग्निशन रिसेप्टर्स असतात. तर ते अलर्ट झाल्यावर सेल्स डू ऑर डाय हे वरती लिहिलंय. हे सेल्स म्हणजे व्हायरसला काय हवं असतं की व्हायरस तुमच्या पेशीमध्ये आत जातो, त्या पेशीचा कंट्रोल घेतो आणि स्वतःच्या कॉपीज तयार करण्याचा प्रयत्न करतो. बरोबर आहे. तर अशा वेळेला नॉर्मल पेशी पण फाईट बॅक करतात आणि जर त्या पेशी व्हायरसला रोखू शकल्या नाहीत तर त्या पेशी आत्महत्या करतात. कारण त्या पेशी व्हायरसचा स्लेव्ह होऊन आणखी व्हायरसची कॉपी बनवण्याची फॅक्टरी त्यांना नको असतं, त्यांना गुलामी नको असते. म्हणून व्हायरस विरुद्ध त्या हरल्या आणि व्हायरस त्या पेशीचा कंट्रोल घ्यायला लागल्या की आपल्या पेशींमध्ये अशी रचना आहे की ती व्हायरस इन्फेक्टेड पेशी सुइसाइड करते. तो दे डू ऑर डाय. नंतर सर्वात पहिला लाईन ऑफ डिफेन्स काय असतो तर आपली इनेट इम्युन सिस्टीम. जसं BCG व्हॅक्सिन किंवा MMR व्हॅक्सिन काय करतात, आपली इनेट इम्युन सिस्टीम तयार करतात. इनेट इम्युन सिस्टीम म्हणजे काय की ज्या आपल्या मॅक्रोफॅजेस किंवा पॉलिमॉर्फोन्यूक्लियर ल्युकोसाइट्स आहेत किंवा नॅचरल किलर सेल्स आहेत, ह्या शरीरात फिरत असतात आणि त्या स्पेशलाइज नसतात. ते कुठलाही व्हायरस आला, कुठलाही बॅक्टेरिया आला तर त्याच्याशी प्रतिकार लगेच करू शकतात. म्हणजे आपलं सैन्य समजा सीमेवर पोचायला त्याला उशीर झाला तर आधी बॉर्डर सिक्युरिटी फोर्स तिथे तैनात असतो की शत्रूंनी हल्ला केला की पहिले बॉर्डर सिक्युरिटी फोर्स त्याची मुकाबला करतो. तसं ही नॅचरल इनेट इम्युन सिस्टीम असते विच इज ऑलवेज रेडी टू गो. आणि त्याच्या खाली हे स्पेशलाइज DC म्हणजे डेंड्रिटिक सेल्स. आता कल्पना करा व्हायरस आज शिरलेला आहे, पॅटर्न रिकॉग्निशन रिसेप्टर्सनी सिग्नल दिलाय की आपल्यावर हल्ला होतोय, आपल्या पेशी त्याच्याशी लढतायत, इनेट इम्युन सिस्टीम लढते. पण जर ते पुरेसं नसेल तर आपली स्पेशलाइज्ड अडॅप्टिव्ह इम्युन सिस्टीम ही जागी व्हायला पाहिजे. तर त्या अडॅप्टिव्ह इम्युन सिस्टीमला कळणार कसं की कुठला व्हायरस आलाय, तर ते कळवण्याचं महत्वाचं काम हे डेंड्रिटिक सेल्स करतात. DC म्हणजे डेंड्रिटिक सेल्स. ते डिटेक्ट द व्हायरस. हे डेंड्रिटिक सेल्स सुद्धा सगळ्या सीमेवर पेरलेले असतात म्हणजे रेस्पिरेटरी ट्रॅक्ट, स्किन अशा सिस्टीम मध्ये. ते काय करतात की त्या व्हायरसला फॅगोसाइटोस म्हणजे पिकअप करतात, गिळंकृत करतात, त्याचे तुकडे करतात आणि ते व्हायरसचे तुकडे स्वतःच्या शरीरावर डिस्प्ले करतात नोटीस बोर्ड सारखं. आणि त्या व्हायरसला घेऊन ते लिम्फ नोड मध्ये जातात. म्हणजे उदाहरणार्थ कोविड व्हायरस लंग्स मध्ये येतो तर तिथून लिम्फ नोड मध्ये कुठे जाणार तर मीडियास्टिनल लिम्फ नोड मध्ये. तिथे गेल्यावर या डेंड्रिटिक सेल्स नोटीस बोर्ड सारखं बाहेर एक डिस्प्ले करतात की हा कोविड व्हायरस इथे आलेला आहे, मी याचे तुकडे करून डिस्प्ले करतो आणि ते वाट बघतात. कारण त्या लिम्फ नोड्स मध्ये टी सेल्सचा ट्रॅफिक चालू असतो. त्याच्यामुळे दर सेकंदाला शेकडो टी सेल्स त्या डेंड्रिटिक सेलला भेटून जात असतात आणि स्पेशलाइज टी सेल जेव्हा येतो की जो टी सेल या कोविड व्हायरसच्या तुकड्यांना ओळखू शकतो, त्याची भेट झाली की ते टी सेल्स एकदम स्टिम्युलेट होऊन मल्टिप्लाय होऊन त्या विशिष्ट व्हायरसचा मुकाबला करायला तयार होतात. खालचा जो आरो आहे कॉम्प्लिमेंट फाईट्स बॅक. कॉम्प्लिमेंट ही रेडीमेड प्रोटीनची सिस्टीम आहे आपल्या रक्तामध्ये. जवळजवळ 20 प्रोटीन्स आहेत. जसं आपलं क्लॉटिंग फॅक्टर्स कसे असतात की एक क्लॉटिंग फॅक्टर ऍक्टिव्हेट झाला की दुसऱ्याला ऍक्टिव्हेट करतो, तो तिसऱ्याला करतो आणि अशी चेन तयार होऊन मग शेवटी ब्लड क्लॉट तयार होते. तसं पहिलं कॉम्प्लिमेंट C3 हे ऍक्टिव्हेट होतं आणि ते ऍक्टिव्हेट झाल्यावर C5, C6, 7, 8, 9 हे जेव्हा ऍक्टिव्हेट होतात कॉम्प्लिमेंट, ते प्रोटीन ऍक्टिव्हेट झाल्यावर एक मेम्ब्रेन अटॅक कॉम्प्लेक्स म्हणून एक प्रोटीन सिस्टीम तयार होते आणि ती व्हायरसच्या सरफेसवर जाऊन त्या व्हायरस नष्ट करते. आणि दुसरं महत्वाचं काम कॉम्प्लिमेंट असं करतं की त्या व्हायरसला उचलून लिम्फ नोड मध्ये घेऊन जातात परत आणि लिम्फ नोड मध्ये FDC म्हणजे फॉलिक्युलर डेंड्रिटिक सेल्स नावाच्या स्पेशलाइज सेल्स असतात. त्या सेल्सच्या सरफेसवर ते व्हायरस कोट करून ठेवते आणि जसं डेंड्रिटिक सेल्स टी सेल्सना भेटतात तसं FDC बी सेल्सना भेटतात. आपल्याकडे खूप बी सेल्स आहेत पण फक्त विशिष्ट बी सेल्सच आहेत की ज्या पर्टिक्युलर व्हायरस विरुद्ध अँटीबॉडी तयार करू शकतात. त्यांची भेट झाली की त्या बी सेल्स ऍक्टिव्हेट होऊन आपल्याला माहिती त्या अँटीबॉडीज तयार करायच्या कामाला लागतात. म्हणून ही प्रोसेस व्हायला 4 ते 5 दिवस लागतात. त्याच्यामुळे 4 ते 5 दिवसांनी आपली अडॅप्टिव्ह सिस्टीम ही जागृत होऊन अँटीबॉडीजचा पाऊस पडायला लागतो आणि ती सेल जागृत होऊन व्हायरसचा मुकाबला करायला लागतात. या एका स्लाइड मध्ये जवळजवळ पूर्ण समरी घेतलेली आहे प्रोसेसची. तर या प्रत्येक प्रोसेसला एक एक डिटेल स्लाइड दाखवतो. ही कॉम्प्लिमेंट सिस्टीम आहे. मध्ये C3 आहे ते कसं ऍक्टिव्हेट होतं की त्या व्हायरसच्या सरफेसला रिकॉग्नाइज करून किंवा अँटीबॉडी अँटीजेन कॉम्प्लेक्सला रिकॉग्नाइज केल्यावर C3 चे तुकडे होतात. C3A, C3B. C3 हे C5 ला ऍक्टिव्हेट करतं आणि C5 हे पुढच्या कॉम्प्लिमेंट सिस्टीमला ऍक्टिव्हेट करून मेम्ब्रेन अटॅक कॉम्प्लेक्स तयार होतो. तसंच कॉम्प्लिमेंट हे अँटीजेनला घेऊन लिम्फ नोडला जातं कशासाठी? बी सेल्सना दाखवण्यासाठी. हे पॅटर्न रिकॉग्निशन रिसेप्टर्स आपण म्हटलं जसे पॅटर्न रिकॉग्निशन रिसेप्टर्स हे दोन्ही ठिकाणी असतात. सेलच्या सरफेसवर पण असतात आणि सेलच्या आतमध्ये पण असतात. म्हणजे सरफेसवर बाहेर असलेला व्हायरस डिटेक्ट होतो आणि जर तो व्हायरस आत शिरला तर सेलच्या आतमध्ये पण पॅटर्न रिकॉग्निशन रिसेप्टर्स असतात. ते काय करतात? व्हायरस आलेला आहे हे कळल्यावर आतमध्ये सेलच्या न्यूक्लियस कडे सिग्नल देतात की ज्या योगे सेलच्या न्यूक्लियस मध्ये असलेला DNA हा अँटी व्हायरल प्रोटीन्स तयार करायला सुरुवात करतो. वेगवेगळे पॅटर्न रिकॉग्निशन रिसेप्टर्स आहेत पण सर्वात महत्वाचा एक उदाहरण म्हणून मी एक घेतलेला आहे टोल लाईट रिसेप्टर्स किंवा TLR. तर हा जो चौकोन आहे ते दॅट इज अ सेल. त्या सेलच्या सरफेसवर हे सगळे TLR रांगेने उभे आहेत. ते आर रिसेप्टर्स आणि वेगवेगळे रिसेप्टर्स वेगवेगळ्या बॅक्टेरिया किंवा व्हायरसेसला डिटेक्ट करून त्यांचा सेलचा आतमध्ये जो भाग आहे म्हणजे शेपटी आहे त्यांनी आतमध्ये ते सिग्नल करू शकतात. या कोपऱ्यामध्ये काय दाखवलं की सेलच्या आतमध्ये काही TLR रिसेप्टर्स आहेत. TLR7, TLR9 वगैरे. ते काय करतात? ते ऑलरेडी व्हायरस आतमध्ये आलेला आहे त्याला ओळखून परत ते न्यूक्लियसला सिग्नल करतात. आता न्यूक्लियस मध्ये सिग्नल केल्यावर वेगवेगळे अँटीव्हायरल सायटोकाइन्स किंवा इंटरफेरॉन हे तयार केले जातात. इंटरफेरॉन हे एक उदाहरण आहे. RNA व्हायरस आत आला, त्याला रिसेप्टरने डिटेक्ट केलं, तो सिग्नल न्यूक्लियसला गेला. आता हे न्यूक्लियस काय करतं? इंटरफेरॉन तयार करायला सुरुवात करतं आणि हेच इंटरफेरॉन बाहेर जाऊन बाकीच्या पेशींना वॉर्निंग देतं की आपल्या शरीरात व्हायरस आलाय. इंटरफेरॉनच्या ऍक्शन नंतर सगळ्या पेशी अँटीव्हायरल प्रोटीन्स तयार करायला सुरुवात करतात. हे कुठले प्रोटीन्स आहेत? तर व्हायपेरिन, पेथेरिन, RNA नंतर इंटरफेरॉन काय करतं की इट शट्स डाऊन प्रोटीन सिंथेसिस. हे का करतं? कारण व्हायरसला काय हवंय की तुमच्या पेशीचा कंट्रोल घेऊन व्हायरस स्वतःचे प्रोटीन्स तयार करायला प्रयत्न करणार आहे. सो इंटरफेरॉन विल शट डाऊन प्रोटीन सिंथेसिस टू प्रिव्हेंट द मल्टिप्लिकेशन ऑफ द व्हायरस. आणि त्याच इंटरफेरॉननी टी सेल्स आणि नॅचरल किलर सेल्सला सिग्नल जातो. तर मगाशी मी म्हणल्याप्रमाणे आपल्या पेशी या सामुराई वॉरियर्स किंवा सामुराई जपानीज योद्धे कसे असतात की लढाईमध्ये हरले ते शरणागती पत्करत नाही, ते सुइसाइड करतात. तसं आपल्या पेशी जर व्हायरसला रोखू नाही शकल्या तर व्हायरसचं गुलाम होण्यापेक्षा त्यांच्या पेशीच्या आतमध्ये कॅस्पेज नावाची एक एन्झाईम सिस्टीम आहे. तर कॅस्पेज सिस्टीम ऍक्टिव्हेट झाली तर दॅट सेल विल कमिट सुइसाइड और सेल डेथ. मगाशी आपण म्हणलं की सेल्स इनेट इम्युन सिस्टीम मध्ये मॅक्रोफाजेस, न्यूट्रोफिल्स हे ह्या पेशी आहेत. तर आपल्याला कदाचित कमी माहिती असलेली एक पेशी म्हणजे नॅचरल किलर सेल्स. या नॅचरल किलर सेल्स काय करतात की आता व्हायरसने जर कुठल्या पेशीमध्ये एंट्री घेतली असेल तर त्या इन्फेक्टेड पेशी नष्ट करणं हे काम त्या नॅचरल किलर सेल्स असतात. ते कशा पेशी नष्ट केल्या जातात? They punch hole in the cell by using this system. Perforin नावाची एन्झाईम सिस्टीम आहे. त्यांनी त्या इन्फेक्टेड पेशीला भूक पाडून आतमध्ये ग्रॅन्झाईम बी नावाचा एन्झाईम इंजेक्ट करतात. And that is a suicide enzyme which kills the cell. आणि अजून एक सिस्टीम म्हणजे प्रत्येक सेलच्या टार्गेट वरती रिसेप्टर वरती एक FAS रिसेप्टर असते. त्याला अटॅच झालं की सेल डेथ हे इंड्यूस होतं त्या सेलमध्ये. आपण म्हटलं की डेंड्रिटिक सेल काय काम करतं तर व्हायरसला उचलून घेतं, त्याचे तुकडे करतं, आपल्या सेल सरफेसवर डिस्प्ले करतं आणि लिम्फ नोड मध्ये जाऊन टी सेल्सना सिग्नल करतं. म्हणून मी त्या सेलला एक सुपर स्पाय म्हणतो. ते डेंड्रिटिक सेल असं काम करतं. इट इज अ फॅगोसाइट. फॅगोसाइट म्हणजे इट विल ईट द मायक्रोब और व्हायरस अँड डिस्प्ले द व्हायरस ऑन इट्स सरफेस, गो टू द लिम्फ नोड, ऍक्टिव्हेट द हेल्पर टी सेल and the helper T cell will do various functions जे आपण एका स्लाइड मध्ये बघूया. आता जस्ट एक फरक सांगतो. ह्या डेंड्रिटिक सेलनी काय केलंय, व्हायरसला फॅगोसाइट करून डायजेस्ट केलेलं आहे. पण सम ऑफ द डेंड्रिटिक सेल्स मे बी अटॅक्ड अँड इन्फेक्टेड बाय द व्हायरस. तर त्यावेळेला काय होतं की ते दोज डेंड्रिटिक सेल्स आर विक्टिम्स, नॉट दे आर नॉट एबल टू किल द व्हायरस. सो ते जर डेंड्रिटिक सेल लिम्फ नोड मध्ये गेले तर त्यांना पाहून हेल्पर टी सेल्स ऍक्टिव्हेट होत नाही, त्यांना पाहून किलर टी सेल्स ऍक्टिव्हेट होतात. जर किलर टी सेल ऍक्टिव्हेट झालं तर काय करतं, ते व्हायरस इन्फेक्टेड सेलला मारून टाकतं. आणि ते मारण्याचे मेकॅनिझम म्हणजे मगाशी आपण बघितलं फास्ट रिसेप्टर आणि परफोरिन सिस्टम. हेल्पर टी सेल एकदा ऍक्टिव्हेट झालं की काय करतं, हेल्पर टी सेल इज लाईक अ फॅक्टरी ऑफ सायटोकाइन्स. तर ते सगळ्या पेशींना हेल्प करतात. खाली हे व्हायरस आलेला आहे, काळा ठिपका म्हणजे व्हायरस आहे. त्या डेंड्रिटिक सेलनी तो उचलला, हेल्पर टी सेलला प्रेझेंट केला. आता हेल्पर टी सेल सगळ्यांना मदत करतं. किलर टी सेलला मदत करतं, बी सेल्सला मदत करतं. मदत म्हणजे काय करतं, ते सिक्रेट सायटोकाइन्स विच ऍक्टिव्हेट व्हेरियस अदर सेल्स. So helper T cell will not kill a single virus. स्वतः एकालाही मारत नाही, पण त्यांनी रिलीज केलेल्या सायटोकाइन्स ज्या आहेत त्या इतर सेल्सना ऍक्टिव्हेट करून डिस्ट्रॉय करतात व्हायरसला. आता आपण बी सेल्स आणि अँटीबॉडीज बद्दल बरंच वाचलेलं असेल, आपण बोलतो त्याच्याबद्दल. तर कदाचित तुम्हाला माहित नसेल की आता जे जगात जेवढे जंतू आहेत किंवा ते म्युटेशन होऊन जे नवीन तयार होणार आहेत किंवा कोणी आर्टिफिशियल व्हायरस जरी तयार केला त्या सगळ्यांना मारू शकेल अशा अँटीबॉडीज आपल्या प्रत्येकाच्या शरीरात ऑलरेडी आहेत. जरी आपला त्यांच्याशी संपर्क आलेला नाही तरी सुद्धा. आता कुठे आहेत त्या अँटीबॉडी, तर त्या बी सेल्स आणि टी सेल्सच्या सरफेसवर आहेत. तर प्रत्येक बी सेल किंवा प्रत्येक टी सेल हे वेगळ्या प्रकारचे युनिक अँटीबॉडी बनवतं. ओके, आता हे कसं शक्य आहे की आपण कधीच एक्सपोज न झालेल्या व्हायरसच्या विरुद्ध आपल्याकडे अँटीबॉडीज कशा आहेत? त्याचं कारण असं की व्हायरस किंवा बॅक्टेरियाच्या सरफेसवर काय असतं, अमायनो ऍसिड्स, पेप्टाइड्स, लायकोपॉलिसॅकराइड्स म्हणजे ऑर्गॅनिक मॉलिक्युल्स असतात. तर असे त्याचे परम्युटेशन कॉम्बिनेशन असून किती असू शकते, तर मॅक्सिमम 100 मिलियन्स, म्हणजे 1 बिलियन म्हणजे 10 लाख, ओके, तसे 100 मिलियन्स मध्ये 100 कोटी, तर तेवढ्या त्याच्या कितीतरी पण बी सेल्स आपल्याकडे ऑलरेडी आहेत. तर बी सेल्स आणि टी सेल्स हे सुपर स्पेशालिस्ट असतात. म्हणजे काय, आता समजा एखादा सुपर स्पेशालिस्ट म्हणजे समजा न्यूरोलॉजिस्ट आहे, तो फक्त एपिलेप्सी ट्रीट करतो, तो कॅज्युअलिटी मध्ये आला हॉस्पिटलच्या आणि तिथे एखादा पेशंटला हार्ट अटॅक केलाय, तो गास्पिंग होतोय, तर तो तिकडे मदत करणार नाही, तो म्हणजे माझी केस नाही. तसं प्रत्येक बी सेल किंवा टी सेल हे एकाच विशिष्ट व्हायरस किंवा मायक्रोबला ओळखू शकतो. शरीरात अटॅक झाला तर फक्त तोच बी सेल हा तिथे काम करू शकतो. तर असे आपल्याला 100 मिलियन डिफरंट सिक्वेन्सेस रिकॉग्नाइज करायला हवेत ना, तर आपल्याकडे भरपूर आहेत. आपल्याकडे 3 बिलियन बी सेल्स आहेत, म्हणजे प्रत्येक कुठल्याही पॉसिबल व्हायरसला मारू शकतील असे 30 बी सेल्स आपल्याकडे आहेत आणि असे 300 टी सेल्स आपल्याकडे आहेत. फक्त सो नवीन व्हायरस आला की प्रॉब्लेम हा नाहीये की त्याच्यावरून अँटीबॉडी कशी बनवायची, नाही, अँटीबॉडी आहेत. प्रॉब्लेम असा आहे की आपल्या 300 बी सेल्स मधला तो बी सेल त्या अँटीजनशी रिॲक्ट व्हायला पाहिजे, म्हणजे तो स्टिम्युलेट होईल आणि अँटीबॉडीज बनवायला सुरुवात होईल. सो इट्स अ प्रॉब्लेम वर्स दॅन फाइंडिंग अ नीडल इन अ हेस्टॅक. एवढ्या बिलियन्स ऑफ बी सेल्स मधला तो बी सेल, तर ते भेटवण्याचं काम लिम्फ नोड्स मध्ये होतं. अँटीबॉडीज असे असतात, त्याची स्ट्रक्चर आपल्याला मिळते. तर हे पहिल्या स्लाइड मध्ये मी कव्हर केल्याचं आय एम जस्ट रनिंग थ्रू द मटेरियल नाव. तर बी सेल्स हे लिम्फ नोड मध्ये जाऊन त्या अँटीजनला भेटतात आणि मल्टिप्लाय करतात. एकदा बी सेल ऍक्टिव्हेट झालं की काय करतं, की दर 6 तासाला एकाचे 2, 2चे 4, 4चे 8 असे मल्टिप्लाय करायला सुरुवात करतात. काही बी सेल्स कुठे जातात, बोन मॅरो मध्ये किंवा स्प्लीन मध्ये, आणि एका सेकंदाला 2000 या स्पीडने अँटीबॉडीज बनवायला सुरुवात करतात. काही बी सेल्स हे आणखी स्पेशलाइज होऊन जास्त स्पेशलाइज अँटीबॉडीज बनवायला लागतात आणि क्लास स्विच. आपल्याला माहिती आहे की पहिल्यांदा IgM अँटीबॉडीज तयार होतात आणि एक 5-7 दिवसात किंवा 8 दिवसानंतर त्याचा IgG किंवा IgA या जास्त स्पेशलाइज अँटीबॉडीज तयार व्हायला सुरुवात होते. आता इम्युन सिस्टीम जर ओव्हर ऍक्टिव्ह झाली तर काय होतं आपल्याला माहिती आहे. लंग्स मध्ये जर ओव्हर ऍक्टिव्ह झाली तर लंग्स गेट डॅमेज, आणि इनफॅक्ट हायपर ऍक्टिव्ह इम्युन सिस्टीम मुळे जास्त माणसं मरतात. तर ते इम्युन सिस्टीम स्विच ऑफ पण करायला पाहिजे. सो अँटीजेन एकदा कमी व्हायला लागलं, व्हायरसचं प्रमाण कमी झालं की आपोआप तो स्टिम्युलस कमी होतो आणि इम्युन सिस्टीम स्विच ऑफ होते. पण ऍक्टिव्हली, आणि प्रत्येक पेशीचा एक लिमिटेड लाईफ स्पॅन असतं, त्याच्यामुळे पण इम्युन सिस्टीम स्विच ऑफ होतं. पण स्पेशलाइज काही सायटोकाइन्स आहेत, म्हणजे इंटरलेक्टिन 10, TGF बीटा, हे इम्युन सिस्टीम सप्रेस करायचं काम करतात. या आणि ऍक्टिव्हेट स्विच ऑफ करायचे अजूनही पॉइंट्स आहेत, ते मी आता घेत नाही. आणि जस्ट समरी स्लाइड घेऊन घेतो की शेवटी बी सेल ऍक्टिव्हेट झाल्यावर काही बी सेल्स हे प्लाझ्मा सेल्स बनतात, म्हणजे अँटीबॉडीज तयार करतात. काही लॉंग टर्म मेमरी सेल्स बनतात, म्हणजे पुन्हा जर इन्फेक्शन झालं तर या सगळ्या सिस्टीम मधनं न जाता पटकन आपला अँटीबॉडी रिस्पॉन्स तयार होतो. तसंच काही टी सेल्स हे लॉंग टर्म इफेक्टर मेमरी टी सेल्स म्हणून टी सेलची मेमरी ही 10-10, 20-20 वर्ष सुद्धा चालू शकते. त्याच्यामुळे जर सेकंड इन्फेक्शन झालं तर आपल्याला कधी कधी कळत पण नाही की दुसरं इन्फेक्शन झालंय, कारण आपल्या टी सेल्स अँड बी सेल्स आर मच मोर इन नंबर, इझियर टू ऍक्टिव्हेट, आणि हायली स्पेसिफिक अँटीबॉडीज आर मेड द नेक्स्ट. थँक्यू.
Request Dr. Neera Bhave to come on stage. I request Dr. Datta and Dr. Andre to felicitate them. Now I request Dr. Harshal Chaudhary to please come on stage. And for the next presentation, I request Nehal Mudha to be ready.
Good evening, everyone. Dr. Harshil Chaudhary, SMBT.
I request Dr. Ram Naik to please chair the session. Ram Naik.
Good evening, everyone. I'm Dr. Harshil Chaudhary. I'm a consultant neurosurgeon at SMBT Hospital, Nashik. I would like to thank organizing committee to give me a chance to speak in front of you. Today, I will be talking about multimodalities used in neurosurgery. I would not like to go in much of technical details, but yes, we all are open to discussion for that. But what all I will be discussing would be few techniques of MRI. Then what is intraoperative neuromonitoring, improved optics, what does it mean, how it is helping us. Then intraoperative ultrasound, immunofluorescence, neuronavigation, and ultrasonic aspirator lastly. I think ultrasonic aspirator most of surgeons are aware of. So, and I will also be touching on why, where, when, how do we use those things. MRI एक feature आहे diffusion tensor imaging. It gives us a pretty good idea about white fiber tracks. आणि विज्युअल्स तर आपण बघतोच आहोत की कॅची आहे त्यासोबत ते इन्फॉर्मेटिव्ह असतात की लिजन नेमकी कुठे आहे आणि व्हाईट फायबर ट्रॅकच्या किती जवळ आहे ते आपल्याला दिसू शकतं त्याच्यामध्ये. As we can see here, sorry for that. Yes, as you can see here, the first section you can see there is a enhancing mass lesion, heterogeneous, probably high grade lesion, आणि बाकीचे 2-3 जे आहेत बॉक्सेस त्याच्यामध्ये आपल्याला त्याची अरेंजमेंट दिसते आहे की व्हाईट फायबर कसे इंटरस्पर्स्ड आहे त्याच्या भोवती आणि मला नेमकं काय वाचवायचं आहे आणि कोणत्या एरियामध्ये गेल्यावरती मला नेमकं काय दिसणार आहे. ऑब्विसली हे ज्या काळामध्ये नव्हतं त्या काळामध्ये पेशंट वाचायचे इंटॅक्टही राहायचे, बट अगेन वी गेट अ बिट ऑफ सेफ्टी नेट नाव. नेक्स्ट इज इंट्राऑपरेटिव्ह न्यूरोमॉनिटरिंग. तर न्यूरोमॉनिटरिंग म्हणजे I would like to check and test functions, basic neurological functions. Basic याच्याकरता म्हणतो आहे की जे ऍडव्हान्स मशिनरी किंवा जे ऍडव्हान्स स्टिम्युलेटर्स लागतात, जे मॉनिटरिंग सिस्टम लागतात, त्या सगळीकडेच भेटतील अशा काही भाग नसतो. आपलं सेटअपचा कॉस्ट वाढते आणि मग उगाच असं होतं की रिकव्हरी नाही म्हणून आपण चालूच नाही केलं, असं म्हणजे फायनान्शियल जे कन्स्ट्रेंट्स असतात त्याच्याकरता ते ओव्हरकम करायचं असेल तर मे बी क्लिनिकली वी शुड बी साऊंड इनफ टू एक्झामिन पेशंट प्री ऑपरेटिव्हली अँड यूज ओनली टार्गेटेड सेट ऑफ टेस्ट. त्याच्यामध्ये 2 प्रकार राहतात. एक आहे की जीए मध्ये आपण अॅनेस्थेशियाच्या अंडर पण करू शकतो, त्याच्याकरता थोडंसं मॉनिटरिंग सिस्टमची गरज जास्त राहते. एक इलेक्ट्रोफिजिओलॉजिस्ट पण लागतो सोबत आपल्याला ओटीच्या वेळेस. पण जेव्हा पेशंट अवेक असतो, जे आय एम ट्राइंग टू प्रोपोगेट दॅट ऍटलिस्ट इन नॉर्थ ऑफ महाराष्ट्र, कारण अवेक क्रेनियोटोमीज कॅन मेक अ हेल लॉट ऑफ डिफरन्स इन क्वालिटी ऑफ लाईफ ऑफ एनी ऑफ द पेशंट्स, बी इट अफोर्डिंग और नॉन अफोर्डिंग. कारण त्याच्यामध्ये बेसिक इन्व्हेस्टमेंटची जी कॉस्ट आहे ती फार कमी होऊन जाते आणि फंक्शनल आउटकम खूप चांगले राहतात त्याच्यामध्ये. सो दिस वुड बी सॉर्ट ऑफ न्यूरोमॉनिटरिंग सेटअप इन OT. So you can see our neurophysiologist is sitting in one corner, OT is going on somewhere else. He has connected all his wires to patient, all the electrodes are connected, and those are throwing all the impulses which is able to monitor on table. So the right lower corner, what you can see is the first box where you can see all those numbering. It is a bipolar stimulator. ते bipolar stimulator आहे. आम्ही पेशंटला स्टिम्युलेट करत जातो. जनरली bipolar stimulator अवेक मध्ये वापरतात
but under GA also, if neurophysiologist is good, he can catch up on things आणि तो आम्हाला सांगू शकतो की कोणता एरिया मोटर आहे, कोणता एरिया सेन्सरी आहे. दिस इज अ प्रोसेस ऑफ मॅपिंग. आणि जेव्हा एकदा मॅपिंग झाली आयदर बायपोलर स्टिम्युलेटर किंवा युनिपोलर स्टिम्युलेटरने, की मग शेजारी राईट साईडला एक्स्ट्रीम राईट कॉर्नरला जे आहे दॅट इज मोनोपोलर इलेक्ट्रोड. त्याच्यामधले जे आपल्याला डिस्क दिसत आहेत, चिप दिसत आहेत, दोज आर ऑल स्टिम्युलेटर्स. आणि मग आम्ही त्यांना सांगत असतो वी हॅव मॅप्ड इट, आम्हाला आता माहिती आहे कोणती चिप कोणत्या एरियावरती आहे. तर आम्ही मग इलेक्ट्रोफिजिओलॉजिस्टला सांगतो की अभि आता इन डेप्थ वी आर नियर हँड एरिया न, तो मग हँड एरिया स्टिम्युलेट करून दाखवेल आम्हाला की येस अवर स्टिम्युलाय आर गोइंग वेल डाऊन, सो नो नीड टू वरी, आय कॅन गो अहेड विथ माय एक्सिजन. आता हा जो आहे हा अवेकचा सेटअप ओटीच्या आतले फोटो दाखवतोय. तो लेफ्ट हँड कॉर्नर आहे, that is patient is seen, anesthetist can see the patient completely all the time. आणि आम्हाला जे मॉनिटर करायचं आहे be it questions for higher motor functions or simple motor functions, तेवढंच नाही तर फक्त सेन्सरी पेशंटला टिंगलिंग नमनेस जरी आला तरी पेशंट सांगू शकतं. आणि अॅनेस्थेटिस्ट किंवा म्हणजे आता आपल्या कॉम्प्रोमाइज सेटअप मध्ये वी प्रिफर अॅनेस्थेटिस्ट लुकिंग बिहाइंड पेशंट, बट इन मेनी एस्टॅब्लिश सेटअप्स तिकडे त्यांच्याकडे एक स्पेशल न्यूरोफिजिओलॉजिस्ट किंवा मॉनिटरिंग करता एक स्पेशल ट्रेंड टेक्निशियन असतो. बट इट्स ओके, दॅट शुड नॉट बी अ हर्डल फॉर स्टार्टिंग और फॉर डुइंग एनी अवेक न्यूरोसर्जरी. आता आपण जो इम्प्रूव्ड ऑप्टिक्स कडे मायक्रोस्कोपने तसं बघायला गेलं तर जसं पावसकर सरांनी इन्सुलिनचं इंट्रोडक्शन दिलं स्कॉर्पियन बाईट करता, जो डिफरन्स झाला प्री and post SIRS paper, that same difference has occurred with microscope. ज्या केसेस जे पॅथॉलॉजी अगोदर पेशंटला टर्मिनल इलनेस वाटायचे किंवा अगोदर डॉक्टरांनाही वाटायचं की यू डोंट हॅव होप, तुम्हाला आता 6 महिने आहेत, तुम्हाला आता 8च महिने उरले आहेत, यू लिव्ह युअर लाईफ, असे वाले वाक्य आता कमी झाले न्यूरोसर्जनकडनं यायचे. मायक्रोस्कोपने खूप जास्त डिफरन्स केलेला आहे, कारण आहे इम्प्रूव्ड व्हिजन. ज्या कोणत्या मायन्यूट नर्व असतात, मायन्यूट परफोरेटर वेसल्स असतात, त्याही आता सेव्ह करता येत आहेत थँक्स टू मायक्रोस्कोप अँड डॉक्टर यासरगिल हू हॅज मेड इट रॅम्पंट. आता एक पायरी पुढे गेले एक्झोस्कोप. ऑब्विसली या गोष्टी बघायला किंवा वेस्टर्न कंट्रीज मध्ये ऐकायला बरोबर वाटतात, आपल्याकडे यायला खूप जास्त उशीर लागेल, पण येस इट इज देअर. कम्फर्ट लेवल सर्जनचा खूप चांगला होऊन जातो विदाउट कॉम्प्रोमाइजिंग ऑन विजन. एवढंच आहे की मायक्रोस्कोप अर्गोनॉमिकली थोडासा सर्वायकल स्पॉन्डायलोसिस न्यूरोसर्जन्स मध्ये वाढतो, एक्झोस्कोपने तेवढा एक कमी करता येऊ शकतो. Then again endoscopy, I would not like to discuss much of it because most of us are aware endoscopy म्हणजे minimal invasive surgery चे you just have to use this toy and it can create miracles. तुम्ही कुठे कसे वापरतात त्याच्यावर ते अवलंबून आहे. How you master it is just a matter of time. Now coming to neuronavigation, this is something which engineers have given us. आपण generally 4-wheeler मध्ये जे ट्रॅव्हल करताना बघितलं असेल व्हील बॅलन्सिंग अँड अलाइनमेंट, 3-dimensional व्हील बॅलन्सिंग अँड अलाइनमेंट म्हणतो आपण. तर इट इज समथिंग सिमिलर. एक फ्रेम असते, रेफरन्स फ्रेम लावलेली असते पेशंटला. आधी तर सगळ्यात पहिले आपण इमेजेस एक्वायर करतो, ज्या तुमच्याकडे जे न्यूरोनॅव्हिगेशन सिस्टम आहे त्याच्याशी कम्पॅटेबल इमेजेसचा फॉर्मॅट राहतो. MRIचा, सिटी स्कॅनचा, थिंकर्स असतात, थोडंसं टिल्ट नाही पाहिजे, काही बेसिक असतं जे प्रत्येक कंपनी देते तुम्हाला स्पेसिफिकेशन. तो एकदा डेटा आपण फीड केला न्यूरो नॅव्हिगेशनच्या सिस्टम मध्ये की मग ओटीच्या टेबलवरती आपल्याला पेशंटला रजिस्टर करावं लागतं. जे पेशंट स्पेस आपण इकडे बघतो आहोत दॅट इज द सेम पेशंट रजिस्ट्रेशन असतंय. आणि मग एकदा ते रजिस्ट्रेशन झालं मशीन विल डू द रेस्ट ऑफ द वर्क. तुम्ही त्याच्यामध्ये सॉफ्ट डेटा दिलेला आहे, हार्ड डेटा पण दिला आहे. मशीन विल इंटिग्रेट द स्पेस आणि त्याच्यानंतर जेव्हाही त्या स्पेसमध्ये मार्करवाले पॉइंटर तुम्ही फिरवतात तर मशीन तुम्हाला सांगेल की तुमचा पॉइंटर रिलेटिव्ह टू दॅट फ्रेम कुठे असणार आहे. तर दिस इज सिम्पल थिंग. लेफ्ट साईडला तुम्ही बघाल तर पेशंटचा चेहरा आहे. पेशंटचे जे माझ्या हातामध्ये आता प्रोब दिसतोय छोटासा, दॅट इज कॅलिब्रेट, प्री कॅलिब्रेटेड असतो. आणि ते पेशंट रजिस्ट्री करता वापरलं जातं. त्याची लेंथ, त्याचा डेप्थ आणि त्याचा थिकनेस या सगळ्या गोष्टी आधीच मशीनमध्ये फीड असतात. आणि पेशंटच्या मागच्या बाजूला जे तुम्हाला राईट साईडला दिसेल ती रेफरन्स फ्रेम आहे. वन्स दॅट इज फिक्स्ड आणि रजिस्ट्री झाली आहे, जर ती फ्रेमचं पोझिशन हल्ली तर आमची रजिस्ट्री चुकते आणि आम्हाला परत रजिस्ट्री करावी लागणार. सो इट इज दॅट सिम्पल. एकदम मेकॅनिकल आहे, पण ऑब्व्हियसली टेक्निकल गोष्टी त्याच्यात इतक्या इन्व्हॉल्ड असतात की आपण ह्या गोष्टी विचार नसतो करू शकतो. नाव दिस इज आफ्टर रजिस्ट्री. रजिस्ट्रेशनच्या नंतर लेफ्ट अपर कॉर्नर मध्ये जे आहे पॉइंटर हॅज बीन प्लेस्ड ऑन स्कल. मी स्क्रीनवरती पॉइंटर ठेवला जस्ट टू सी वेदर आय एम राईट ऑर रॉंग. आणि सरफेस मार्किंग वरतून जे आम्हाला दिसलं होतं दॅट वॉज परफेक्ट. जो ट्यूमर आहे हे जे सगळं चित्र दिसत आहे ॲनिमेटेड जे दिसत आहे दॅट वॉज प्री प्लॅन्ड. ते सगळं DTI फायबर ट्रॅक्टोग्राफी केली आणि ट्यूमर पण आपण प्री ऑपरेटिव्हली मार्क केला किंवा आपल्याला या सगळ्या गोष्टी इंट्रा ऑपरेटिव्हली बघायला सोयीस्कर राहत आहे. तर मार्किंगच्या नॅव्हिगेशनच्या हिशोबाने मार्किंग केलेली आहे. स्किन फ्लॅप मार्क झाल्यावरती पेशंट पेन ड्रेप होतो. अँड आय एम सॉरी इट वुड बी अ बिट ॲब्रप्ट. मी कट करतोय कारण या सगळ्या गोष्टी एकत्र मी परत शेवटच्या एका व्हिडिओमध्ये दाखवणार आहे. म्हणजे इट वुड नॉट बी जस्ट अ थिओरिटिकल टॉपिक. Immunofluorescence is again one modality which we have picked up from pathologists. फक्त processed tissue वरती immunofluorescence microscopy करण्यापेक्षा we have started doing it in live patients now. Live OT table वरती पण आपण करायला लागलोय. सो इंट्राऑपरेटिव्ह UAC ही एक खूप व्हर्सेटाईल आणि खूप जास्त कॉस्ट इफेक्टिव्ह टूल आहे. आय थिंक it is high time now most of the clinicians should start using it in our clinical practice, be it OPD, be it IPD or be it surgery. कॅज्युअलिटी मध्ये पण UAC चा खूप जास्त बेनिफिट होऊ शकतो आपल्याला. म्हणजे बऱ्याचशा गोष्टी आहेत ज्या आपल्याला एक्सरे ला पाठवा किंवा CT ला पाठवा त्याच्या अगोदरच प्रूफ टाकला, कुठे बघून घेतलं. बी ट्रॉमा मध्ये फास्ट आपण करू शकतो. नॉट अ रॉकेट सायन्स ॲट ऑल. जस्ट रिप्रेझेंटेशन मी दाखवलंय. जो MRI आपण बघतो anterior is on left side. I have deliberately tilted it so that we know how we are going to see image of tumor which is seen on MRI. हा जो MRI आहे सरफेसिंग ट्यूमर आहे पॅराइटल इमिनन्स वरती. तिकडे सरफेस प्रोब लावलेला आहे. द सेम ट्यूमर कॅन बी सीन, इट कॅन बी कोरिलेटेड. सगळी अनाटॉमी दिसते तुम्हाला. खालती व्हेंट्रिकल दिसते, कोरोइड प्लेक्सस दिसते. द मिडल वन इज बिफोर स्टार्टिंग सर्जरी. ड्युरा ओपन करायच्या अगोदर तो ट्यूमर आपण व्हिज्युअलाइज केलाय. तो याच्याकरता की नॉट फॉर लोकलायझेशन सरफेसिंग ट्यूमरला अजिबात गरज नाही पडत. बट इट इज फॉर बेसलाईन. आपल्याला बेसलाईन कळतंय. ओके, सो बेसलाईन UAC राईट आणि राईट एक्स्ट्रीम इज पोस्ट एक्सिजन ऑफ ट्यूमर. cavity can be seen, slight of edema can be seen. So this is the integration of ultrasonography in neuronavigation. Again, cost effectivity थोडीशी डामाडोल होते, पण plain UAC is also equally beneficial. If you permit, I may extend for a few minutes. May I extend for maybe 2 or 3 minutes more? Is it possible? Okay, thank you. I'll just try to solve this issue if it is possible. Hello, really sorry for this. Just to demonstrate ज्याही काही मल्टीमोडॅलिटीज मी आता दाखवल्या होत्या त्या सगळ्या एकत्रितरित्या कशा काम करू शकतात किंवा कशा वापरू शकतो आपण त्याच्याच करताय. बाकी it's not possible, maybe I'll have to skip that part. But the crux of the story is that फक्त मी टेक्नॉलॉजीवरती अवलंबून नाही राहू शकणार कोणत्याही सर्जरी करता, बिकॉज at the end a fool with a tool is always going to be a fool no matter what you do in his hands. So as surgeons आम्ही निग्लेक्ट करायचा प्रयत्न करतो किंवा आमची ती टेंडन्सी होऊन जाते की क्लिनिकल पेशंट बघायचाच नाहीये किंवा प्री ऑपरेटिव्हली काय असेस करायचं, एमआरआय हातात आला की होऊन जाईल सगळे काम, एमआरआय वाले सांगतील रेडिओलॉजिस्ट रिपोर्ट करून देतील आणि आपण ऑपरेट करून टाकू. सो वी शुड कम आउट ऑफ दॅट टेंडन्सी, दॅट इज व्हेरी व्हेरी इम्पॉर्टंट. आणि जर ते पॉसिबल झालं तर मे बी अवेक सर्जरीचं जे रिलक्टन्स आहे अजून तरी, म्हणजे somehow I don't know why, but people are still finding it difficult to digest that awake surgeries are actually going to be beneficial and easier for doctor and beneficial for patients. Let's hope that things change and that it comes in favor. Okay, yeah, thanks a lot. I'm very sorry that video I could not play.
Thank you, sir.
Thanks a lot.
Now I request Dr. Santosh Kavle to please come on stage and discuss with us legal boundaries of patient management.
So, good evening to all of you. At the outset, let me thank Dr. Ravindra Kutte sir for inviting me here to have an interactive session. Actually, this topic is quite vast, and I'm sure everybody of you must be quite interested in knowing how to face legal complications. Second. So the dignitaries who are sitting in the, I say in the audience because I was introduced to Dr. Himadrao Bavaskar sir, then along with Dr. Kutte sir, the other dignitaries who are sitting, maybe I may not name all of you, but then I'm happy to see all of you here, even at the fag end of the day, with a good number you are sitting here. So I'm thankful to all of you. My topic is legal boundaries of patient management. After practicing as general and orthopedic surgeon for more than 20 years, I was graduated in law, completed LLB, LLM, PhD in law. Now registered for LLD, which I was also not knowing. After PhD, there is one degree called LLD. So I'm registered for that. I will be completing that next year. So due course of time, I got an opportunity to be a member at the State Consumer Commission. मराठी भाषेत सांगायचं झालं तर कंझ्युमरच्या हायकोर्टला न्यायाधीश म्हणून गेली 5 वर्ष बसण्याची संधी मिळाली. And you all are aware that the doctor face the cases in the consumer courts. Another is the criminal cases, probably after the death of a patient on table, when they face the inquiries by the police and when some criminal action is taken against them. So nowadays, due course of time, I'm sure everybody of you now definitely having some kind of worry in the back end of the mind that even if I treat patients successfully, possibly I don't know what the legal outcome is. And it has happened. 1996 was the Consumer Protection Act, which was enacted, which was applied to the medical profession in 1995. After 1995 till today, the number of cases which were filed against doctors increased like anything. And there is a 450% rise in the filing of the cases against doctors. And I'm sure a few of you must have faced the music at consumer courts. And it's very difficult to digest as well as face the consumer court.
Now sitting on this side as a judge, I gathered that experience, and then I definitely can tell you that it's hard to face consumer court or even legal any action. The topic is legal boundaries of patient management. So whether legal boundaries exist, the answer is yes. We all are knowing that clinical outcome is a separate thing and legal outcome is a separate thing. So if legal outcome is not satisfactory, the patients, they definitely are now aware as consumers, file cases against doctors. I'm going to take it very fast, and I wish to have some question answers for say 5 minutes. Just I have tried to define the boundary, but I don't think I need to explain it too much. Whenever you breach a boundary, the action is taken, legal action is taken. Different boundaries are there: professional boundary, legal boundary, clinical boundary, social boundary. As I said, more than 450% growth in filing the cases against doctors. We all know that there is ethical regulation of the medical profession by the Code of Medical Ethics, and the legal regulation. Various acts are there, and due course of time, various cases which were decided by various courts, like consumer courts as well as even the Supreme Court of India, they are the guiding points why any doctor, liability of any doctor is decided. So I'm just keeping a few of general slides. Everything depends on doctor-patient relationship. The doctor who has a sweet tongue probably doesn't face much of the medical legal cases or legal cases. If these boundaries are breached, what patient can do? The patient can file consumer complaint, the patient can file criminal complaint of